Yeah. भाई लैपटॉप फिर मेरे वो की कंप्यूटर था कोई नहीं and I'm going to be, oh my god, it's just about that I have to sit. I was trying to powder my face. Blended actually, not like white. And more there. Anyway, we only be allowed to
Hello.
Hello.
Hello. Can I speak with somebody who's the organizer, committee person?
Ma'am, you are audible, ma'am.
Yes, I just want to check whether my slides are showing or not. Can I do
Okay,
that?
ma'am. Okay, ma'am.
Shall I try once?
Ma'am, I can't see your slides yet, ma'am.
No, no, you can't see because I have not shared them. I'm just
Okay,
asking
ma'am.
you whether I can share or not. So I presume you are telling me I can share, isn't it?
Ma'am, ma'am, can you use earphones, ma'am?
Can you see my slides?
I can see your slides, ma'am, but ma'am, it's not audible very loudly, ma'am.
I think my audio is fine. I'll just double check again, but I think the audio is fine. I'll get that sorted out. Just check whether the slides you can see or not.
Yes, ma'am, I can see your slides, ma'am.
Okay, fine.
Okay, ma'am. Okay, ma'am. Thank you, ma'am.
I'll just sort out the audio bit. So can you
Okay,
hear me
ma'am.
now? Hello, can you hear me now?
Yes, ma'am, I can hear you, ma'am.
Is the audio quality better?
Yes, ma'am. Yes, ma'am.
Okay, thank you.
Thank you, ma'am. I can hear you, ma'am. I can hear you, ma'am. Yes, ma'am.
Yeah, then it's fine. Then I'm not changing any audio settings. So this much is okay, isn't it? Yeah.
Namaskar. Guru Brahma, Guru Vishnu, Guru Deva Maheshwara, Guru Sakshat Param Brahma, Tasmai Shri Gurudev Namaha. The Sanskrit saying Na Kanchit Shashvatam literally translates to nothing is permanent. What can be truer during these trying times of COVID 19? Yet, despite all the agony, pain, and loss that the world has suffered, we remain undeterred in our quest for knowledge and learning. Good morning, one and all. I welcome you all to the 36th National ISOPARB Conference organized by the Bhubaneswar chapter of ISOPARB, hosted by IMS and Some Hospital. Indian Society of Perinatology and Reproductive Biology was founded with the thought that the mother and child are the very essence of our society. With a handful of members, this society was founded in the city of Patna under the able guidance of Dr. Kamla Achari, the founding president of ISOPAR. We have come a long way indeed. Now, seeking the blessings of the Almighty, we proceed to our inauguration ceremony. Now, we will listen to a small speech by our beloved Dean and Vice President of ISOPAB, Professor Dr. Gangadhar Sahu sir.
And one sub-chapter of ISOPAR. So we are going to organize the 36th National ISOPAR Conference 2021. And in the pre-conference workshop, we have got population induction and genetics. In one meeting in the surgery and fetal medicine. So I hope the delegates and all the members who are online will enjoy this workshop. Earlier we are planning a real workshop in Bhubaneswar where the blessings of Lord Jagannath and Baba Lingaraj will have helped us to interact with you and you have got the blessings of Lord Jagannath and Baba Lingaraj by going to Puri and Bhubaneswar itself. So because of the pandemic, now this is a new chapter we have opened and it will be written in history of ISOPAR that Bhubaneswar chapter has started the first online national conference. Wish you all the best, my dear friends and delegates, and I am very much thankful to my organizing friends, the organizers who have taken a lot of troubles to transform from the real conference to a virtual conference. I wish my friends who are working day and night to make it successful to get the result that they will come up with flying colors. Thank you very much. Namaskar.
Thank you, Dean Sir, for your words of encouragement. Now, without further ado, we begin this 3-day academic feast filled with orations, sessions, speeches by the very best in our field of obstetrics and gynecology. Now, we will start with our workshops. Our first talk of today is by Dr. Chinmay Rath. It is an honor for me, ma'am, to introduce you. Chinmay Rath, ma'am, is the lead consultant.
I think let it be. I think that's a wrong CV that I have. I don't work for Rainbow Hospitals. I work for, that's an old CV. So it's okay. It doesn't matter. I don't think we need to get the introduction. Let's start with the session. We're already running late. Yeah? Can you please stop that sharing? I will just share my screen and we can start the session.
Okay, ma'am.
Can you see my slides?
Not yet, ma'am. It's visible, ma'am. Thank you.
Okay, thank you. So I am Dr. Chinmay Rath. I work in Hyderabad in a hospital called Resolution Fetal Medicine Center, and I also work for Yashoda Hospital, Secunderabad. And I have been closely associated with ISOPARB for the last many years. It is really an honor to be here on this platform in this fetal medicine workshop, pre-congress workshop for the National ISOPARB conference. So the topic that I am going to address is the first trimester scan and its implications. Now, all of us know that the first trimester scan is a very important part of pregnancy, and the scan that is done in the first trimester, often called the 11 to 14 week scan or the nuchal translucency scan. Now, what exactly is going on in pregnancy at that point, if we have a little insight into it, then we can understand why this scan has so much importance and why we are talking about the implications of this scan as the first talk of the day in terms of discussing the details of fetal medicine practice. So at this time, in the first trimester, after 14 weeks, a little baby is growing inside the mother's womb, taking shapes and organs and starting to become identifiable. So if you see these pictures, all those of you who do scans or look at pictures of scans, you can see the pictures of various organs of the baby, the head, the face. It's a complete longitudinal section, sagittal section of the baby at that stage, eyes, legs, hands, heart, stomach, abdominal wall cord insertion, and the urinary bladder, the spine, and the kidney. So you see, even at 11 to 14 weeks, there is so much of anatomy that can be seen. So a comprehensive head-to-toe fetal anomaly scan can be performed in the first trimester. That is one of the first important things that we can do in the first trimester scan. The other thing what's going on at that point is that the uteroplacental circulation is getting set. So we know that in the normal uterus, you have the uterine artery which supplies blood to the uterus, and this uterine artery ultimately divides into arcuate, radial, basal, spiral vessels. The spiral vessels are the end arteries there, and the spiral arterioles are affected by the trophoblastic invasion of the placenta. So when the uterine artery supplies blood, there is a certain resistance, but when the spiral arterioles are subject to that trophoblastic invasion, the resistance in that plane goes down and the uterine artery Doppler characteristics change. If they don't change, they indicate impaired placentation, and therefore an assessment for placental function and screening for placental dysfunction can be done at the time of the first trimester scan. What else is going on? The uterus is now sort of increasing in size. The cavity is increasing in size, the muscles are getting stretched, and the pressure on the lower uterine segment or the cervix is now starting to become defined. Suppose the cervix is incompetent or it is very short, then it will be an indication that probably this uterus may not take the stress of further distension, and the pregnancy may be at risk of preterm birth. We know that preterm birth is one of the leading causes of neonatal morbidity and mortality, and therefore screening for a possible preterm birth by looking at the cervical characteristics in the first trimester would also do a lot of good to pregnancy. So there are many things that we can do in the first trimester scan, but to achieve a very widespread goal, we have to start properly. We have to have a systematic plan in mind. So this 11 to 14 weeks becomes a window of opportunity, and it's a very important window for optimizing pregnancy care in the first trimester of pregnancy. It's an important landmark for fetal evaluation, and a very reasonable time to screen for maternal problems in pregnancy forms the base of the pyramid of modern antenatal care. Now, this is not new. I mean, Professor Kypros Nicolaides, and happy birthday to him, it's his birthday today. And he introduced this concept of inverting the pyramid of antenatal care almost a decade back. And the sense that it made is now percolating into almost every practitioner's realization that if you do a lot of hard work in the first trimester, if you evaluate your pregnant lady and the fetus very thoroughly in the first trimester, your work actually becomes very, I won't say minimal, but it becomes more targeted, focused, and you can actually minimize the unnecessary anxiety that otherwise comes up in the third trimester. So while the traditional antenatal care pyramid started with little work in the first trimester and more clinical interaction in the third trimester, it's now understood that if you just reverse it, you do much more clinical evaluation in the first trimester, you have less and less to do later, and you can actually optimize things by screening for problems and also, devising methods of avoiding those problems. So the first trimester workup becomes the base of the pyramid of antenatal, inverted pyramid of the antenatal care. So what do we do in the first trimester? We assess and analyze issues. In terms of fetal problems, what are we assessing in first trimester? Structural integrity. So if the structure is normal, it's very reassuring for the parents. If there is a structural abnormality and it can be detected in first trimester, then there are obvious advantages. Risk for aneuploidies. There is a separate session going to be done by Suresh sir on aneuploidy screening, but the first trimester scan will be an important part of aneuploidy screening. Dr. Sirisha has raised a hand. Is there anything you want to say, Dr. Sirisha? Okay. Increased NT and its implications in pregnancy, multiple pregnancy issues. And in the mother, the first trimester scan can be used for screening for risk of preeclampsia, preterm birth, and specific maternal concerns. As always, ultrasound has been the magic eye for the perinatologist, and all problems in the fetus have to be first dealt with by an ultrasound assessment, because that is probably the only way you can see a fetus with its, who's vital in utero, and assess its condition. So you always start with a checklist when you want to do things systematically. And when you want to do a head-to-toe assessment, you got to see the fetal head, the neck, the face, and the spine. And what you have to see in these structures have been given to us in the form of guidelines. So I have taken this from the ISOPARB first trimester guidelines, which says that the minimum requirement of evaluation of the fetus in the first trimester scan includes the presence of the cranial bones, the midline forks, the choroid plexus filled ventricles. The neck should have a normal appearance. If you can measure nuchal translucency, that is good. But mind you, just a first trimester scan in assessment need not always include the nuchal translucency. You need to do the nuchal translucency properly if you're trying to do a risk assessment for aneuploidies, definitely. And of course, it's a good practice to include nuchal translucency because it's a marker for many more things other than just the risk for aneuploidy. You can see the eyes with the lens, you can see the nasal bone, you can see the normal profile of mandible, and you can also see intact lips if you look very carefully. But they've been put in the optional group so that you don't feel that stress of definitely having to prove this in the first trimester. But as you will realize, when you start doing a scan, you see less. But when you keep on doing that again and again and again, your remit of evaluation keeps increasing. In the spine, you can see vertebra both in the longitudinal and axial sections, and it is possible to look at the integrity of the skin over that vertebral column so that if there's something obviously protruding out of a spine, you may be able to see at this stage. Now, how much ever I tell you theory, you will always understand when you see something happening practically. And that's what happens here. So this is how the fetal head looks in the first trimester. You have a bony outline there. So cranial bones are present. There is a midline forks dividing the brain into the left and the right sides. And you have this butterfly shape structure in between, which is the appearance of the normal choroid plexus at this stage. Now, just compare this here with this. This is a normal contour of the first trimester fetal head in the longitudinal section of the baby. But this is a problem here because you don't see the vault of the cranium, and therefore you suspect the absence of cranial vault or acrania, or what we call as anencephaly. This midline division of the forks into left and right is so nice and prominent here, but here in this picture, you don't see that midline division. Instead, there is no cleavage here, and there seems to be a problem which we identify as holoprosencephaly. This is a normal contour up there in the central picture there. It's a normal contour of the baby, whereas this video which you see in the lower right corner of the screen, you see something is abnormally protruding out of the fetal head up there. So these are things like encephalocele, which is happening up there in the cranium, and that is obviously an indication of an abnormality in the fetal head. So again, if you keep on looking at things very carefully, a normal fetal head will have a normal contour, but when there are abnormal protrusions out there, you start suspecting abnormalities. And as all of you know, that these kind of abnormalities where either the head is not formed very well, or there are protrusions of the brain in the first trimester, or you don't see the cleavage of the brain, these have very serious implications on the quality of life. Anencephaly is lethal postnatally, and therefore most of these conditions will warrant a discontinuation of the pregnancy. If that decision can be taken as early as the first trimester, it is a huge obstetric benefit for the patient and the obstetrician, because your risks of termination of pregnancy in the first trimester are very minimal. If a anomaly does not need termination but needs further workup and a decision for correction, even then an early suspicion of such an anomaly gives you time to work on it and decide what more tests have to be done in those cases. So this is about fetal head and fetal spine. See, this is the normal contour of the fetal spine, and as you can see what we described in that list, you can have a longitudinal assessment very easily. You can see the vertebral bodies which are nicely calcified, and they show a railroad appearance there. And you have the skin which is the contour of the skin smoothly over the spine. Compared to that, if you see the picture here, the spine is convoluted. It has an abnormal curvature on one side in that longitudinal view. Here, you don't see the spine mineralized at all. It is hypomineralized. And these are again pictures where you are suspicious of the contour of the spine. Then you start suspecting problems, and one of the common problems of the spine in the fetus is new open neural tube defects. Now these are heterogeneous group of malformations which result from the failure of the closure of the normal neural tube. And the origin of this malformation starts around the 4th, 5th week of embryonic development. We know that by day 26 to 28, there is the closure of the neuropores, but the effect of this malformation is only apparent later on. Sometimes it may not be apparent in the first trimester, and therefore you may have to look for indirect signs. If you can see direct signs like, obvious protrusions of things, of abnormal contents from the spine, like this one, you see here, as compared to the video on top and the video below. I don't know whether you're able to see my cursor, but the video on top, you can see that there is a protrusion of contents of the spine outside the fetal body, and that is a classic open neural tube defect there. It's like a lumbosacral meningomyelocele. Whereas here you see a normal spine which is ending in there. You see the lower end of the spine without any protrusions, and the skin on top is intact. So if something is so apparent and you can see it right there in the first trimester, your diagnosis is confirmed, and you can then start discussing plan of management after that. But in many cases, it may not actually start protruding to that extent that it is detectable. And in those cases, a little sign called the intracranial translucency helps us in suspecting neural tube defects. So this intracranial translucency is nothing but the future fourth ventricle, which we see there as a combination of three parallel lines, which is representative of the brainstem, the future fourth ventricle, and the cisterna magna in there. So this future fourth ventricle becomes collapsed if there is a open neural tube defect. So if you don't see an intracranial translucency well, you may start suspecting the possibility of an open neural tube defect, which you may detect later on. What happens is when you see a very good anatomical evaluation in the first trimester, you often call the patient back at 19 weeks. Now that the law might change, we might call at 22, 23 weeks. But suppose you know that we are suspecting a problem, something like an open neural tube defect, which can have huge implications on the planning of the further planning of the pregnancy. We may plan for an early anomaly scan, like around 16 weeks, so that once the ossification of spine is complete, we can give a definitive diagnosis regarding this problem. So then coming to fetal thorax, as you can see here, a normal fetal thorax will be seen in a manner that you see the heart right there in the middle, occupying 1/3 of the thorax, and the lungs almost equal in size, flanking the heart by the two sides. In the heart, you will be able to see the 4 chambers of the heart, and if you just twist your probe, you will be able to make out the outflow tracts. Whereas if you see abnormal structures occupying the heart, or an abnormal shape, occupying the thorax, or an abnormal shape of the heart or the lungs, you start suspecting problems. So in the fetal thorax, in the first trimester, your aim is to see a thorax like this, where there are homogeneous lung echoes on both the sides of a heart, which is occupying around 1/3 of the thorax, with the apex towards the left. And if you don't see that, then you suspect thoracic abnormality. In the heart per se, if you look at it very carefully, you will be able to see the 4 chambers and the outflow tracts. And sometimes you may start suspecting problems when you don't see the cracks very well, and then think, but all of you who are used to doing these scans will understand that yes, we can start looking at fetal cardiac defects in the first trimesters. Those of you who are still going to start the scans tomorrow should not get very disheartened if you can't see the entire cardiac anatomy in the first trimester. Believe me, with practice, you will get better at it. You will start suspecting many things, and there are a lot of cardiac problems which we are now beginning to diagnose in the first trimester, and even taking decisions on them, because the diagnosis is becoming very confident. And this is the layout of the first trimester heart in the 4 chambers. And as in the second trimester, the chamber closest to the spine is left atrium. This is right atrium. So this is right ventricle, and this is the tricuspid valve. So if you can do a pulse wave across the tricuspid valve, you will get the tricuspid valve flow, and look for tricuspid regurgitation. We'll come to that. So sometimes the fetal heart looks good, and sometimes it doesn't look so good in the first trimester, as you can see in all these pictures here. Um, the contour of the 4 chambers is not as clear as it was in the first picture, and the chambers seem to be big. They seem to be going in some other direction, and then that is where you start suspecting cardiac defects in the first trimester. Otherwise, in a normally shaped heart, you can go on there and look at the tricuspid valve, place your pulse wave on the tricuspid valve, and get the tricuspid Doppler. Then coming to fetal abdomen, what we expect to see in the fetal abdomen in the first trimester is the presence of a stomach bubble. The stomach bubble indicates that a good sized stomach bubble indicates that the fetus is swallowing amniotic fluid and it is reaching the stomach bubble. So it somewhat indicates the patency of the upper GI tract, although it is not infallible in the first trimester, because there may be fluid in the stomach because of secretions from the glands, and you may still see a stomach bubble while the baby may be having an esophageal atresia. Unlikely, but it's possible. So it needs serial evaluation. You can't draw the line here, but if you see a good sized stomach bubble emptying and filling on itself, then it definitely rules out esophageal atresia. We cannot rule out tracheoesophageal fistula at this stage, and even later that is a challenge, but that's it. Then you see the abdominal cord insertion at the level of the umbilicus there, and if there are no abnormal protrusions, then that is a normal cord insertion. If you see protrusions like this, then you know there is an anterior abdominal wall defect. Depending on whether there is a cord attached to the apex of the defect with a membrane covering it, it will be an exomphalos, or with all the bowel loops just floating in the amniotic fluid, it will be called a gastroschisis. It is a good idea to even do a longitudinal assessment here, so that you can see the relationship of the organs in the thorax and the abdomen, and a shadow of the diaphragm in between, because when there is a diaphragmatic hernia, you may see the malposition of abdominal organs into the thorax, and it is a good idea to detect this early also, if that is possible. So when you see an abnormal protrusion in the abdominal wall, it is an exomphalos. We all know exomphalos is a completely correctable abnormality, but a lot depends on whether there is an associated chromosomal abnormality or not. So if you detect an exomphalos at 32 weeks, then you have no option but to continue. And even if there is a chromosomal abnormality, you will have to deal with it, and that may not be a very happy experience for everyone. But here, if you see at 11 to 12 weeks, you can ask for a carrier, you can do a CVS, get a karyotyping done, and if there is an abnormal chromosomal content there, then you know that the long-term effect won't be great. In terms of the urinary bladder, a normal appearance is like that in the axial section, and here in the longitudinal section, we expect it to be less than 7 millimeter in the longitudinal diameter. Seeing the bladder is very reassuring, because it rules out bilateral renal agenesis or dysfunction. Because if any kidney is functioning somewhere and producing urine which is coming into the bladder, then that is a sign of renal function being present. A fluid around the baby may be present in the first trimester, again because of membrane secretions, and that does not necessarily indicate functioning kidneys. If the bladder longitudinal diameter is more than 7 millimeter, then it is called megacystis. And if it is very, very large, then we suspect there is a lower urinary tract infection, obstruction. Whereas if it is between 7 and 15, we suspect hypotonia, and also consider it as a marker for aneuploidies. So some of these severe cases of megacystis don't do well. They require termination. And this was one interesting case we had once seen. And this, after workup, turned out to be prune belly syndrome, which was a weakness of the abdominal wall muscles and other things. And the information that we got on the scan was only megacystis, but the rest of it came by the autopsy. So that is also an important thing to remember, that if you suspect an abnormality, always reconfirm with postnatal evaluation if possible. Normal appearing kidneys are here on the right side of the screen, where you see two kidneys almost equal in size placed across, around both the sides of the spine. Whereas this kidney on the left side, both of them are large and they have many small cysts, and they look like almost filling the abdomen there, and these are nothing but enlarged polycystic kidneys. And as we know, bilateral polycystic kidneys would be genetic condition, autosomal recessive in origin usually, and poor prognosis in that pregnancy. So diagnosing this very early is always useful. In the fetal phase, we look at it in two views. One is the mid-sagittal view, where we look at the profile, the presence of the nose, upper jaw, lower jaw, and just the general appearance of that. And the other thing we look at is the coronal view, where we look at this premaxillary triangle, and the base of which here is the maxilla, and the apex of which is formed by the two nasal bones. So if we can see the face properly, then that's great. If we see an abnormal contour of the face, we suspect facial anomalies. Absence of the nasal bone, hypoplasia of the nasal bone has implications in terms of aneuploidy screening, or a break in the maxillary contour has implications in terms of suspecting clefts later on. If we can diagnose them in a confirmed manner, that's great. If not, we wait for a later evaluation and confirm it. But as in neural tube defects, you can call them early and diagnose things early. Looking at the fetal limbs. Now, remember, this is the best time to look for fetal limbs. This is the best time when both the limbs on the upper segment and lower segment can be evaluated in their entirety in one view. So if you see a picture like this, you know that both legs were present and all three segments of the lower limbs were seen clearly. All three segments of the upper limb were seen clearly. In the second trimester, although the organ becomes much more defined, it is not easy for us to 100% confirm that we have seen both. Sometimes the hands may be curved over each other, the legs may be folded, and you may get confused. But if you have a first trimester picture like this, and you have been intelligent enough to document it in your records, you have made life easy for yourself for the rest of the pregnancy evaluation. Things like club foot and all can be seen at this stage, but again, you know, I would restrict. I mean, if you're 100% sure and you're seeing it along with another problem, for example, in this polycystic kidney case, we could see club feet, and we could put a foot there because it was kind of a high suspicion area. But in a normal case, if I'm doubtful, I would hold on till the mid trimester and give a complete diagnosis, because many times it could be a postural issue. But looking at the segments, presence of the segments of the limbs, undoubtedly this is the best time. Then missing limb segments are very important. They are not lethal. They are very much compatible with life, but have a very, very strong impact on the quality of life. And therefore, we don't want to miss this thing. And the problem with missing limb segments is it may happen in a baby which is otherwise looking completely healthy. So at 19 weeks, if you're seeing everything wonderfully and the baby is missing a right forearm, you may not actually suspect it unless you are looking at it very carefully. And sometimes you get confused when you see the hands like this. You may not know that you've seen both the hands or not. So therefore, first trimester evaluation and review of that first trimester image before you start your second trimester scan of utmost importance, and a good practice point for practical implication. Limb body wall complex, again, you can see now that we've described how do we look at anatomy, this problem definitely can be diagnosed in the first trimester. Again, something with poor prognosis, needs termination of pregnancy, and that can be achieved in the first trimester in a very relatively simple manner. So this is just a list of certain problems that we can definitely see, like holoprosencephaly, anencephaly, encephalocele, cystic hygroma, and exomphalos, limb agencies. There won't be any questions about whether you diagnose this correct or not, because they are very, very obvious. Spina bifida, cleft lip palate, heart defects, and short limbs, you may not be able to diagnose in first trimester, which is fine. If you suspect them and you're sure because all the markers are falling in place, then you can put confirm your diagnosis. Or if you want and wait and reconfirm later, but you've raised the suspicion in the first trimester, at least you will do the second trimester scan earlier or in a more sort of dedicated manner and not miss this thing in the second trimester. There's no harm in that. Certain other problems which don't really fall in the anatomical timeline, I don't think we need to spend time on them to look for them in the first trimester. Then comes the concept of screening for aneuploidy. Now, I'm not going to address this at all because Sir Dr. Suresh is going to do an entire session of this after this. And just for you to understand that screening is a concept which is applied on normal population to classify the normal population into high risk or low risk for a certain condition. And we know that there are markers in the first trimester like increased nuchal translucency, absent nasal bone, which make a fetus high risk for a certain condition, but the scan can be used for risk stratification. And finally, a test has to be done like a chorionic villus sampling or an amniocentesis, and the final diagnosis has to be confirmed before a decision is taken. Measuring of the NT is important in the first trimester, and we all should be aware of this entity called nuchal translucency. And this is the sonographic appearance of collection of fluid under the skin behind the fetal neck in the first trimester of pregnancy. It's a beautiful definition, and once you remember this definition, you don't forget what it is. So this is the area of nuchal translucency, and the concept came from Sir Langdon Down's idea that the skin is too large for their bodies in Down syndrome babies. And almost 100 years after he said that, Professor Kypros Nicolaides conceptualized it and gave us this beautiful concept of NT in the first trimester, which we can measure in the mid-sagittal section in the head and the neck in the first trimester of pregnancy, and give a numerical risk assessment for Down syndrome. Now, whether it is confined to the neck, septated, non-septated, or covering the whole body, nuchal translucency remains nuchal translucency, and it's the same way we measure it always. This protocol for measuring nuchal translucency is important, and anyone who is doing these scans should remember that it's the crown rump length which is more important. That should be between 45 and 84 millimeter. So even today we get NT reports at 40 mm. Giving an NT measurement is not a problem, but using it for risk calculation is a problem. So for risk calculation for aneuploidies, the CRL should be between 45 and 84 millimeter. Magnification of the head and thorax should occupy the whole screen. Mid-sagittal view, neutral position, distinguish the amnion and keep the calipers in the widest dimension. Now, this is all given in the Fetal Medicine Foundation website, and anybody who's interested in doing this should go there and hone their skills on how to do it. Whenever you do the NT measurement, turn your gain down to reduce the fuzziness there, and put your calipers in an on-to-on manner so that the horizontal line of the caliper is coincident with the brightest point of the edges there. Measure the maximum lucency, avoid flexed and extended positions which will measure the NT wrongly, because if you do a wrong calculation, you are giving a wrong value for NT and therefore a wrong risk assessment for aneuploidies. So magnification, gain, fetal attitude, take more than one measurements and record the maximum measurement for NT. One of the practical tips of doing an NT scan is going to the BPD, making the Fox cerebri vertical and turning 90 degrees there. So from BPD to NT is a good trick. Go to BPD, make it vertical, turn 90 degrees, you will get your NT view there. So for all of you who want to go and start doing your NTs tomorrow, try this, it'll work. And then you have minor adjustments. Whenever you're doing a scan, always differentiate the amnion from the rest of the baby. So the amnion does not move, the baby moves. So you tap the baby a little bit, it'll move, and then you see. So your NT measurement has to be perfect. Sometimes there is cord around neck in the first trimester of pregnancy. Don't fret, this is a common thing. It happens in about 5% of babies in the first trimester. You can see a cord around neck in the first trimester. And if that happens, just take the NT above the cord and below the cord and take the average of that. So in your FMF software, you will have nuchal cord as an option. Once you tick it, you can do NT above the cord, NT below the cord, and you report an average NT as the final NT for that baby. A normal NT is very reassuring, but an abnormal NT opens the Pandora's box for checking for chromosomal abnormalities, infections, genetic syndromes, cardiac defects, and therefore a lot of work starts from there on. So doing that NT properly is very important, and sometimes increased NT may be a normal variant, but that is a diagnosis of exclusion. So it just requires doing a lot of tests and doing this. So I always ask this question that which of these values is normal? Always remember NT is a function of CRL, and therefore never comment on the NT without knowing what is the CRL. And the same NT might be normal for 84 millimeter CRL, but it might be high above the 95th centile for a 45 CRL. So NT is always correlated with CRL, and that is how you decide whether the NT is increased or reduced. I am just telling you how to do the scan, how to interpret it in terms of risk calculation. Suresh sir will do in his session. So again, because CRL is so important in the NT, doing the CRL correctly is also important. So when you do CRL, your image magnification should be such that the entire baby is covered in that view which you are seeing. Position has to be midline sagittal. Attitude has to be neutral. Take 3 measurements and take the best of 3 measurements. And in NT, you took more than 3 measurements and you took the largest measurement. Whereas in CRL, just take the best of 3 measurements. Linear CRL, maximum length with the calipers placed at the intersection of the outer margin of the skin borders. All self-explanatory, and you have them all on the FMF website. Fetal heart rate is something else we measure when we do risk calculation, and that is done again using pulse wave Dopplers and 6 to 10 cardiac cycles, and in a period of relative fetal quiescence, so that your calculation is accurate. Nasal bone is measured almost at the same view as the NT, and what you need to see there is the second line. So that it's an equal to sign, but not so equal, because the lower line has to be more echogenic than the upper line, and that is representative of the nasal bone. If that is present, it's great. If that is present but not very convincing, you may call it hypoplastic. For the purposes of risk calculation, whether absent or hypoplastic, it means one and the same thing. So measuring the nuchal nasal bone also is similar to that of the NT. So always look for that equal to sign there. Then the ductus venosus in the first trimester, it is a very small vessel which is a continuation of the umbilical vein and connects into the inferior vena cava before draining into the fetal heart, carries oxygenated blood into the baby, has a lot of importance, and is almost a direct connection with the right atrium. So this can be measured in a mid-sagittal section, and you see an area of aliasing indicating that small narrowing of that umbilical vein into the while it gets connected to the IVC. That is the ductus venosus, and the normal pattern of the ductus venosus is very reassuring because it indicates good inflow of this thing and good cardiac function. When it is abnormal, the risk of cardiac defects increases, and it has been correlated with the risk of fetal death also because of the related pathologies. And it is abnormal ductal venous flow is therefore also associated with a high risk of chromosomal abnormalities. So tricuspid, this is how we discussed how we do it. And when we get the waveform, a normal waveform on a valve is always unidirectional because it opens in only one direction normally. Suppose there is flow in the opposite direction, occupying more than half of the cycle and going to a maximum speed of more than 60 centimeter per second, then it is called as tricuspid regurgitation. Otherwise, normal flow is always unidirectional. Abnormal flow is in the reverse direction, occupying more than half of the systole and going to 60 centimeters per second. So with all this, you can do this screening test, which is known as first trimester screening test. If you just do the scan, it is NT based. If you do the scan and the blood test, it becomes a combined screening test and can have a sensitivity of as much as 95%. So doing a wrong NT will give you a wrong risk calculation, and therefore your endeavor should be to do the NT properly and maintain your standards by external audit and quality. All of you who've got your first trimester certification for NT scan must be knowing that there is a method of regular audit. All of this is free of cost, just it requires your inputs there. And if you keep on sending your data and images for auditing. They will give you back a result telling you that how you're performing. If you're making mistakes, they will give you an advice for that. And if you're doing well, it's very reassurance. So if you do an NT scan, do it properly, because like Spider-Man said, great power brings great responsibility. And NT is a very powerful tool in fetal care. So if you do it well. Don't make a mess of it. If you cannot do it properly, better not to call it an NT scan, just call it a first trimester scan, because we discussed so many other things that can be done on first trimester scan. No harm if you have not done the NT, but at least whatever you've done, do it correctly. Now, sometimes you feel that you're doing this first trimester scan, something you are able to confirm, some things you're not able to confirm. Are we actually increasing the anxiety in the minds of the patients? Are we actually just, doing a lot of unnecessary intervention in the first trimester? But really, if you look at it, if you look at the data and now the way obstetrics is progressing, the advantage of first trimester early detection of problems is immense, and especially in the era of multiple cesarean sections and women who are conceiving after uterine surgeries, should they have that unfortunate situation of requiring a fetal requiring a termination, then at first trimester would be so much safer than. So for anomaly assessment, doing a good first trimester anomaly assessment is indisputably a good practice point. So the advantages for 11 to 14 weeks are, of course, that you diagnose things early and you can do a safer first trimester termination if required. When there is a correctable problem, you need certain workup before you decide that it's an optimal case for correction. So early detection gives you that advantage for time for working up. And if the patients want to rethink their decision and they want to do something later on, they may or may not, it gives them that time frame also, because getting a sudden information at the brink of a week when you have to decide that, oh, I can either terminate now or I cannot tomorrow, it's not a good time to make a logical decision. Aneuploidy screening, sir will be covering, and I'm not touching that. The other thing that we do in the first trimester scan is the screening for maternal problems like preeclampsia. And uterine artery Doppler is a very powerful tool in the first trimester, which can augment the screening process for preeclampsia. And as we discussed in the beginning, uterine artery is a branch of the anterior division of the internal iliac artery and supplies the uterus. Normally, uterus is a muscular organ, but as the pregnancy progresses and the placenta sets in, the muscle of the uterus as well as that of the vessel supplying the uterus get reorganized by the trophoblastic invasion of the placenta. And this reorganization ends in creating a low resistance circulation in the placental bed. If the circulation becomes low resistance, the normal resistance of the uterine artery reduces from first trimester to second trimester to third trimester in a normal pattern. This is the expected reduction of the resistance in the uterine artery. So you know that if you have tall peaks and very, very deep troughs here, that is high resistance. When you don't have that kind of deep troughs or you have very good diastolic flow, that is low resistance. So this is the normal transition that should happen. And over years, people have actually made nomograms of what should be the pulsatility index of the uterine artery at any point. And mind you, when we say uterine artery, we are talking about the mean pulsatility index of both the uterine arteries put together. So in the first trimester, you could do the uterine artery Doppler by just going into the lower segment of the uterine body, identifying the uterine artery somewhere near the origin of the cervix, and then measuring the pulsatility index of that waveform. So you measure both the right and the left uterine artery and convert it into multiples of median. Take the average and convert it into multiples of median. So in the first trimester, roughly about 2.6 would be high for all stages, but it is always better to check the nomogram per week and see whether it is high or low. And when you put all these into the software that calculates the risk for preeclampsia, you can complement it with other markers like the pregnancy-associated plasma protein A, PAP-A, or PLGF, placental growth factor, and then do a proper screening for preeclampsia. So this preeclampsia screening integrated with the aneuploidy screening has been put together in a very interesting name called the Be Happy test, where you do blood pressure, extended clinical examination, HCG, alpha-fetoprotein, PAPE, PLGF, and your NT scan. And then you can finish off the entire comprehensive screening protocol in the first trimester, including aneuploidies, open neural tube defects, and conditions like preeclampsia and fetal growth restriction. So the preeclampsia screening report will show the risk of preeclampsia, the early preeclampsia, and the risk of late preeclampsia. And if it is low risk, then that is very good. The cutoff here is 1 in 20. If it is high risk, then you still have time for some kind of intervention. This is the software on the FMF website. It is free for access to everybody, as long as you fill in all the details here, which include maternal characteristics, medical history, and obstetric history. Maternal characteristics include weight and the mean arterial pressure and the uterine artery pulsatility index. Then you can put in the biochemical measurements and get a numerical risk assessment, either by history only or by a combination of all these factors, which will make it more reliable, and you can then institute any kind of intervention. The best that we know is starting low dose aspirin before 16 weeks, which can improve the placentation and therefore reduce the risk of preterm preeclampsia significantly. We can do a risk assessment for fetal growth restriction based on the first trimester scan. Again, the protocol is given on the first trimester on the Fetal Medicine Foundation website, and you just need to fill in these clinical parameters and you can get an individualized assessment for fetal growth restriction. In the first trimester, being aware of these problems targets your antenatal care, prepares many things, and all of you who do regular obstetrics understand how important it is to know which pregnancy is going in which direction. Then comes the screening for preterm births. We know that if a woman is at risk of preterm birth, we cannot always prevent that preterm birth, but we can always do something or the other to optimize it. Now, in the first trimester, when you see a cervix which is short or it is yielding, that gives you time to start thinking what can be done. So the two interventions that we know in this regard are starting progesterones or inserting a cerclage. Now, doing a cerclage, again, after the first trimester scan is usually the ideal time to insert a cerclage, because you've done a comprehensive anatomy and aneuploidy risk assessment here only. So cerclage can be inserted, and sometimes in cases where there have been multiple preterm births, including failed vaginal cerclages, if first trimester workup is done properly, then after the scan you can plan and get an abdominal cerclage also inserted. The jury is still out what cerclage works, what intervention actually works for preterm labor, but the first trimester scan is the sort of watershed point where these decisions can be taken. Then the other important thing in first trimester scan now is the implications with the problems of the placenta, the lower segment issues, considering that the incidence of scar pregnancies and the previous cesarean scar woman has increased. So this, again, the first trimester is an important time to look at the placenta carefully and look for any signs of morbid adherence, of vessels crossing over from the normal level into the myometrium or the other areas, signs of morbid adherence which need to be sorted out in the first trimester. If we suspect all that, then again, you have to make some important decisions in pregnancy here. So in the last point that I want to touch upon in the first trimester scan implications is implications in multiple pregnancy. There is no taking away from the fact that the only single most important determinant of outcome of multiple pregnancy is chorionicity. And the establishment of chorionicity is unequivocally possible in the first trimester, because 11 to 14 weeks is the time when you have to put a foot down, whether it is monochorionic or dichorionic, because before that it may be too early, after that it may be too late, but 11 to 14 weeks is just the ideal time. And all that you need to see there is this lambda sign, which is a sign of dichorionicity. If there is a lambda sign, there is some chorionic tissue coming in between the membranes there. This is a sign of two placenta being present, and therefore this is dichorionicity. Whereas if you don't see the lambda sign, then you have to assume monochorionicity. So you may lose the lambda sign after 14 weeks. So please, if you're doing the first trimester scan, document lambda sign, and if possible, preserve a picture of that lambda sign in the notes for future reference, because there are times when people come and we are confused, and the stories are endless of how things go wrong. But if you want to make it right, then this is your opportunity. If you don't see the lambda sign, look for it, because only when you've looked for the lambda sign and not found it, please label it as monochorionic. So if it is monochorionic, you will find the T sign. You don't see a chorionic peak coming in between, but you see the membrane attached like a T into the placenta there. So T sign is a sign of monochorionicity, whereas lambda sign is a sign of dichorionicity. And monochorionic twins, of course, they have shared placenta, shared circulation, and they can have a number of problems. So establishing chorionicity is another implication of the first trimester scan. The importance is all the complications of twin-to-twin transfusion or perinatal morbidity and mortality are higher in the monochorionic group as compared to the dichorionic group, and the follow-up protocol is different in either of them. So determination of viability as well as chorionicity is optimally done at the 11 to 14 week scan for multiple pregnancies. So really, if you summarize the first trimester scan, this 11 to 14 weeks window, if you actually open that window of opportunity, what does it do? It does a baseline fetal anatomy scan. It does screening for fetal aneuploidies, screening for risk of preterm birth, screening for preeclampsia and fetal growth restriction, and screening for multiple pregnancy issues. So you can diagnose multiple pregnancy in the second. I am sure many of you would have had that situation where there was a single fetal pole in the 6 week scan and twins in the 12 week scan, because you can't miss multiple pregnancy in the 11 to 14 week scan. Not only diagnosing multiple pregnancy, but also diagnosing chorionicity and taking it further from there. So if you see who benefits from the first trimester scan, a primigravida, yes, because if fetal anomalies, preeclampsia, all this you need to see in the primigravida. Multipara, of course, because there are so many issues now, especially with the ones with previous cesarean section, we've had added benefits there. Low BMI, high risk of premature birth, of course. High BMI, of course, because in high BMI patients, this is the best time to do a proper assessment of anatomy. Second trimester, the baby might be bigger, but your windows of, acoustic windows might be lost there. High risk for aneuploidy, of course, in first trimester, you want to establish things. Low risk for aneuploidy, you want to do the first trimester screening and find out whether she turns into high risk or not. If it's singleton, of course, you want to do the first trimester scan. If it is, multiple pregnancy that should have been, then also you want to do the first trimester scan. Previous preeclampsia, of course, you want to do the first trimester scan. So really, there isn't any pregnant woman where you would think that a first trimester scan is really not required. So I rest my case with the fact that the first trimester window is an extremely important window, and which pregnant woman may not be offered the first trimester scan after the doctor is aware of all these benefits. So there is no taking away from the fact that good first trimester scan will establish the base of the pyramid of antenatal care. Even if it is inverted, that is what occupies the base. So do no harm to your patient, give them the opportunity of doing a good first trimester evaluation. And if you begin your pregnancy workup with a good first trimester scan, half of your work is anyway done. Can we do more? Whatever I have told you today, tomorrow that's going to get old. So I'm sure when you want to do more, something else is going to come up. There will be newer things that will come up. We are now hearing about the ophthalmic artery evaluation, although it's still the gestational age is still to be determined for the risk of preeclampsia. We are thinking of other methods of looking into the fetus in the first trimester. And I'm sure there'll be more changes and we'll address it in the future meetings. But till that time, do everything in a structured manner and do it exactly the same way, following the checklist to achieve a standard format of first trimester evaluation, because we are what we repeatedly do. Excellence is therefore not an act of chance, it is a habit, and that must be pursued. So thank you very much for a very patient hearing. And if there are any questions, I'll be happy to answer. Thank you.
Thank you, ma'am. That was an excellent session indeed. I'm sure everybody listening has benefited highly from this session, ma'am.
Thank you. Are there any questions or any?
Yes, ma'am. We are just waiting to see, like, we are checking if there are any questions, ma'am. Ma'am, your talk has been so good that I think everybody understood everything that you said, ma'am. There have been no queries, ma'am.
Thank you. Thank you very much.
Thank you, ma'am. Now, I would like to invite our next speaker, Dr. S. Suresh, and he will be speaking on the topic aneuploidy screening in pregnancy. Dr. S. Suresh has been a fetal medicine specialist over 30 years. He has been conferred the FRCOG by Royal College of London in 2010. His main areas of interest are prenatal diagnosis and fetal therapy. Sir is a member of the WHO SEARO expert group for birth defect surveillance and prevention. He is also a task force member and ambassador of ISUOG. Sir, I welcome you.
Thank you. Are you able to hear me?
I can hear you, sir. You're audible, sir.
Okay, thank you. My slides are visible. Is my slide visible?
It is visible, sir.
Okay, thank you.
Thank you, sir.
Good morning, and thank you very much for inviting me to give a lecture on prenatal screening for aneuploidy. And I just heard Chinmay giving a fantastic talk on the first trimester. And she has made my job easy because all the technical details regarding the how to take the markers have already been covered. So the plan is to look at basic principles of screening, importance of counseling, understanding terminologies, and also screening tests and their performance, NIPT, and also case discussions. So we will try to go more in case discussions by cutting down a bit on the theory. So first of all, the risk of Down syndrome increases with mother's age. But that's the thing which we all of us know well. 70% of babies with Down syndrome will be born to women below 35 years of age. And that's the entire concept of screening, is to screen in women where we are unsuspected incidence of Down syndrome. It's also important to remember that 99% of people with Down syndrome report being content with their lives. So we are doing detect and terminate kind of a thing. If you go to the Down Syndrome Association, they will say, well, these people have a right to live and they also do have a good life to lead. But we must know for medical purposes, there are three types of Down syndrome. One is 95% will be non-disjunction or pure trisomy 21, 4 to 5% translocation Down syndrome, and 1% mosaic Down syndrome, because sometimes during screening, translocation Down syndrome may not, or mosaic Downs may not be picked up. Now, life expectancy for people with Down syndrome has increased dramatically from 25 in 1983 to almost 60 years today. I know of a couple of people who are 64 years old and they are going quite strong. Right. Now, what do screening tests actually do? Now, screening tests are generally applied on the population. They identify patients at risk for a disorder in an unsuspected population. A patient walks into my clinic and says, doctor, I'm pregnant. I potentially see, and she says, I'm 25 years old, but that is a patient where I want to do screening because the incidence of Down syndrome is less in a 25-year-old as compared to a 40-year-old, but most certainly it is not zero. So that's why screening is important. And we identify patients for further diagnostic testing. And it's important also to know that screening does not say yes or no. It is probable or not probable. We are looking at probabilities. So we have some screening tests which are ultrasound, biochemistry, which is applied on the population. If you consider all the green people as normal and the ones in the orange are Down syndrome, when we apply a screening test, we will find that both the normal people and people with Down syndrome are filtered, but this is called as the high risk group. And in this high risk group, we can add do an additional test, which is the invasive test, and identify those who have Down syndrome, and those who do not have go back into the population. But it's also important to remember, while you're applying the filter, there will be some persons affected with Down syndrome, some babies which will not be detected by the screening. So that is why screening is never an yes or no test. And we can improve the screening by looking at various newer methods of screening. One is, of course, the classical biochemistry and the ultrasound. The other is non-invasive screening, which gives you a better predictability. We'll come to that a bit later. Now, we need to understand the concepts of screening very well. And the first concept that needs to be understood is pre-test counseling. Pre-test counseling is very important. It takes about 8 to 10 minutes to go through the counseling, unless the patients have a lot of questions where it can extend. We explain what is Down syndrome, explain availability of screening tests, all options in the program to be discussed, detection rates, false positive rates and false negative rates, action to be taken if screen positive or negative. This has to be mentioned ahead of time. If you are screen positive, you might have to undergo through an invasive testing. And if the patient opts out of invasive testing, then we say that no screening is not required. Option of refusal and opting out at any time, and documentation of patient choices. If you have offered screening tests and the patient has refused screening, simply document saying screening offered but patient has declined. Now, second thing is essential pre-test information. Before we embark on the test, we need to take the obstetric history, method of conception, maternal weight and BMI, sibling history of Down syndrome or neural tube defects, maternal date of birth, donor's age if there is, in the case of oocyte donation. These are two very important things. We don't ask for maternal age, we ask for maternal date of birth, because the probability or the risk is calculated for Down syndrome when the mother's age when she delivers. So at the time of delivery, what will be the mother's age? That is what is put into the algorithm. Now, if there are previous screening tests, supposing she's come to you at 16 weeks, and she's had a screening test at 11 weeks, and you find that you need to do an additional screening test, then the results of the screening test has to be used, because this forms what is known as the baseline or a probability. The maternal age is the baseline probability or baseline risk, and the previous results of the previous screening test becomes the baseline probability. The next issue in screening is one where you have utmost importance, is doing the crown rump length correctly. In the between CRL 45 to 84, where at that time we do the NT and other soft markers. In the second trimester, we do the biparietal diameter of the head circumference, because all dating for screening is done only by ultrasound. We don't go by LMP dating for anyone. So ultrasound dating is what, even if the date or LMP date is correct, we still use the ultrasound as the point for the CRL is taken for the dating. So the technique of CRL imaging is very important. And if you see a screening test from anybody, when you look at the result, please go and look at the CRL picture. If the CRL picture is not taken correctly, then the entire result what is given is completely wrong. Now, the NT, of course, are also to be taken correctly. So here is a baby with a neutral head where the NT was measured as 3.5. The same baby with the head flexed, the NT has become 2.7. And the risk given in both these things will be completely different. So you need to pay a lot of attention to detail. Next is the workflow. Now, we first have the a priori probability, which is the maternal age or previous screening result. Then you identify markers, both could be both ultrasound and biochemistry. Then you choose the screening model. What is the screening model? I'll tell you about. Timing, quality control, and interpretation are the three key components here. Then once you choose the screening model, you put all the data you collected from the ultrasound and biochemistry, you put it through a software, and that will give you a modified probability or the modified risk. Now, once you have a number saying 1 in 400 or 1 in 600 or 800, you need to have a cutoff before you say that this patient is at high risk or low risk. So we will define cutoffs as we go by. Now, once you define a cutoff, and if the is above the cutoff, then you identify patients for invasive testing. Next is, of course, the ultrasound markers itself. The way how to take the nuchal translucency has been already mentioned. So higher the nuchal translucency, higher the risk for trisomy 21. Lower the nuchal translucency, lower the risk of trisomy 21. When the NT is greater than 99th centile, it has a very high T21 risk. When the NT is greater than 4.5, higher risk for other defects. And when the NT is greater than 6.5, there's a higher risk for Turner syndrome. Of course, we'll keep all the aneuploidies in mind, but specifically when it's more than 6.5, you should consider Turner syndrome as one of the options. Next is nasal bone. It is easier said than done, because nasal bone is probably the most controversial marker of all. There's a very high degree of ethnic influence. Very high likelihood ratios are reported, right from 3.9 to 24.6. There's a high inter-operator variability to be used only when the operator is supremely confident and certified. And it is preferable to image when the CRL is greater than 55 millimeters, because then the incidence of unossified nasal bone is actually less. There are questions here. When the nasal bone is absent in the first trimester and ossified in the second trimester, what is the implication? Does the risk go down? And when the nasal bone is present in the first trimester and not seen in the second trimester, then did the operator did a mistake? Can the NB actually disappear after seeing in the first and second? So obviously we know an ossified nasal bone cannot become an ossified laser, but an unossified nasal bone can become ossified in the second trimester. But as far as risk prediction is concerned, it is the time at which you see the marker, you consider apply the marker and don't revisit it again at a later date. Next is ductus venosus. We know that the reversal of A wave is abnormal, but again in ductus venosus you must ensure the waveform is not contaminated and you have a clean waveform for interpretation. So same thing with the tricuspid regurgitation. There are conditions which are applied. You can see the sample volume has to be large, and then you, Chinmay has told you, it has to be more than 60 centimeters for you to ensure that is called as tricuspid regurgitation. So the key message here is training and certification is essential for all markers. Appropriate software should be used, and if NT is greater than 3.5 millimeters, direct testing is preferred. Do not go and do biochemistry or any other test. Go for direct testing. Increasing preference for microarray testing. Of course, in that we have to take care in interpretation depending on what type of microarray, and maybe you might need the help of a geneticist at that point. Now, structural defects and other specific markers are something we look for. When there is a structural defect, we don't go for screening, we go straight for direct testing. Right. Now, just a word to say that you can see hyperplastic nasal bone, tricuspid regurgitation, reverse ductus venosus. So they are seen in a number of patients with Down syndrome, but it can also be seen in euploid fetuses. So a marker doesn't mean it is a diagnosis. It is only an indicator, and we need to apply the rules and say that. Now, but there are some very specific ultrasound markers for some trisomies. For example, trisomy 13, polydactyly, holoprosencephaly, midfacial hyperplasia. We know that this all points toward trisomy 13, And when there's a large head and small abdomen, it points towards triploidy. And when there's a large nuchal transparency or a septated large NT, then you know it is a points towards a Turner syndrome. So key message again here is aneuploidies are present with characteristic markers and ultrasound signs. Detailed anatomical screening is the second filter. So first filter is the marker, second filter is the detailed anatomical screening. Only after these two are done, you go and apply the biochemistry and do that. Then we need to understand some terminologies. One of them is called multiples of median. This is what you'll see in the report. Second is the likelihood ratio, cutoff, detection rate, false positive rate, positive predictive value, and otherwise called as odds of being affected with a positive result, or OAPR, and a negative predictive value. So what is multiples of median? If you have a value of 10, which is the median value, let's say the Pape median value at a given point is 10, and then you measure it in this particular fetus and it is 20. So we are expecting a value of 10 when the CRL is 45 millimeters, but this patient is having 20. That means it is twice the median that is there. So it is 20 by 10 or 2 multiples of median. Similarly, if it is 5, then is 5 by 10, which is 0.5 MOM. So multiples of median is nothing but variation from the median of that value from that week at that week of gestation. Now what happens to these MOMs which are generated by the software? They are converted to likelihood ratios. Now the likelihood ratio, so each MOM value has a likelihood ratio. For example, NT of 2 millimeters, CRL 55, let us assume has a likelihood ratio of 3. But if the same NT 2 millimeters with a CRL of 75 will have an LR of 1.2. So this means that everything is linked to the CRL, and because markers change over a period of time. So, but higher the NT mom and higher the likelihood ratio. Higher the HCG mom, higher the likelihood ratio, and lower the Pape mom, higher the likelihood ratio. And as I said, for example, nasal bone ductus venosus, we have a positive likelihood ratio and a negative likelihood ratio. What do we mean by that? A negative likelihood ratio, when the marker is absent, then the likelihood ratio goes below 1. So the risk lowers for the patient. When there's a positive likelihood ratio, the risk multiplies depending on that number. Now we also have what is known as an isolated likelihood ratio. This actually means that if no other markers are present, all the markers are absent and only this one is present, then the likelihood ratio is called isolated likelihood ratio. And you will find it is very different from the positive LR which is there. The next concept we are going to talk about is called as the cutoff. Now, when you have, we do the screening can throw up any result, like it could be 100, 150, 250, 600, 400, 2500. So we need to know what to do with these numbers. So what we will do in India, what we have done is we have taken 1 in 250 as the cutoff. Across the country, we have done this. But if you take the United Kingdom, they have taken 1 in 100 as a cutoff. Most countries in the world take 1 in 100 as the cutoff. So the reason is, once you have a cutoff which is a higher cutoff of 1 in 100, then the number of invasive testing you need to do will be lesser. But there is a potential you can miss out on babies because they will be called as screen negative and you may not opt for that. So the more efficient the screening test, your cutoff can be adjusted accordingly. So 1 in 250 if you have the cutoff, between 1 in 251 to 1 in 1000, because less than 1 in 1000 we call as low risk. Between 1 in 251 to 1 in 1000, around 5 to 6% of Down syndrome babies will be in this group. So that is why we call them as the intermediate risk group. We'll talk about that as we go by. Right. So cutoffs are important. Your own cutoff is what you go by. Now, next is positive predictive value. Positive predictive value is otherwise called as odds of being affected with a positive result. Here it's in practical terms, translates into how many invasive procedures I need to do before I detect one Down syndrome. There are some practitioners who are continuously sent for screening. They have 4 patients or 5 patients within a week or 10 days having screen positive. all 4 of them are sent for invasive testing, and all 4 of them come as negative. So immediately you say, what is the purpose of doing this test? There is no use, because all screen positives are coming as normal. They are not Down syndrome. So we should not look at it like that. We should look at it from a larger perspective. You need to do, for example, if OAPR 1 in 5, then among women with screen positive results, 1 will have a affected pregnancy, for 5 which is not. So in your combined testing, the OAPR is 1 in 23. So you have to do 23 procedures to identify 1 Down syndrome. That is why we are moving, because the positive predictive value of the Down syndrome routine screening tests are not very high, whereas the positive predictive value of the non-invasive screening is high. I'll tell you about it shortly. Now, so finally, we are boiled with we have some options for screening. Let us take the first trimester. First trimester, everyone is familiar with the word double marker, which is PAPA and beta HCG, and that is probably the worst name that was ever coined in the history of screening, because we should never use that word. I'll tell you why. Second is the combined test, first trimester screening, NT plus PAPA plus beta HCG. Plus you can add nasal bone ductus venosus tricuspid regurgitation. Then we also have something known as enhanced FTS by adding a few more markers I'll tell you about. In the second trimester, we have the quadruple screening, and then we have screening models. We have the combined screening, we have the sequential screening, we have what is known as contingent screening, and also the serum integrated screening. It's very simple. When you do all the markers combined in one go, you call it a combined test. In sequential screening, you do one test after the other. In fact, in the combined test, the software will calculate the risk sequentially. First it will take the NT, then it will put the PAPA, then it will put the beta HCG, then you will put the other markers. So then you have the contingent screening, where you do 2 tests. First you do a first trimester screening, then you go and do a second trimester screening. So based on the first trimester result, you want to do additional screening. So that's called as a contingent test. Then you have, of course, NIPT, and NIPT fits in very well as a contingent test. Now, it's also important to know that in the first trimester screening biochemistry, free beta HCG and PAPA are the common ones. In trisomy 21, the free beta increases and PAPA decreases. In trisomy 18 and 13, both decrease, and sex chromosome aneuploidies, PAPA decreases, there's no change in the beta HCG. Now, why I'm saying this, when you see a screening result, it's important you go and look at the MOMs of the free beta HCG and PAPA and also the NT, and understand why this person is called as low risk or high risk. And that we'll tell you with illustrated examples. Now, there are also factors that affect biochemistry and risk prediction. Diabetes, IVF, a vanishing twin, and early pregnancy bleeding. In diabetes, you have increased false positive rates because of reduced PAPA and increased HCG. Again, increased false positive rates in IVF pregnancy because beta HCG is a little higher and PAPA is lower, and vanishing twin. And that's why this PAPA being lower in IVF pregnancies leads to a little smaller placenta, and this also leads to the fetal, the trophoblasts not entering into the maternal circulation. So in IVF, when you do non-invasive screening, you have a higher failure rates because of that. We'll come back to that again. So vanishing twin is if there is no fetal pole in the other sac, then you just treat it as a singleton. But in a vanishing twin, if you see a small fetal pole on the other sac, then you don't do biochemical screening. And early pregnancy screening, there is no need, there is no impact. So let's look at the first trimester. If you do the NT and the biochemistry, you have a 90% detection rate for a 3 to 5% false positive rate. Now, if you add PLGF and alpha fetoprotein along with free beta HCG and PAPA, this is called as enhanced first trimester screening. And how that is valuable is if NT is available and you do the enhanced first trimester screening along with the NT as a combined test, you have a 90% rate, but your false positive rate goes down to 1.4%. So it's very powerful to reduce the false positive rate. If NT is not available, but you still have the crown rump length, then you still get an 80% detection rate for a 5% false positive rate. Now, this is why I'm saying that when you talk about free beta hCG and PAPA as a double marker, the sensitivity is only 59%. So first trimester double marker alone not preferred, not should never be done, because it has got extremely poor sensitivity and it puts the patient at a false sense of security that everything is normal. Oh, double marker is normal. If you don't have nuchal translucency, you can do a quadruple marker or enhanced first trimester screening in the first trimester, which will give you at least 80%, which is the same as doing NT alone. And if you have NT plus this, then of course it's very, very powerful. Now, sometimes say, I don't have access to biochemistry. Let me do only ultrasound alone, and how efficient is this? So this paper looks at screening by ultrasound alone, but looking at all the markers: maternal age, NT plus NB plus tricuspid flow plus ductus venosus, and you keep a cutoff of 1 in 50, not 1 in 250. When you keep a cutoff of 1 in 50, then you have a 95.7% detection rate for a 4.3% false positive rate. So soft markers alone can be a very good screening method, but your cutoff is different and you need a very high degree of skill consistently across all patients to do it. When you come to the second trimester, we do the classical method is the quadruple screening, which is 15 to 18 weeks, and the quadruple marker test. When you go beyond 18 weeks, the sensitivity actually goes down. AFP, HCG, unconjugated estriol, and inhibin A. And the detection rate is about 75 to 80% with a false positive rate of 5%. The OAPR is 1 in 36. So your second trimester, you have to do 36 amnios in positive patients to detect one-term stroke. So that's why earlier screening is definitely better. So again, never do double marker alone without NT. If NT is not possible, you do quad screening the first trimester, and if you missed that out, quadruple screening in the second trimester. Now we come to cell-free DNA. Now, cell-free DNA was introduced as a test. It actually changed the game for screening in a very significant way, because the increased detection rates, reduced false positive rate, and reduced number of invasive procedures, reduced risk to the fetus. The question is, can it be offered to all women? It's quite expensive, and there are some limitations to this test. Now, what is cell-free DNA? Maternal hematopoietic cells are present in the maternal circulation. Fetal, in the fetal, there are apoptosis of the placental or syncytial trophoblastic cells. These enter into the maternal circulation. They cross the placental barrier. They generate cell-free DNA, and it's circulating in the maternal blood. Now, the fetal fragments of the cell-free DNA are shorter in length, whereas the maternal cell-free DNA fragments are longer in length. So, the relative concentration of cell-free DNA in the maternal blood at 10 to 20 weeks, it increases by about 0.1% every week, and after 20 weeks, it increases almost 1% every week. So, there's a free exchange, the free flow of fetal DNA into the maternal circulation. But the most important thing is, when they test for cell-free DNA, you have to look at the result and say, what is the fetal fraction? The sensitivity of the fetal cell-free DNA test depends on the fetal fraction. If the fetal fraction is 0 to 4, too low to report, like maternal obesity, and in when there's a low PAPA and other situations. When there's an intermediate fetal fraction, we can overcome by what is known as the SNP method. And when the fetal fraction is over 8%, it is ideally suited for highly sensitive testing. So let us look at predictive value of cell-free DNA. Now, if you do for trisomy 21, the combined test has got a positive predictive value of 5%, right? And a negative predictive value of 99.8%, which means in cell-free DNA, the positive predictive value is almost 85%, which means the odds of being the positive result is almost 1:1. That is, if you see a positive result, you are most likely that the baby will be Down syndrome process. So that's why the cell-free DNA is very powerful. The negative predictive value is also very powerful, greater than 99.9%. Okay, so that's why cell-free. But if you look at 18, trisomy 18 and 13, the sensitivity actually goes down and the positive predictive value goes down. Now, there are issues in cell-free DNA testing. If you test it too early gestation, less than 10 weeks, suboptimal sample collection because sample collection has been done correctly, maternal weight over 80 kilograms, there is more maternally derived cell-free DNA and correction for weight cannot be applied in the situation. Lower fetal fraction is seen in trisomy 18, 13 and Turner syndrome and triploidy less than 4%. So if the baby is already having a chromosomal abnormality, which is 18, 13, Turner's and triploidy, you'll have a lower fetal fraction in the maternal blood. And then again, your test may not result. That's why the detection rate for these tests are a little less. Now, use other factors like use of low molecular weight heparin in the patient. Also, it will affect your NIPT result. IVF pregnancies and twins, each of those fetus can have a lower fetal fraction. And if one fetal fraction is very low and the other fetal fraction is high, then the result may be belong to one fetus and may not belong to other fetus. So a lot of confusions there. So, but the cell-free DNA is cleared from the mother within 1 hour after delivery and complete clearance is seen within 2 days. Means every pregnancy you test, it is for that pregnancy alone and there is no lingering legacy cells which are there. So finally, to summarize this, the first line of screening by combined test, if you have a risk cutoff of 1 in 250, when the risk is greater than 1 in 250, you go for invasive testing. When the risk is less than 1 in 1000, we say don't do anything else. When there is a risk between 1 in 251 to 1 in 1000, which is about 7 to 10% of the population, you can do an additional test, which is the cell-free DNA test. And if cell-free DNA is screen positive, then you do invasive testing. If it is screen negative, don't do anything else. And if it's no result, you simply use the combined test result. And if the risk is more than 1 in 100 or less than 1 in 100, or you can have your 1 in 250 as a cutoff and offer direct invasive testing. Right. Now, we'll come to finally some frequently asked questions. And who should be offered cell-free DNA testing? Primary screening can be offered to all women, but the cost is prohibitive. There are countries who have moved to all women getting cell-free DNA testing. Secondary screening after combined first trimester screening, the intermediate probability group. But again, you can have a cutoff of different, either 1 in 150 or 250, whichever you want, you can choose that. High probability group, because if you're going to offer a very high powerful test, you may want to take a cutoff from 1 in 250 to 1 in 100 or 1 in 50. So at 1 in 101 to 1 in 1000, you can offer cell-free DNA so that there are less chances of missing a baby with Down syndrome. Now, for which conditions should cell-free DNA screening be offered? A good clinical utility for trisomy 21. 18 and 13 is a little less, but still better than combined testing. It potentially less clinical utility for sex chromosomal aneuploidies. There is insufficient evidence to support routine clinical application for microdeletion syndromes, rare autosomal trisomies, so on and so forth. So, can we use cell-free DNA for primary screening? So this is what I said, some affluent countries have implemented. But important thing to remember is there is a 1 to 5% test failure rate. So you send for cell-free DNA and the result comes as no result. And when it comes as they do retesting, again no result. And then you do invasive testing, then the baby has Down syndrome or may not have it. Now, consistently, if you don't have any result, low fetal fraction, because of low fetal fraction, it now has also been said it could be a pointer for maternal malignancies which could exist. So that is another fallout which is coming. We need to look into that as more evidence comes in. Now, how well does cell-free DNA perform in twins? Sensitivity is 95.2%. False positive rate is less than 0.1. However, test failures are more common for twins at approximately 5%. Right? Does not give individual probabilities in the DCDA twins. Hence, 2 amnios may be required. And if single fetal demise, false results can happen because cell-free DNA can remain up to 50 weeks after the demise has occurred on the baby. So we don't offer that as these patients. So the International Society for Prenatal Diagnosis has given a position statement of all the testing results where the false positive rates are there. Of course, cell-free DNA has got the lowest false positive rate and the highest detection rate. Now, what about cell-free DNA and IVF conceptions? NIS can be done in IVF pregnancies. 97.6% of cell-free DNA tests on IVF pregnancies will be provided the result. I mean, 3 to 4% you will not get a result. However, compared with spontaneous conception, there is lower fetal fraction and higher failure rates. And all these results from the placentae may be a little smaller as in IVF pregnancies as compared to routine pregnancies. Now, when there is a donor oocyte or embryo in a singleton, there are some labs will say we can do it. There are some labs which will not do it. So check with the lab. Because there are different techniques of doing the cell-free DNA, and they will do it. When there's a donor oocyte or embryo in twins, it is not recommended. When triplets or more, only NT screening, no non-invasive testing or even combined testing. Now, how to manage cell-free DNA test failures? The result comes as no result. The repeat testing can be done, or you offer direct diagnostic testing, or go with the combined first trimester screening result, or you can do a second trimester quadruple screening. So any options that are available. Now, can cell-free DNA be used for screening for single gene disorders? Now, the answer is no. Even though technologically many people claim, it has still not been validated. So let's not get into that area and get ourselves into some kind of a trouble. Now, can we ignore second trimester soft markers in a woman with low probability cell-free DNA result? So this is a good question, because you're doing a second trimester scan. Suddenly you see aberrant right subclavian artery, or there is mild ventriculomegaly, or there is a thickened nuchal fold, echogenic intracardiac force. All these are soft markers, and which was not seen before. But you've already done a cell-free DNA test. So should I take notice of these markers or no? So the answer is very simple. Soft markers have no value after cell-free DNA. You can simply ignore them, because you have done a very high test with very high sensitivity. Any other thing which are added on is of no use at all. If there is a structural abnormality, then you can do an invasive testing, because there could be other chromosomal anomalies other than trisomy 21, because all our focus is only on trisomy 21 for looking at other things, right? Now, what is the importance of second trimester soft markers? When you do a first trimester combined screening, then what is the use of second trimester soft markers? They found that this paper found that detection rate increased from 1 to 9%, but only NT-based screening. There is no clear evidence available, because once you have filtered a baby with a very powerful filter, what goes to the second trimester are those filtered babies. So unless you test millions of people in those filtered babies with these markers and come out with likelihood ratios for a first trimester screened patient, these markers are not valid. So let's not get into the area and confuse ourselves. Now, can we do the second trimester genetic sonogram as a contingent second trimester? That is, you do a first trimester combined screening. I have a result told, say 1 in 700. The woman says, I don't want to go through any further testing. I don't want any invasive testing. Can you reassure me a little bit more that it's not 1 in 750, maybe 1 in 1500? So in such cases, you do a second trimester full genetic sonogram, and if that is negative, then you have a negative likelihood ratio. You can readjust the 1 in 750 to 1 in 1500. So but there is no hard evidence for this. But in case a little bit of reassurance can be given, but we can't go and stick our neck out for that. So it needs high expertise and software. So the final take-home points are: keep it simple in low-risk women, counseling and combined first trimester screening done well. If intermediate probability, then offer NIPT. If patient is apprehensive, then offer NIPT. If combined first trimester screening is above 1 in 50, direct testing. In some women who say, I have gone to Google and read everything, you give me NIPT for the first choice, you can offer it as a first choice, no problem. If NT is greater than 3.5 or structural abnormalities are present, no screening is required. Straight away go for invasive testing. Always decide the program and stick to it, and don't change for patient to patient. Don't say for this patient I will do NT alone, the next patient I will do NT plus combined screening, then because she's my friend's daughter I will do some other screening. Don't do such the thing. Treat everybody the same way, because then your program becomes very robust and auditable and verifiable. There are many approaches to one condition: accessibility, availability, affordability, and the availability of experts to deliver high quality testing is what ultimately matters. And you can add more markers if competent and have specific software. So how much time we have? How much time we have? What's the
So
time?
we have time, sir.
Okay, so I'll go through some case scenarios.
Yes,
We
sir.
go
Sure,
through case
sir.
scenario.
Yes, sir.
So when we get a screening result, why did the screen test become positive? That's the question I want to ask myself. Understand the screening. What are the variables we need to factor in the discussion? That is, when I talk to the patient, what is the kind of counseling I need to give? What are the issues in counseling? And decision making in twins, is it different? So let's look at this now. So here's the first case where the risk has come as age risk is 1 in 257, final risk is 1 in 51. So you can see this red saying the T21 risk is high. Now what I do is, instead of seeing this, I go and see the components of the test. Let's see what I understand from this test. HCG beta, there is an underscore DBS. Please remember this. There's an NB, there's an NT, and there's a PAPE underscore DBS. I'll tell you what that means in a minute. Then you have the concentration, and you have what is known as the corrected MOM. This is corrected by maternal weight and other factors that need correction factor that need to be applied. So HCG shows 2.2 MOM, NB is present, nuchal translucency is 1.15 MOM, and PAPE is 0.33 MOM. Now when I talk about MOM, as I say, 1 MOM is my standard for that week. So if I say 2.2, HCG is double and PAPE is 1/3 less. That's what it shows. So this baby has got a low PAPE and a high HCG. So we said initially in the biochemistry, HCG increases and PAPE decreases in Down syndrome. And this is the reason why this screen became positive, right? So low PAPE and high HCG. Now the age risk is also 1 in 257. Now an average risk of a woman who is 25 years old is about 1 in 1,000, right? So here the maternal weight is 59 kg. The maternal age is not given here, but I can say this mother must be over 35 years old, because it's already gone to above 1 in 257. So age risk itself is quite high, right? Right. The next one is, so case 1, amniocentesis done, karyotype is normal, follow for growth and Doppler. Now let's see what's important here. 1 in 51, high risk. You do a karyotype, it is normal. You should not be surprised about this, because if 51 people of the same result are going to go through an amniocentesis, only one of them will have a Down syndrome, right? But because the PAPE is very low, so what happened here, PAPE is very, very low. And because PAPE is low, I will go and look at growth and do uterine artery Doppler for this patient. We'll come back to that in a minute. Now, let's consider another case where the first time the screen positive test was trisomy 13, 1 in 50, trisomy 18, 1 in 21, but trisomy 21, 1 in 600. So this is because PAPE was 0.1 and HCG was 1.5. Okay, so this baby has low PAPE, very, very low PAPE. And what to do next? Should I do NIPT? Should I do direct test or CVS amniocentesis, or can reassure with ultrasound and follow up? Because I can tell, I have done the ultrasound, fantastic ultrasound, baby does not have anything at all, so it cannot be trisomy 13. So I don't need to go and test for it. But can I reassure the patient, and will you be comfortable with that? So the answer is, the patient says, no, I want a sure answer. Don't tell me may not happen. So we do CVS and we found all were normal. All were normal, right? Right. Now, the ultrasound review at 16 weeks. So the patient PAPA was 0.1. Karyotype is normal. So she comes at 16 weeks and we found the uterine artery Dopplers showing high resistance flow. There was a 2 to 3 weeks lag. There was early growth restriction, and you can see placental abnormalities which are there. So obviously, this was a case of placental dysfunction. So that low PAPA pointed to placental dysfunction and not aneuploidy. So any patient with screens positive with lower biochemical MOMS inform the need for close monitoring of growth from 20 weeks onwards. Now let's go to case 2. In case 2, the age risk is 1 in 1,471. Then obviously she must be a young mother. That because 1,471. The final risk is 1 in 74. And why? Because NT is 2.4 mom. NT is very high because NT is 4.1. Right? HCG is 59, is 1.37, and then PAPA is 0.67. Now, what did we say? Any NT more than 3.5, you will always get a screen positive result, irrespective of anything. So there is no point in going through screening. Go for direct testing, right? So an increased NT, you don't need to screen at all. So when there is an increased NT, do definitive testing, because if your NT is 3.5 to 4.4, the 21% will have chromosomal defects and major fetal anomalies in 10%. So you better go and do a direct testing. You could have any of the structural abnormalities. So better to do CVS or amnio. So the next case, age risk is 1 in 85, which means she must be around 39 to 40 years old, right? And see, prior risk itself is very high, and you are using an NT of 2.4, 1.5 bomb, 1.6, and HCG of 2.7 bomb. So it has gone up from 1. So her risk went from 1 in 85 to 1 in 139. That means she lowered the risk. By doing this, she lowered the risk, but she's still under 250, greater than 250. So why? For her, if they did not want to do an invasive testing, a better test would have been NIPT. NIPT would have been a better test because sensitivity is very, very high for this case, right? So that's the reason. So the message is age greater than 42 years, biochemical screening has poor sensitivity, baseline risk is very high. You can do NIPT or you can go a direct testing. Okay. So when there is a high HCG in any screening test, 7 mom, 6 mom, 5 mom, like that, you look at certain things. Whether the mother has had HCG injection within 1 week, right? Second is sample collection. You've taken the sample on Friday evening, you kept it on the table because the courier did not come, and you sent it on Monday morning. This HCG will just increase like anything in this sample. So sample must be refrigerated at all times and cold chain must be maintained. Or there could be placental pathology. Now let's go to the next case. The age risk is 1 in 1,507. The final risk is 1 in 5. Now 1 in 5, why? Because HCG is 4.2 mom. NT is absolutely normal. Nasal bone is absent. You can see absent nasal bone. So the risk has gone up to 1 in 5. So unossified nasal bone and higher HCG can also cause this screen positive. So this is the case 5 where you can see HCG is 0.63 mom, PAPA is 0.4 mom, NT is 0.9 mom, T21 by age is 547. Final risk is 1 in 327. Even though all these parameters are within normal limits, right? PAPA is a little low, but HCG is okay and NT is absolutely fine. Okay, so NB is absent. So nasal bone is absent. So this is called as borderline risk because you are close to 250. So supposing somebody has 252, the screen will say low risk, but 250 is the cutoff. So it is not like night and day. It is not like it is you draw a line and say today you are low risk, tomorrow you are high risk. If you have 250, you are high risk. If you have 251, you are low risk. It cannot happen like that. because it's a biological measurement. So these are called borderline risk, and that's why we give it a new terminology called intermediate risk. So one, you say high risk, and that is my own arbitrary cutoff. I can have it as 100, 250. The patient can themselves say, doctor, 1 in 1,000 is too high a risk for me. I want invasive testing. So we have to offer it. The patient, we have had patients with 1 in 10,000 who wanted an invasive testing. But we tell them, but the chance of losing the baby because of the amniocentesis may be higher. If they're still willing, want to do that, you please go ahead and do that. Not a problem, right? So this is the word cutoff is a very variable thing. Now what next? 4 to 5% per fetuses with intermediate risk have trisomy 21. The options are you can look for markers, genetic sonogram, non-invasive screening can still be offered, or definitive testing. And this patient opted for routine follow-up. We did a genetic sonogram. And then they said, okay, we are quite reassured. We don't want anything. Now the next case is first trimester screening was done, where T21 very low risk, all of them were low risk. Patient reviews with the above results. What do you want? Well, so he says, okay, all the parameters seem to be fine. You come back at 19 weeks with, we'll do the uterine artery Dopplers and routine. And then at 19 weeks he comes and you look at a clenched fist, there's a cardiac anomaly, there's choroid plexus, absence of corpus callosum, huge number of anomalies are present in the second trimester. So this patient needs invasive testing. But if you look at the biochemical values, HCG is 0.3, PAPE is 0.1, but the risks were low. So if you just look at the risks alone, you will pass it off as normal. But when you say, oh, HCG and PAPE are very low, when both HCG and PAPE are very low, this is a pointer for trisomy 18. So I will go and look for trisomy 18. Maybe it is not, the anomalies have not evolved. I look at you, come for early target scan at 16 weeks, and then you find all this. So that is the importance of actually going and looking at the individual markers, not the risk alone, right? Now here's a case number 6, where the nasal bone is seen, NT 1.4, DV normal, no tricuspid regurgitation. She is assisted conception, 39 years old, and then we can do either combined test, non-invasive screening, or direct test, which is preferable. Let's look at what it came. The beta HCG 1.4 mom, PAPE 2.2, the NT was 1.1, age risk is 164, post risk 1 in 6,500. The patient was very, very apprehensive. They said, doesn't matter, doctor, 6,500 also doesn't matter. I will go for NIS. Now she could have chosen NIS right at the beginning, right? But she said, okay, now I'll do NIS. We did non-invasive screening and it came as positive. It came as positive, right? 17, 18 weeks review scan, minimal ventriculomegaly, karyotype was done, trisomy 21. What was her T21 risk? 1 in 6,500. So this is a classical example to tell you, whatever you are giving is only probability. With the screening, it is not yes or no. Some cases of Down syndrome will be missed, right? This patient, something was telling her she wanted NIS, and then it was done that way. So the message is false positive and false negatives can occur. So pre-test counseling is important. Markers can evolve in even later gestation. Screen negative with evolving markers, review the screening and recounsel. Avoid second trimester screening in women with advanced maternal age. 40 years, don't go and do second trimester quadruple screening. Go for the highest test as necessary. So the next case is a case where nasal bone was anossified, NT 2.1, no A-wave reversal, but tricuspid regurgitation was present. Look at all the thing here. Nasal bone is a powerful marker. Tricuspid regurgitation was present. Of course, ductus venosus was normal, NT was 2.1. So this case, age risk was 1 in 480, drown risk was 1 in 14, just using the soft markers alone. And then karyotype, Ultrasound is the first level screening. Multiple markers, high risk, then it turned out to be Down syndrome. This was just a screening. You can see obviously a very high nuchal, 4, right? And the karyotype showed a 21-21 translocation. Now, this is something which you may not find out on screening, because it's important to find out on the karyotype 21-21 translocation, because we have to screen the parents and she has a chance of getting the same thing every pregnancy. So we need to look at it. So ultimately, even if it is Down syndrome, we need to look at the karyotype. Make sure it's not translocation 21-20. If it's translocation, counseling for next pregnancy becomes very, very different. So when you find one marker, look for other markers. When multiple markers are present, option of screening can be provided. However, it will be prudent to counsel the patient on the need for direct testing. And karyotype is essential because it helps us to predict recurrence. Right. So this is a first baby which is Down syndrome. Okay, she comes pure trisomy 21, and she comes for current pregnancy at 12 to 13 weeks. So what are the options? The patient most patients will want direct testing to be done. This patient opted for non-invasive testing. The NIS failed. They said low fetal fraction, not available. So repeat NIS or amniocentesis. The patient said, I want a repeat NIS. So she wanted a repeat NIS. So repeat NIS also failed. So low fetal fraction. So we are losing almost 10 to 12 days between all these tests. So finally, patient said, okay, I'll go through amniocentesis, and luckily it turned out to be normal. So inconclusive non-invasive screening. So the result comes as inconclusive. Then what do you do? It happens in high BMI, low fetal fraction, certain aneuploidies like 13, 18 and triploidy, as we said, interfering factors, large tumors, maternal malignancy can be there, and the best option here is to do amniocentesis. So then we have fetus with exome flows and partial herniation of the stomach. Somebody had done an NIPT. So when you have an exome flows, there is no need for doing screening. You go and do direct testing. At 15 weeks, the patient was referred for the same. There was a large omphalocele, there was a cardiac anomaly, and never do NIS before anatomical evaluation at 12 to 13 weeks. There are some countries where they do NIS at 9 to 10 weeks. Okay, but we don't need to hurry. We can wait till about 12 to 13 weeks, do a detailed anatomical evaluation, and then offer NIS. So here's a patient who had the result was final risk was 1 in 472, and we find that the HCG beta, free beta HCG was 2 mom, NT was 1.9 mom, and PAPE was 1.1 mom. So she went through NIS, and everything was very, very low risk, right? So, but here you can see here, T18, 13, 21 were low risk. When you come to sex chromosome aneuploidy, XO was detected. So this PAPE was normal, HCG alone was high. So what did we say in Turner syndrome? HCG will be high, PAPE will be normal, no change in the, that's what we said. So this baby had XO detected. And so NIS provides information on sex chromosome aneuploidies. Pre-test counseling must include the showing patient sample report, what to expect the results and what it is liable for. So karyotyping was done from the NIS, but karyotyping turned out to be normal. Okay, so there was an increased risk for sex chromosome aneuploidies, which turned out to be normal. Right. So that's the last one, I think two cases, I think. Current pregnancy. So this patient has FTA screen negative. She has had a third pregnancy child diagnosed with SMA, spinal muscular atrophy, and fourth pregnancy baby was unaffected and doing well. She has come at 12 to 13 weeks. They have done first trimester screening. Now for this patient, they did also NIPT. But what is the mother's question? It is not Down syndrome. Mother wants to know whether my baby has SMA. So we have completely missed the bus, spending huge amount of money on NIPT and first trimester screening. And we had to recounsel them and says, in spite of all this, you still have to go for amniocentesis. And the DNA analysis showed the presence of S7 and 8S7 on gene, fetus unaffected. So please avoid NIPT for a disorder for which you already know a genetic disorder is present. Right. Now, this patient was referred for CVS because T21 risk was 1 in 200. Maternal weight was 56 kg. NIPT was done at 13 weeks, negative for trisomy 21, but positive for trisomy 18. Right. So, at 15 weeks, we found growth normal, Doppler normal, anatomically normal. So, can we have trisomy 18 baby with an absolutely normal ultrasound? That is the question. Because for our T21 risk is low, T18 risk is high. Right. So, with the NIPT positive, no CVS and amniocentesis was preferred. Structurally normal fetus, unlikely to be trisomy 13. A good anatomical scan and reassurance can be given. So, in cases where you know that trisomy 13 risk is very high, there will be no case on earth reported where trisomy 13 baby has had a normal anatomical ultrasound. So we can use that as a good test. But even if there's a simple anomaly, we still go ahead and go to the testing. Right. So this patient had a T21 final risk of 1 in 644, PAPE 1.38, 1.38, and BCRC 1. So everything is, this is called a screen negative. Nasal bone risk was not looked at. So when they came to the second trimester, found nasal bone was absent. So suddenly all hell broke loose and says, oh, they didn't include nasal bone in the first trimester screening. Now nasal bone is absent. So what should we do now? So should you recalculate the risk with second trimester absent nasal bone LR, any other major markers? And if you do the recalculation, this has gone from screen negative to screen positive. So sometimes it happens. It all depends on what. So when you have one marker, obviously this person must have had absent nasal bone in the first trimester. So that was missed. Okay, it was not included. But in your protocol, if you are not using nasal bone at all, then you are in a fix. So when you come to the second trimester, nasal bone is also as absent nasal bone second trimester marker. Use it as a second trimester marker. Calculate so we call it as contingent screening. So first trimester screen result, add the NB in the second trimester, get the final result and act on it. So a few cases of twins. So this patient came for FTS monoclonic twin, right? CRL both. What do you do? Age plus NT or age plus combined test or NIPT. So we prefer age plus combined test to do in the beginning, or you can do NIPT also, because monoclonal twins are monozygotic, identical. So the fetal fraction appears to applies to both. So you can do that very easily. And then, right. So wait, sorry. So in monoclonic twin, remember the risk is always a single risk which is given. The result, if you get a result from a lab, when you have said monoclonic twins, they give you twin A and twin B, then please change that lab, because they don't know how to do. Monoclonic twins means only single risk for the pregnancy. Second is, here's a patient who came with embryo transfer at 12 weeks, referred for FTS. There's a small fetus, 7 mm. Fetus FH was absent, and the other one FH was present, and baby had a no NT and all. So what is the best screening method? Age plus NT, combined test or NIPT. Age plus nuchal translucency alone. No combined test, no NIPT. Right. Now, here you can see the risk estimate plus NT, 1 in 3,592. Because the nasal bone is present, then the risk goes to 1 in 11,973. So using nasal bone and NT in the first trimester. So you resort to the soft markers, push them, because that's the only thing you have. You can't do biochemistry in these patients. Right. Then here is a monoclonic twin, obviously. and one baby has anossified nasal bone, the other baby also has anossified nasal bone and tricuspid regurgitation in an MCDA twin. Fetus A and fetus B, both U and B, and one has a tricuspid regurgitation. The options are combined test or direct amniocentesis. So we offered amniocentesis because strong markers are there. Patient opted to review at 16 weeks. 16 weeks anossified nasal bone for both, but the fetuses were concordant. So the patient then went for invasive testing, and then we found chromosome 21 was detected in prenatal BOBs. So two powerful markers were there, right? So here is a dichorionic twin, a DCDA twin, one placenta anterior, one placenta posterior, right? So in a DCDA twin, this is fetus A NT 2.5 and fetus B NT 3.8 and B anossified. So, and ductus venosus reversal. So this baby has got everything loaded, all three markers. So this most likely the baby will be having trisomy 21. So fetus A discordant for nuchal translucency. And so what do we do here? Both fetuses have different risks. Baby A has different risk, baby B has different risk because they are two individual babies. And option for CVS for B, karyotype and prenatal BOBs, or CVS for both. Because we definitely know this baby is going to have problem. But can you definitely say that baby does not have T21? But there is one caveat here. It is very highly unlikely that in a dichorionic twin, both babies will have chromosomal abnormality. That probability is 1 in 90,000. So it's very unusual to have dizygotic twin with both having chromosomal abnormality, right? Right. So if this abnormal, we can do selective fetal reduction because of DCDA twin. Okay, I think this is the last one. The final plan was CVS sample for both twins, simultaneously do the following investigation: prenatal BOBs and karyotype. So let's move. I don't think you want to see the CVS sample. So 5 days later, after doing CVS for both, fetus B increased anossified nasal bone, trisomy 21 was detected, right? And this was 16 weeks for fetus B. And then fetal reduction was done, selective fetal reduction was done. And then, so the key message here, screen early, ultrasound markers, you differentiate. If testing is needed, CVS or testing both is preferable. MCDA twins, amniocentesis is preferable to CVS. So thank you very much for a patient listening. I hope I have not overshot my time.
Thank you so much, sir. Your talk was truly informative. So there are some questions for you
Yes.
in the Q&A chat box, sir.
Yes, 1 minute. I'll just check it out.
Yes, sir.
Q&A chat box. Yes. Yes. If a patient is high risk in screening test, but you don't want to do invasive testing, how to proceed further? Well, that is counseling. Pre-test counseling is if you do a screening test, if it's high risk, the next choice is to do an invasive testing. If the patient does not want invasive testing, please document it as saying recommended invasive testing, but the patient has declined. This is only to save you legally later on, right? Because you cannot decide for the patient, it's for them. If quad screen to be done, which gestation is the best? Is it sensitive in the presence of DM IVF? Yes. So quadruple screening is done. If you want to save time, then you can do first trimester quadruple screening. Okay, that gives you the same result. As regards diabetes and IVF, there are correction factors which needs to be employed. Definitely in diabetes, the HCG will be a little higher. So we need to take care of that. Now, can microarray be done instead of karyotyping? Yes, microarray. So I will not do microarray when there is a biochemical abnormality. Microarray will be done when there is an increased NT. Okay, but microarray also, there are different types of microarray, which is a low resolution, high resolution. You need to be careful, because does it give you more? It will give you a little bit more than the karyotype. Your predental bobs is also an option, which will give you 7 microdeletions, which are the most common. Okay, I can thank you. Sorry, in case can PAPE be higher in Down syndrome? Well, see, generally what we say as a marker, PAPE is low in Down syndrome and HCG is high. Now there may be a case where the baby can have high NT and a lower PAPE, a higher PAPE, and HCG can be normal. So any combination is possible. It all depends on how that particular placenta functions. Okay, I think I've answered all the questions.
Sir, thank you, sir. Your talk was indeed very informative and insightful. So I'm sure everybody listening has benefited a lot from your talk, sir. We are
Thank
truly
you.
indebted to you, sir. Thank you.
Thank you. Bye.
Bye, sir. Now we will take a short coffee break and resume at 11:30 sharp. Thank you, everyone. I hope everyone is refreshed after the short coffee break that we had. Now we will continue our workshop. Our next speaker is Dr. Pratima Radhakrishnan ma'am, who will be speaking on the topic second trimester anomaly scan and its implications. Pratima Radhakrishnan ma'am is the director of Bangalore Fetal Medicine Center. She is the ISUOG ambassador in India for the year 2021 to 23. She is the first to perform therapeutic fetoscopic laser in India. Ma'am's special interests are fetal diagnosis and therapy, fetal screening strategies, early fetal diagnosis. Ma'am has successfully performed advanced fetal invasive procedures and pioneered first trimester screening and diagnosis in India. Ma'am is FMF UK accredited trainer for various certification courses by FMF. Ma'am, thank you for taking some time out of your busy schedule for us.
Thank you very much, Doctor. Sorry, I don't have your name. I'm really sorry. Thank you. Can I share my screen, please?
Yes, ma'am. You can go ahead and share your screen now.
So that's visible, I would think.
It is visible.
Okay, right. So having gone through the first trimester scan and the screening strategies, and which was very elegant lectures by my colleagues, Dr. Chinmay and Dr. Suresh, we're now going to move on to the second trimester anomaly scan and its implications. And we have really tried to cram a lot of things in this one-day program, and it would be quite challenging to cover any of these topics, even in 2 full days, to be very honest. And to cram it in one day is really, trying to do things to just give more a perspective rather than giving details of everything. Okay, so let's move on to the second trimester scan. And we know that the aim of antenatal screening is to be able to reduce reduce perinatal mortality, morbidity by diagnosing congenital anomalies and problems with placental insufficiency, and of course reduce the preterm delivery and prematurity associated problems. Now, the second trimester scan, the purpose is the main diagnostic tool. Ultrasound is indeed the main diagnostic tool, and it detects major and minor abnormalities. And of course, majority of the anomalies do occur in low-risk population, so-called, where we do not expect things to happen. And therefore, it is extremely important to offer the second trimester ultrasound scan to all pregnant moms. It's absolutely vital. The aim is to provide accurate information in order to optimize antenatal care. And of course, as we always aim for best outcomes for the mother and the baby. And pretty much everything is directed towards that, even in the second trimester. Now, we determine the gestational age, but we also know that the best time to date the pregnancy is in the first trimester. We perform fetal measurements and evaluate the presence or absence of the heartbeat, the number of fetus. If it is multiple pregnancy, determine the chorionicity, but already, as we already know, the chorionicity is best determined in the first trimester. We look at the fetal size, fetal age, look at the basic fetal anatomy, look at the placenta, look at the appearances and the location, of course. We know majority of the anomalies can be detected at this scan. However, some anomalies can still be missed. This may be because of inadequate visualization, or it could be some evolving anomalies that could present not in the second trimester, but much later on in the in the pregnancy. And therefore, it is very important for us who are performing the second trimester anomaly scan to be aware of what are the abnormalities that would present later on, and not not everything can be detected in the second trimester itself. Now, the best time to perform a second trimester anomaly scan is defined as 18 to 22 weeks because you have fluid all around the baby. You can see much better. Technically, it's a lot much easier. And most of the abnormalities are already formed by this time. And therefore, and of course, majority of the studies are also performed at this time to check for the abnormalities. Now, in India, of course, because of the law of the land, we do it at 18 to 19 weeks. And I personally feel it is still important to stick to this, although the termination of pregnancy law is going to be changed very, very soon. It's already in process up to 24 weeks. Why? Because one is we have gotten used to it and we really can see the baby very well at 18, 19 weeks. And the extra 4 weeks that we get can help us to evaluate the pregnancy properly before terminating the pregnancy. Because if we do not evaluate the pregnancy properly in the presence of an abnormality, then we might end up end up terminating many babies that have potential to be normal. Right? And we know this is a major problem in our country. So I would personally feel it is better to stick to 18 to 19 weeks and not shift our anomaly scan also to later because the termination law is shifted. Of course, when it is necessary, it is important to repeat the scan. And of course, remember the cervical screening and uterine artery Doppler prediction is better at 22 to 24 weeks, but still reasonably good even at 18, 19 weeks because we can see more data coming out with that. Now, it's not rocket science to say who should perform the second trimester ultrasound. Of course, before performing a second trimester ultrasound, whoever you are, whether you're an obstetrician, radiologist, or whatever, any doctor who's qualified to perform a second trimester ultrasound scan must be trained in the use of diagnostic ultrasound and, of course, the safety issues. They must be regularly performing fetal ultrasound scans so that you develop competency as you do more and more. You participate in continuing medical education activities so that there is a whole lot of updates that is available almost on a monthly basis. And therefore, it's very important for us to be up to date by participating in the on-site and online education activities. And now I think in the last 1 year, we've all become experts in online education activities as well. And as you can see, a lot can be achieved from that. And we must have proper established referral patterns for suspicious abnormal findings. Now, everybody cannot be an expert, and it takes time to become an expert of whatever level that you are saying. So, especially in the initial 5-10 years, it's very important to have good patterns of referral or discussion groups, be part of discussion groups where you can discuss your abnormalities and refer timely. And this is the way of learning on the go, and that is important for every one of us. And of course, it is important to keep checking how well you are performing on a regular basis by proper audit and control measures as well. Now, it is very important to do a proper or an optimal scan, to have the proper equipment. You have your abdominal transducers, you have good ultrasound machines with good acoustic power out controls and output displays. We need to have freeze frame capabilities. Electronic calipers is very important. Capacity to print and store images is very important, and then shift to hard disk, etc. And regular maintenance and servicing. So this is very important because a lot of people use suboptimal ultrasound machines. Although they may be very skilled, you cannot compensate your skills with a suboptimal machine, and vice versa. You may have the best machine, but if you're not skilled enough, you may still not be able to perform a good scan. And if you have the if you do not have an optimal machine, but you have extremely good skills, to some extent you may compensate. But if you can't see certain parts of the fetal body, you cannot see it. I mean, you may be very good and you may be looking for it. If you don't get optimal images, you don't get optimal images. And there is really very little you can do to change the maternal habitus, of course, right? So your machine should be optimal to be able to perform in all variety of ranges of BMIs. And of course, you have to have proper settings. that documents to be produced. It's very important when you have a detailed report, you have your findings, your diagnosis, summary, recommendation, you put your relevant images, you stored your images, and of course there is a rule to define time period for storing of images, and it's very important to do that. And of course there is absolutely no going back on, no compromises that can be done on the PCP-NDT requirements, and those who are performing any fetal scan for that matter must be completely aware of the state jurisdiction, because it can vary from state to state and district to district also. So very important that you are in touch with touch and up to date also with the local PCP-NDT requirements. Right now, this is a very often asked question: is it safe? Of course, it is safe, and there is no study so far that have indicated a derogatory or a bad side effect of ultrasound scans. And importantly, one as a responsible clinician, it's very important to you to minimize the fetal exposure times and use the ALARA principle for diagnostic information as much as possible. Now, there will be certain situations where you will not be able to complete the scan, and therefore it is very important to document the reasons why it has not been completed and repeat the scan at a later date as soon as possible. Now, it may be that you could not see the heart because of the fetal position or the spine because of the fetal position. So you don't really need to wait for 1 month for that. You can bring them back, within a couple of days and then complete the scan. However, sometimes, the visualization, the overall visualization is very difficult. And you know that unless the baby gets a little bit bigger, you may not be able to see. In that case, you may want to wait for 3 to 4 weeks and repeat the scan. Right? And if required, if you think that it is to do with your equipment, or if it's to do with your scanning skills, or if you're in doubt, it is better to refer the mother sooner rather than later and not wait for weeks together. And it has not been unusual that if there has been a suspicion or if you have not visualized the cardia properly, and this is one of the commonest indications that I see, cardia not visualized properly, rescan after 4 weeks, and after 4 weeks there is a major cardiac abnormality. You did not visualize the cardia properly because there was a cardiac abnormality, and that is very likely, and therefore it is important that you refer the mother sooner rather than later. And of course, there is no doubt this will reduce the parental anxiety as well. Right? Now, coming to the second trimester scan, there are guidelines available. There is also the the SFM guidelines in India, the FOXI guidelines. There is ISOORG and Fetal Medicine Foundation. These are the most largely followed guidelines across the world, and pretty much all the guidelines are almost the same when it comes to visualization of the scan. Visualization of the fetus. Okay. Now, when you're looking at the second trimester scan, we start with the anatomical survey. It's very important to look at the presentation. How is the baby lying? The attitude of the baby, and that will tell us that will help us to determine the situs. And of course, there are various ways to determine the situs, but what I find very useful is to look at the look at the way the baby is lying on the maternal abdomen and imagine a baby lying there and do the situs. Okay. Now, that also confirm, of course, the viability of the heart fetus, and it is important to make the mother hear the heartbeat. Now, amniotic fluid, generally, if you see all these black space all around the baby, pretty much you can say the amniotic fluid is normal, and majority of the time at this stage, it is a subjective evaluation rather than an objective evaluation. However, if you feel that the amniotic fluid is more or less subjectively, then it is very important to measure the 4-quadrant amniotic fluid index. Okay. Now, followed by the placenta. It's good to measure the placental distance from the cervical canal and look at the bladder and check the umbilical cord vessels. And at the umbilical cord, you see the umbilical artery vessels, umbilical arteries abutting the bladder from both sides, and you're making sure that it is coming out. So this confirms two things, that there is a bladder and there is two umbilical arteries. And of course, there's always a single vein. Now, coming to the fetal biometry and well-being, we are the 4 important measurements which confirm the gestational age and fetal size at this stage are the BPD, HC, AC, and FL. Of course, dating is ideal before 14 weeks, but we don't live in an ideal world, and there will be some people who will come late and or the first trimester dating has not been correct and or suboptimal, in which case the best way is to take composite biometry and preferably repeat it after 3 to 4 weeks, because that will tell us uh, 3 to 4 weeks, because that will tell us that the baby is growing properly and your dating is correct. So if you are dating in the second trimester, it's better to use 2 scans 3 to 4 weeks apart to date the pregnancy and use all the biometry to date the pregnancy rather than just going with one biometry. If you have discrepancy, for example, if the BPDHC is on the 5th centile, but the AC and FL are on the 50th centile, then definitely you will skew up your dating miserably. And on the other hand, if you have a small AC or a big AC or a short female length which is on the lower side, then again it can skew up your measurements, and therefore it is important to take a composite biometry for dating rather than using just one measurement. Okay, now head brain, again, there are 2 important from the Fetal Medicine Foundation. ISOAG uses 3, some people use 3, but there's again no harm. Whatever you use it properly. I personally use only the 2 measurements, the transventricular and transcerebellar planes. And let's look at the transventricular plane. It's in the axial plane at the level of the cavum septum pellucidum. Here you measure the BPD, which is usually out to out. And when you measure the OFT also, which is out to out, the computer calculates, or even the machine would calculate the head circumference. You look at the lateral cerebral ventricles and you measure the lateral cerebral ventricle. And of course, you look at the cephalic index ratio as well. Now, looking at the other ventricle is always a good practice, where you just tilt the probe slightly, you dip the probe, tilt the probe slightly, and then you will be able to measure, because in this view, you don't actually see the lateral walls, although you can kind of make a guess. You can see the medial wall and lateral wall of the lateral ventricles. You don't see it clearly. So you need to tilt your probe slightly and at least glance it and make sure that it is not enlarged. And if you put a measurement to it, always good, because anything you put a measurement to it, it tells you surely that you have seen it in the view that is required. Now, as you're looking at the transventricular anatomy, you're looking at the anatomy, you're looking at the cranial continuity, you're making sure that there is no gaps. Normally you would see a gap there, that's the parietal suture. The continuous midline falx is very important to see. In the anterior 1/3 and the posterior 2/3, you see this rectangular shape, which is the cavum septum pellucidum, which is longer than wider, right? So it is longer, wider. Okay, and of course you look at the symmetry of the ventricle, that's both sides are symmetrical. You're looking at the sylvian fissure, which generally at the mid trimester is more flattened, and you look at the parieto-occipital fissure, which usually just a little bump there, and that's where you're measuring your lateral ventricle as well. Okay, now in the transcerebellar diameter, again it's a transverse view at the level of the cavum septum pellucidum, but you dip the probe slightly posteriorly, going caudally, and that's where you will see your posterior fossa. So you have to continue to see your cavum septum pellucidum. You're seeing the thalamus, and then you're seeing the dumbbell-shaped cerebellum. You're looking at the cisterna magna, and you're measuring the nuchal fold. So your dumbbell-shaped cerebellum, you're measuring it out to out. Your cisterna magna is a cystic space, so you're measuring it from the outer border of the cerebellum to the inner border of the occipital bone. And again, nuchal fold, you're measuring from the outer border of the occipital bone to the outer border of the skin, so you're measuring the nuchal fold thickness. So you take all these 3 measurements in this view itself. Okay. Now, as you're doing this, you're looking at, again, the cranial continuity, but remember, there will be, when you're looking at that, there will be some normal breaks in the continuity. There's nothing wrong in that. You're looking at the midline falx, and you're making sure that that's completely connected. You're looking at the contour of the CSP. You're looking at the symmetry of the cerebellar hemispheres. Looking at the cisterna magna, that there is no gaps and nuchal fold thickness. Now, when you're doing the transcerebellar diameter, it's important to just go a little bit, few millimeters down for a few, and ensure that the vermis is there as well, because it's vermis, and then you get the brainstem. So I'm sorry, I don't have a video of that here, but just very slightly you go down, and then you will make sure that there is no gaps there, and that is very important. Now, coming to the abnormalities of the brain, there's some very important, and I'm sure Chinmay has gone through these abnormalities in the first trimester that must be detected. However, there will be times where you have missed out the first trimester scan, and therefore they end up in the second trimester. So acrania is anencephaly is a complete absence of the skull. The holoprosencephaly is where you don't see the midline well, and there's a discontinuity in the midline, and therefore it could be a semilobar, which are usually seen, semilobar and lobar holoprosencephaly, which are seen in the second trimester. You can again have, discontinuity of the occipital bone, or anywhere, in fact, for that matter, where the brain matter is herniating outside, and that disrupts the brain, of course, and that is an encephalocele. And again, these are abnormalities that must ideally be picked up in the first trimester, but sometimes, they land up in the second trimester as well. There is the stargazing appearance, where the baby is continuously looking up because of the fusion of the cervical vertebra, and that is an ineancephaly. Now, the other things that can be seen in the second trimester is absence of the cavum septum pellucidum. So you're trying to locate this box, and you're seeing these multiple lines, and here in this particular case, the ventricles appear normal. Sometimes you can have ventriculomegaly associated with it as well. Now, this obviously is not the cavum septum pellucidum, because I told you it should be seen in the anterior 1/3 and the posterior 2/3 at that junction of the scan. So it's very important to do not only axial views, look at all the take all the axial views, look at the ventricles, look at the posterior fossa, and then go to the sagittal view of the fetus. And if you have 3D imaging on your machine, I find 3D rendering with OmniView quite useful in these circumstances. And then especially for the cavum septum pellucidum or corpus callosum, and for the vermis as well. And occasionally you may have to use MRI as well, because there are certain genetic syndromes like the SOD, the septo-optic dysplasia, where you may not be able to see the optic nerves and the optic chiasma at this stage. So if you suspect or if you see absence of agenesis of corpus callosum, it's very important to do a detailed fetal brain scan, take additional views, consider doing a transvaginal scan and 3D imaging. A proper neurosonogram is very important, and sometimes you may need to take the help of MRI as well to be able to decipher the anatomy correctly. And because it can be associated with chromosomal and genetic disorders. Now, coming to the cerebral ventricles, now something like that is very obvious on the ultrasound scan, because you've got huge ventricles, which is more than, severe is defined as more than 15 millimeters, 10 to 15 is defined as mild. Now, if you have this kind of ventricles, then that obviously you know that is not a good thing. You look at all the other ventricles, you look for the third ventricle, you look at the posterior fossa, look at those abnormalities there as well. And of course, here, it's just the ventricle. You have got some part of the corpus callosum that you can view. So again, very important to do a detailed neurosonogram. And coming to the mild ventriculomegaly, where there's just a little bit of increase in the ventricles, again, important to get the look at the rest of the intracranial anatomy, because it would matter, get sagittal views, and here you can see the corpus callosum nicely there in the sagittal view, and of course, and then act accordingly. So why mild ventriculomegaly can be associated with. So it is a soft marker. About 4% of babies with mild ventriculomegaly can have chromosomal abnormalities. It can be associated with fetal infections and intracranial intracranial abnormalities, and therefore follow-up for these pregnancies is very important. Mild ventriculomegaly, if it is isolated in the absence of all these things, then the outcome for these babies are much better. However, the challenge is to exclude the other abnormalities, which can, and plenty of studies have been done, which have shown that even postnatally they have detected abnormalities. So very important to counsel these patients very well, particularly when it is between 10 and 12 millimeters. Majority of these babies will be normal, but once they go past 12, if it is progressive or if it is associated with other structural abnormalities, then the outcome can be much worse. And very, very important, must not forget in these situations to check the spine, because your original problem could be lying in the spine, where there is a spina bifida, and therefore you have these changes in the brain as well. Now, coming to the posterior fossa abnormalities. Now, posterior fossa, you're seeing the, for example, here you're seeing the cerebellum dumbbell shaped very well. And as I said, just go a little bit below there, because there you see a gap there, and then you want to see what could this be. Now, posterior fossa cyst could be, something simple as a Blake's pouch cyst, or it could with and without a vermiogenesis, and of course a very bad one, which is the Dandy-Walker malformations. Therefore, it is very important for you to check for check it in the sagittal views as well. Do a transvaginal scan, do a neurosonogram, use 3D rendering to check for the additional the corpus callosum, and here you can see a nice vermis. So, and just the vermis has been pushed up, and this is very likely a Blake's pouch cyst. And the outcome for Blake's pouch cyst, again, isolated Blake's pouch cyst, once you've excluded chromosomal and genetic problems, outcomes are good. Sometimes you may need to take help of an MRI. And however, if you do a good neurosonogram, realistically, majority of the times you don't need an MRI. But and the most important thing about MRI is that the person who's performing the MRI, or the person who's reading, the doctors who are reading the MRI, should also be very familiar with fetal anatomy and fetal scans, because then only you can have a valuable fetal MRI done. Okay, now moving on to the face. Again, face, very, very important structure. It is one of the most favorite structures for the parents. You can see two eye sockets very well. Just go down, again, axial views, go down, you see the hard palate, the bony part of the palate. Really, the soft palate is a challenge to see. You may be able to use 3D rendering, but it's not part of a routine scan. And of course, the profile, which is again one of the most favorite images for the parents. Important to look at the soft tissue, that is the lips, the nostrils, two little nostrils, the lips, and then once you come side by side of, come sagittally, you will be able to see the ears as well. And yeah, I mean, many times you can see at least one ear. Sometimes you may be able to see both the ears, particularly when the baby is looking directly down. Both the ears, just moving your probe from side to side, you will be able to see the ears. And if, again, it's not absolutely mandatory to measure the ears, but if you measure something, you have seen it properly. And to me, that is very, very important because it authenticates that you have seen it. And one would argue that, one missing ear, is it a big deal? Of course, it's not a lethal problem, but these are things that is very obvious to parents as soon as the child is born and causes a lot of distress. And therefore, it's no harm doing a little bit extra than what is recommended in the guidelines, right? So, and if you're used to it, and and it's not very difficult, you just do it, and then as you do more and more, you become experts in that as well. And very importantly, as my geneticist always says, the ears is one of the leading clues to diagnosis of fetal genetic abnormalities, because many genetic abnormalities will have ear abnormalities as well. Now, abnormal facial profiles is again one of the most frequently seen abnormalities that is picked up. And there are a lot of discussions which go on fetal profile. And fetal profile is very important because also that is not only gives you clues to many genetic syndromes, but also to facial hypoplasia, etc., things like that. So if you see abnormal facial profile, it's very important to look at rest of the structures and come back and assess the baby thoroughly, to particularly for genetic syndromes as well. Okay, now orbit abnormalities, what you're looking at the size of the orbits, and you should be able to fit in one orbit. So 1/3, 1/3, 1/3 is how it is divided. Here you can clearly see that the orbits are spread across. There is hypertelorism, and the orbits also appear smaller than usual. So, and when we did a 3D rendering, that you saw that clearly there was an abnormality of the orbits as well. Now, again, something that can be quite distressing on at birth for many of these parents, and therefore looking and documenting good orbits is very important. Now, this is another fetus where we could not see the orbits at all, complete absence of the orbits. Right now, this is not something that we should be looking in the second trimester, because orbits is something that you see in the first trimester as well. But again, microphthalmia can develop later on also, and therefore it's not necessary that all of the absence of orbits can be picked up in the second trimester only. Okay. Coming to the thorax. Thorax is seen in the heart view itself. You can do axial, and of course, good to have a quick look sagittally as well, because that helps you to decipher the diaphragm and the lungs also. So the cross section of the baby's chest is divided into 3 sections, and 1/3, 1/3, 1/3. So you have got 2 lungs and a heart, and the entire thing occupies entire thing occupies the chest. And as you can see, the echogenicity of the lungs is less than the bone which is right next to it, and they are pretty much pretty much similar all across, and all resembles the liver to a large extent. And when you look at the sagittal images, then you can clearly see the diaphragm as well, and which has got a slight concavity down, and that is a normal view of the diaphragm. Sorry, a normal view of the thorax. Now you can sometimes see, lungs which are brighter, and here clearly that this side is brighter than this side, and because of that, the heart is pushed to the right. And one of the most common things is congenital pulmonary adenomatoid malformation of the lung, and there are 3 types. There is, microcystic, macrocystic, and mixed type. And mixed type seems to be the most commonest. It could affect unilateral, it could affect bilateral, or it could affect only it could affect one lung, or it could affect both the lungs, or it can affect only parts of the lung as well. Now, very importantly, when you're diagnosing a right-sided CPAM with the mediastinal shift to the left, as you can see, it is very important to exclude diaphragmatic hernia, because it can be very commonly confused or mistaken for CPAM and CDH. Right? And the right-sided CGH would have much different prognosis compared to a right-sided CPAM. A CPAM, we know, has generally a good prognosis, and therefore, you would encourage the parents to continue the pregnancy. Now, coming to, again, mediastinal shift. When there is a mediastinal shift, that is shift of the heart, important to make sure the cardia looks normal, the heart looks normal. And it is basically in this particular image, the heart is sitting on the right side, and that's the aorta, and the heart is shifted to the right, right? And that is either because of a pull or a push. Once you've excluded a cardiac abnormality, look at the other side there. So here there is echogenic lung on that side, and therefore the heart is pushed, but the cardia appears pretty much normal, and there is no compromise in the cardiac function either. Whereas on this side, you can see that the heart is pushed to the right, and this is mainly because there is a cystic structure there, and then there is an echogenic structure. So the liver and the stomach are in the chest, and therefore the heart is pushed to the right. And then, as you can see, there is the left chambers are compressed as well. Those many times the heart can be structurally normal, but there can be compression of the chambers of the heart in these situations. So of course, this is a congenital diaphragmatic hernia, and of course we know about 5 to 10% of babies with congenital diaphragmatic hernia could have chromosomal or genetic disorders, and therefore it is very important to exclude that, because that would obviously have implications for the future pregnancies. Okay, now with that we move to the heart, and I know there is a long lecture on the heart in the afternoon, so I'm really not going to spend too much time. Again, heart, the routine anomaly scan must be seen. You don't wait for a fetal echo, or a fetal echo is done in certain exceptional circumstances, but heart must be seen at every scan, in my opinion. And they are primarily the axial fuse, and now of course it's 7 planes right from the stomach, the 4 chambers, the LVOT, RVOT, three vessel trachea, and finally the right subclavian artery, because it's right on the top. And use color flow imaging, because this would help you to pick up a few more structural abnormalities. And any abnormality that anything which deviates from the normal must alert your alarm bells to say that, okay, could this be a cardiac abnormality? So very, very important to familiarize yourself with the cardiac anatomy, normal cardiac anatomy, because once you suspect cardiac abnormality, once you suspect in your normal planes, that's when you start making your diagnosis, a differential diagnosis, and then plan your management accordingly. So most common are septal defects, and again, very important to make sure that your septal, the atrioventricular septum, which atrioventricular septum is basically the right atrium which connects to the left ventricle, and that is the atrioventricular septum, because of the apical insertion of the tricuspid valve. You have this AVS, and the abnormality in there is about 1/3 of these babies, or rather 1 in 3 babies, as you can see here. 1 in 3 such babies will have a chromosomal abnormality, and therefore it's very important to karyotype these babies and find out so that it can be prognosticated well, right? And then followed, you can have again defect along the septum anywhere. It could be the perimembranous septum, or it could be the muscular part of the septum, and therefore it's important to ensure that the septum is continuous right through and through. And once you find a ventricular septal defect, whether it is perimembranous or muscular, it is important to go back and check out your screening and see if there is any possibility, look for possibility of chromosomal abnormalities. And if chromosomally this baby is normal and it is an absolutely isolated finding, then the prognosis may be actually pretty okay, because they can be surgically corrected as well. And opinion from the cardiologist would be helpful, and encourage the parents to and encouraging the parents to possibly continue this pregnancy. And diagnosis of VSD, very important to have at least minimum 2 views, apical, lateral, apical, basal. So a combination, there are many combinations. So it is very important to demonstrate the presence of the ventricular septal defect at the same point in multiple views, and then only call it ventricular septal defect, because otherwise there can be a lot more false positives, positive diagnosis of septal defects, ventricular septal defects. Okay. Now, coming to the chamber abnormalities, we have 4 chambers in the heart, and any chamber can be enlarged, or you can have a global cardiomegaly also. In this particular case, the right atrium is quite large, and therefore you will be wondering what is happening there. And most likely it is the tricuspid regurgitation. There is excess flow of blood into the right atrium, regurgitating from the right ventricle into the right atrium, which is causing the right atrial enlargement. Now, in this particular case, you've got again a huge ventricle. It's important to check what kind of what ventricle that is, and again, hypoplastic right, hypoplastic left ventricles can present like this. And here it appears to be the left ventricle. So you see the aorta, there is no branching there, this is a tricuspid artery, so you can see a right tiny little obliterated ventricle almost on the other side. Okay, right. Now, outflow tract abnormalities, many times a 4th chamber would look normal, but once you come to the 3-vessel trachea view, or the 3-vessel view, you can suddenly see there is abnormalities. In this particular case, the outflow tract that is coming out of the left ventricle is branching, and therefore and pulmonary artery and the right ventricle is coming forward. And in the 3-vessel view, you can see only the 2 vessels. This is the aorta, which is coming from the non-branching vessel, which is coming from the anterior ventricle. And in the 3-vessel, you're seeing only 2 vessels, that is the aorta and the superior vena cava. And that is transposition of great arteries. Now, other common outflow tract abnormality is a tetralogy of Fallot. In this particular case, you can see a deviation of the heart is almost at 90 degrees. The septum is at almost at 90 degrees to the axis. And then once you come up again, there is a discrepancy in the 3-vessel trachea view. And and the aorta is coming in from the center. There is a VSD, and the aorta is coming out of the center. And in the 3-vessel trachea view, you can see a small pulmonary artery. So again, it's important to look at all the planes of the heart and make sure that you're watching it properly, seeing it properly, so that you can suspect these abnormalities. It is not at all important to make your diagnosis in the first go, but it is very important to suspect your abnormalities, document your findings, and then work out the diagnosis slow and steady. So this is what I teach my students as well, that I do not want to hear the diagnosis. I want you to hear what are your findings, and to go systematically in the heart is really the key to it all. Otherwise, heart is probably one of the most easiest structures in the fetus to examine. Now, moving on. We're now going to talk about the abdominal wall and the stomach. Now, abdominal wall, simple, come down the stomach, slightly down the stomach, and you see the abdominal cord insertion in the baby. And very important to look at the cord inside the fetus and outside the fetus, and that the skin is touching that. So that you avoid missing out small exomphalos, and there's no echogenic structures inside the umbilical cord there, and therefore you know that this cord insertion is intact. And of course, this should be seen in the first trimester, but it should be redocumented in the second trimester as well. The stomach bubble, of course, you see the stomach and the portal vein, and and again single ribs on either side, the 3 dots of the spine. The stomach towards one side, it's not too posterior, it's not too medial, it's just in the left mid of the, slightly in the left posterior quadrant, and the portal vein concavity on the other side, and that ensures that you have measured. And of course, you would see the stomach bubble, and you would measure it out to out and out to out, and that's where you would measure the abdominal circumference as well. So gaps in the abdominal wall can be gastroschisis or can be exomphalos, and gastroschisis has no sac, whereas exomphalos has a sac. And of course, these have implications for chromosomal abnormalities, particularly the exomphalos, which can be associated with trisomy 18. And of course, it becomes a surgical challenge after birth in the presence of normal karyotype. Gastroschisis, generally the association of chromosomal abnormalities is low, but not no, right? So there's no harm ensuring that the baby has got a normal karyotype, even microarray maybe now, to ensure that before the pregnancy is continued, and then undergo surgery postnatally. I feel personally that any fetal abnormality should warrant checking the fetal chromosomes, primarily because it's more so if they're going to continue the pregnancy, because the last thing you want to have is a chromosomal or a genetic abnormality associated with the structural problem, because the challenges of managing the structural problem will increase 10 to 100 times if the baby has an additional genetic or a chromosomal abnormality. Now, visualization of the stomach bubble must be documented in every single measurement of the abdominal circumference right from the first trimester onwards. Not only it confirms abdominal situs, again, small, big stomach bubble is more subjective. There are normograms, you can use the normograms, but then remember, it is not absolutely accurate, because the stomach, when the baby is swallowing amniotic fluid, it will appear slightly bigger, whereas when the baby is not swallowing amniotic fluid, is in the quiescent phase, then it could be a small stomach bubble. If you have a suspicion that the stomach bubble is small or large, very important to check your amniotic fluid index, document it. Don't say subjectively increase, subjectively reduce. What is subjective to you can be very different subjective to me. But when you document a measurement, again, it authenticates an objective evaluation of what you thought subjectively. So if you do not see the stomach bubble very well, or if it's too small for your comfort, it's good to rescan in 45 minutes, because then the swallowing and reflex of the baby is about 40 to 45 minutes, and majority of the times it will return and you will see the stomach bubble after 45 minutes. However, if you still don't see it, check everything else, and if everything else is looking okay, or you may want to rescan at 26 weeks, because typically the upper GI abnormalities, most of them start presenting in the late second trimester rather than in the early first trimester, second trimester. So polyhydramnios with non-visualization of the stomach bubble in the later parts of the second half, in later parts of the second trimester, could raise the suspicion of upper GI blockages. Okay, so kidneys and bladder again, very important. In the kidneys, you would measure with the spine anterior in the axial view, measure the AP diameter of the renal pelvis. It's good practice to demonstrate it with in the coronal view as well with the renal arteries, and of course the bladder is already visualized with the presence of the umbilical arteries abutting the bladder. So this tells you that there are two kidneys, and you've rechecked in the coronal view as well, and of course they are working too by the presence of the bladder. Okay, now one of the common things that we see in the kidneys is renal pelvic ileal dilatation. I prefer not to use the word hydronephrosis, primarily because the moment you use hydronephrosis, it already implies an abnormality. And to be very honest, you know, it's not infrequent to have renal pelvis dilatation in the pregnancy, but postnatally they turn out to be normal or prominent. Of course, if you have calyceal dilatation, then the probability of them progressing to hydronephrosis is much more. Now, most studies use 4 millimeters. Some of us use 5 millimeters, just so that to reduce false positivity. And again, it's important to check the bladder. Of course, it's a marker for aneuploidy. Renal pelvic ileal dilatation is a weak marker for aneuploidy. And Dr. Suresh has already gone through all the aneuploidy screening, even in the second trimester. And we know that if you have got a good first trimester screen, then the second trimester aneuploidy markers are not as important. The problem is we don't know how not important it is, right? But in our country, where vast majority of the first trimester scans are either not done, or still we have not achieved the high standards of doing a proper first trimester scan, our second trimester scan genetic sonogram still remains important to some extent. Okay. Now, the other things that you need to think about when you see renal pelvic ileal dilatation is a pelviuretary junction obstruction or a reflux. It's not possible to differentiate between these two problems in the on the antenatal scan. However, follow-up scans would be good, and a consultation with a pediatric urologist is very important, because they will give a perspective of what happens postnatally, as many of these babies will require follow-up soon after they are born and to prevent urinary infections, because it's the urinary infections which cause problems for these babies. And therefore, if they can have timely intervention and timely treatment by a pediatric urologist, the outcomes for these pregnancies are still quite good. Now, renal agenesis can be unilateral or bilateral. Unilateral is less frequently picked up. We are more likely to pick up a bilateral renal agenesis, if it is, which is of course lethal, and there is anhydramnios by mid-trimester. Of course, if it's unilateral renal agenesis, we reconfirm by the presence of or absence of the renal absence of the kidney in the renal fossa. The renal artery is not visualized there. You can see a bladder. Most of the times the amniotic fluid is normal. Here, the contralateral kidney, the normal kidney, becomes extremely important. Follow-up scans is recommended, and majority of them will be benign. And of course, but it can be a counseling challenge to the for the person who's performing the scan and the obstetrician. So take time, explain these to the couple, and say, in the absence of any other abnormalities, in the presence of a normal contralateral kidney, bladder, and amniotic fluid, the outcome for unilateral renal agenesis or absence in the fossa is generally good. Many times you see an ectopic kidney, but most of the ectopic kidneys are non-functional anyway, so it's almost as good as not being there. Okay. Now, again, echogenic kidneys are not infrequently seen, many times bilateral, sometimes unilateral as well. It is important to check the size of the echogenic kidneys. Look at the bladder again, look at the amniotic fluid, normal bladder, normal size of the echogenic kidneys, outcomes are likely to be normal. However, if there is multicystic, multiple cysts, multicystic dysplastic kidneys, the outcome is likely to be poor. If it is enlarged, again, it's likely to be poor. You think of infections, think of chromosomal abnormalities, and of course, renal abnormalities. However, if they're normal in size, a good follow-up is important. Coming to the spine, again, spine we see primarily in 2 out of the 3 views at least, which is the sagittal, coronal, and the axial views to ensure the normality all through the extent of the spine. Now, spinal defects are not uncommon. Most of the times you suspect it by a lemon-shaped skull and ventriculomegaly. Many times it's only mild, and obliteration of the cisterna magna because of the herniation of the cerebellum into the cisterna magna, that is the banana-shaped cerebellum. And of course, you go down into the spine and then you see a big splaying of the vertebra and a large open neural tube defect, right? And this is one of the most common things that is seen in the as a spinal abnormality in the second trimester. You can, of course, suspect it in the first trimester. And if you suspect it in the first trimester, do an early anomaly scan at 16, 17 weeks, and you may be able to diagnose it even earlier, right? So, but definitely you should be able to diagnose it in the second trimester, and very important to document a normal spine in the second trimester. However, beware of certain situations where you can have a normal head and brain structures, the normal cerebellum, normal ventricles, and then when you come down into the spine, you see this little bubble there. So this is a meningocele, and the outcome for these ones are actually relatively better. So, about 8 to 10% of spinal defects can have normal head and brain. So it is, even if you have a normal head and brain that you've seen, it's still important to look at the spine in its complete continuity. Okay, now you can have contoural defects where you can have the fused cervical vertebra, or you can have severe kyphoscoliosis, as in this image. And obviously, you would think about looking for other structural abnormalities and discuss the prognosis with the parent, because this may not be something that they would like to see in their baby, and you need to look out for causes of kyphoscoliosis. Sometimes you can have just isolated kyphoscoliosis with no other abnormalities, but still, because the abnormality can look pretty severe, it may be something that the parents would not want to envisage in their baby. Okay, now coming to the extremities, of course, sorry about that. Again, important to look at the extremities in all the 3 views. So that is, you're looking at thigh bone, you're measuring the humerus and the thigh. You look at the extent, the thigh, the leg, and the foot. And similar to the hand, you look at the arm, the forearm, and the open hand fingers. So again, important to document all these things. And these are very interesting images for the parents as well. So they love to see the fingers and toes and the hands and legs. And of course, they can understand them better as well. And therefore, it is nice to have these parents see these images. Now, you can have isolated bone abnormalities. You can have isolated femoral hypoplasia. It may affect one femur, or it may affect both femur, and many times they can be associated with maternal diabetes. So important to look for maternal diabetes if you have isolated bone abnormalities, which is very common in our situation. Now, when you have bone abnormalities, look at the thorax as well. And if you have a small thorax in association with short long bones, then you are possibly looking at a lethal skeletal abnormality. I think when it comes to the skeletal system and skeletal dysplasias, because there is huge number of skeletal dysplasias, and more or less they are now become genetic diagnosis rather than phenotypic diagnosis. I think it's good enough to just define them as lethal and non-lethal on the ultrasound scan and investigate thoroughly with X-ray, postmortem, and genetic diagnosis before giving a name to the skeletal dysplasia there as well. Then you can have isolated joint abnormalities, and it can affect only one joint, and whereas all the other limbs can be completely normal. And therefore, it is very important to look at all the 4 limbs and document normality of all the 4 limbs. Here you can see only one leg that is completely dorsiflexed there, whereas the other leg looks completely normal. And in the similar thing, this one hand looks normal, whereas the other hand has a, it is completely bent over, and that's the club hand of the upper limb. So you can have isolated joint abnormalities, and therefore make sure that you have documented the normality of all the 4 limbs. And then you can have congenital talipes equinovarus, CTV. Once you document in the mid-trimester anomaly scan a view like that you've seen the ankle joint properly, then you know that there is no talipes. So this is very important, because when you're looking at the leg, you do not see the foot. When you're looking at the foot, you do not see the leg. The moment you see both of them together, you're looking at very likely at a talipes. And talipes must be detected in the mid-trimester anomaly scan. So you can see that you're seeing the leg there. You're seeing the leg and the foot together, and then you know that this has got talipes. It could be unilateral or bilateral talipes. It is important to assess all the limbs. Look for any associated abnormalities when you see a CTV. If it is isolated, it has got a much better prognosis, and postnatal outcomes are really good. I would, again, consider karyotyping, because the last thing I want is an associated chromosomal abnormality along with talipes. So isolated is a very technically difficult term, and it's a huge commitment on our side when we write the word isolated on the ultrasound scan report, because what seems to be isolated now can have become associated a few weeks later. So be very, very cautious when you use terms like isolated on the scan. Okay. Now, when you see multiple joint abnormalities, of course, something like arthrogryposis, think about possibility of genetic syndromes, and therefore it's very important to investigate these pregnancies properly by doing an amniocentesis, checking the for major chromosomes, checking for microarray, and maybe even store the DNA for later assessment as well. So think about genetic syndromes when you have multiple joint abnormalities as well. Okay, now moving away a little bit away from the fetus. Again, by this time you have actually, the mother's bladder has got reasonably filled up. So you look at the placenta and you measure the distance of the leading edge of the placenta with the from the internal os, and that tells you and document it. There's no harm writing, the placenta, leading edge of the placenta is 3 centimeters from the internal os. It is posterior, and you're again at the same time you're looking at the cervical birth canal, canal abdominally as well, and complete the scan by measuring the uterine artery Doppler. And the uterine artery Doppler flow, if it is normal at this stage, it's very reassuring that the probability of developing preeclampsia and growth restriction is less. However, if you have a uterine artery Doppler PI of more than 95th centile for that gestational age, then you would arrange follow-up, because these pregnancies are more likely to develop growth restriction, or growth restriction, and mother is likely to develop preeclampsia. So follow-up is very important, even in the 2nd trimester. Okay. Now, the ideal way to measure the cervical length is with a transvaginal scan. Important to empty the bladder. Use a transvaginal transducer. Place the probe in the anterior fornix, where you're looking at the endocervical, you're looking at the cervix well, you're looking at the endocervical mucosa, you're looking at the internal os, you're looking at the external os, and you just measure the distance from the internal os to the external os. It is very important to avoid pressure on the cervix, because the more pressure you put into the cervix, the more likely you will elongate the cervix unnecessarily. Like everything else, it's important to magnify the image and see the views very, very correctly, and take 3 to 4 measurements over 3 to 5 minutes, and that would help you to measure the cervix properly. And even as you come, you're withdrawing the probe, even as you are withdrawing the probe from the anterior fornix, you're looking at the cervix and making sure that the cervical canal is not opening in front of you. Remember, the cervix is a dynamic structure. It can open and close. So therefore, it's important to do your cervical screening over an extended time of 3 to 5 minutes, document it properly, and of course, look for any funneling as you come out of as you're removing the probe out of the vagina. Now, that brings me to generating a report. It is very important not only just to do a good scan, but also to do a good report. Now, it is not difficult anymore to generate a report using a software. Once you use a software, you can actually save these reports. And again, it's an important requirement according to the PCP-NDT to save the reports, save the images. And of course, your report must include the patient demographic details, history, any detailed medical and obstetric history, all your findings, use your centiles and charts. And it is good to have, I mean, there is nothing one is better than the other. Almost all the softwares in the market are reasonably good, but please use them, because that shows that you're actually authenticating your good scanning skills with good reporting as well, because your scanning skills only as good as or how well you report it, right? These are the things that is going to last longer. And make a proper diagnosis, give your diagnosis, give your conclusions or summary, and you have any recommendations, document that recommendations in the in your report as well. Now that actually brings us to giving the images. And of course, you generate images, you give be generous about giving proper images, good images to the patient. And of course, when we are taking images, out of 50 images, sometimes 10, 20 may not be very good. So it's very important to select your images carefully so that you give proper images to the couple, because your images ultimately will speak how well you scanned that baby, right? And of course, you have to maintain a copy of these images that you have given to the patient and your PCP-NDT records as well. So don't forget to do that. Now, just like how we have abnormalities that are always present in the first trimester, we must remember that certain abnormalities are very easily picked up in the second trimester. Now, in the head brain, apart from all the first trimester brain abnormalities, agenesis of the corpus callosum must be suspected in the second trimester. Posterior fossa abnormalities can be reasonably well detected in the second trimester, the lobar, semilobar, holoprosen cavity. Coming to the face, the documentation of 2 normal size eye sockets will confirm that there is no microphthalmia. Clefts of the lip and the palate can be detected, and abnormal profile can be detected in the second trimester. CPAM, pulmonary sequestration, are second trimester diagnosis. And cardiac abnormalities, like particularly the septal defects, the atrioventricular septal defect, hypoplastic chambers, the transposition, tetralogy of Fallot, tricuspid atresia, these are things that you can easily detect in the second trimester. And so therefore, you should aim to be able to detect at least these basic lists, and then you slowly progress for those ones which are potentially detectable. Moving on to the kidneys, the bilateral hydronephrosis, renal agenesis. In the spine, you're looking at the spina bifida, kyphoscoliosis, sacrococcygeal teratomas also can present in the second trimester. The skeletal system, you're looking primarily at the lethal skeletal system, isolated bony abnormalities, as I already showed you, arthrogryposis. In the extremities, you look at your talipes, a good image of the foot will actually exclude talipes. It could be unilateral or bilateral, and isolated joint abnormalities. And therefore, it is important that when you're scanning, you're looking at all the joints properly. Now, of course, then there could be certain other things that may be present in the second trimester, but can evolve, can be detected even in the third trimester as well. Ventriculomegaly can be progressive. Microcephaly can be progressive, that you can have a normal profile in the second trimester, but you can have microcephaly in the second trimester. You can have normal head size in the first trimester, the second trimester, and you can have microcephaly in the third trimester. The face, micrognathia. You can have severe micrognathia present in the first trimester, which are typically associated with chromosomal abnormalities, whereas the ones which are associated with genetic abnormalities can present in the second half of the second trimester or even third trimester. Similarly, with congenital diaphragmatic hernia, the very lethal forms will present early on, but the less lethal ones will present later on. In the cardia, the structure of the cardia, the connections of the cardia are normal, but stenosis or regurgitant valve lesions can be second trimester or even third trimester diagnosis. So they can evolve. You can have what we call as evolving or third trimester abnormalities as well. Majority of the gastrointestinal abnormalities, the cysts, the duodenal atresia, bowel obstruction, again late second trimester and third trimester. Some hydronephrosis or unilateral renal agenesis, you may miss out in the second trimester, but it's not a crime, and can be more obvious in the third trimester. Meningocele, as I already showed you, particularly the ones which are associated with normal brain and non-bony abnormalities of the spine, the lipomas, etc., can present later in the second trimester. The non-lethal skeletal dysplasias, the ones that turn out to be achondroplasia, etc., can be in fact, early third trimester or even late third trimester diagnosis, and even postnatally sometimes. Progressive arthrogryposis is also a condition where you can have progressive neuromuscular disorders, which can sometimes, unfortunately, present in the third trimester, and fetal tumors more likely to present in the late second and third trimester as well. Now, once you diagnose a fetal abnormality, it is an exercise that must be followed for every single abnormality that you detect. Look for other abnormalities. Look for possibility of chromosomal abnormalities, possibility of non-chromosomal abnormalities like genetic syndromes, which could be isolated. And this is very important that you define why this abnormality is present in this baby, in this couple, and it is the abnormal baby that needs to be investigated and thoroughly, so that we understand what is the cause and what is the chances of recurrence of these abnormalities. And the scope of the second trimester scan pretty much covers a good growth, fetal biometry, looking at the anatomy according to the standardized guidelines, looking for soft markers, which I have not covered in my talk, but this was covered in the previous talk. Look out for the soft markers. It is good time to screen for preeclampsia, growth restriction by looking at the uterine artery Doppler, and finally look at the cervical length and screen for preterm delivery. So it must pretty much cover this whole spectrum so that you can triage the woman into groups, or if everything looks good, you can look into the eyes of the woman and say, very likely this baby is normal. So we will see you back in the third trimester for your routine growth scan. There. So I think that kind of confidence must be developed. Of course, it comes over a period of time, and that is possible by following strict guidelines, auditing yourself, training and retraining yourself again and again, so that you can achieve the best results in your practice. With that, I conclude my talk. Thank you very much. I'm happy to answer any questions.
Thank you so much, ma'am. Your talk was very organized and it was a beautiful talk, ma'am. And we'll see if we have any questions for you, ma'am.
You don't have any questions for me?
Nobody has asked or raised any question or query, ma'am. I think your talk was so informative that everybody understood.
No. It could be the other way around also. Thank you very much, anyway.
Thank you, ma'am. Thank you so much.
Thank you. Thank you very much, and have a lovely day. Yeah.
Same to you, ma'am.
Bye.
So now will have a short lunch break, and again we'll rejoin the session at 1:30 p.m. for our next discussion. Thank you. Good afternoon, ma'am. Your slides are visible, ma'am.
Great. Good afternoon, everyone.
Good afternoon, ma'am.
Yeah, may I know who is speaking?
Ma'am, I'm Dr. Shrishti, ma'am.
Okay. Dr. Srishti, can we start or we will wait for some time?
Ma'am, just give us 2 minutes, ma'am. We are waiting for people to just log back in after the lunch, ma'am. And we can start within 2 minutes, ma'am. Good afternoon, everyone. I hope everyone had a nice and healthy lunch. Now we will begin our post-lunch sessions.
Oh, yes. Continue.
Our next speaker is Dr. Mandakini Pradhan. Ma'am is the chairperson of Genetics and Fetal Medicine Committee, FOGC. She is the professor and head, Department of Maternal and Reproductive Health, SGPGIMS, Lucknow, UP, India. And ma'am has multiple publications in national and international journals, and her special interests are in genetics. Ma'am, we are very glad to have you with us, ma'am. Good afternoon, ma'am.
Okay, good afternoon.
Good afternoon, ma'am.
Yeah.
You can start your presentation now, ma'am.
Okay, great.
Thank you, ma'am.
Yeah. Good afternoon, everyone. At the outset, I thank ISOPARB and the team ISOPARB, Dr. Tapan Patnaik and the whole team for inviting me to talk on something which we do day in and day out. And probably if it can be helpful for others, then the program is successful. Next, my regards to all the seniors, including Professor V.C. Mahapatra, who forced me, encouraged me, and guided me to take up this branch. And then from time to time, he have encouraged me knowingly or unknowingly. And he is really an inspiration for all of us. So thank you, team Bhubaneswar, for organizing this. Since morning, you must be having a lot of this thing about first trimester, second trimester. So here we are to talk something about diagnostic and therapeutic antenatal intervention. So my first part of the talk will be diagnostic. So we have a lot of fetal abnormalities and they may be picked up by an ultrasound or may not be picked up by ultrasound. So how do we diagnose them, pick them up so that the burden of the disease in the society is less. So there are ultrasound non-invasive way of picking a malformation or a fetal abnormality, and that you have discussed since morning. But what I will be talking about is the invasive way of obtaining a fetal sample and doing a test. So as we have heard by this time is chorionic villus biopsy, amniocentesis, scodocentesis. but there are rare centesis or aspiration by which fetal samples are aspirated. So I'll be first part, I'll be talking about diagnostic procedure. I've got at least more than 80 slides. So few slides I'll be passing through very quickly, because initial part will be diagnostic and then I'll jump onto preventive and then therapeutic. So at the beginning, before we venture on to do an invasive test, we ask ourselves, what is the risk? And first we get to know what is the fetal risk, that the fetus is likely to be affected. Then which fetal tissue is the best for the test, so that we go ahead and obtain that tissue. How to collect that sample? How do we collect it? Which vial we use to collect this sample? And what test to be done to pick up that disease? Which laboratory to send? All labs do not do prenatal testing, and hence we need to know which laboratory to be sent. Then complication, cost and consequences of the test needs to be known to us and then to be explained to the patient. And what constitute our pre-test counseling? So a pre-test counseling before going ahead and doing a test is a must. So what is the risk? First is, how do we determine that what is the fetal risk? There are different ways and it depends on our understanding. For example, a woman who has come with a Down syndrome risk of 1 in 50 is 1 in 50 is 2 in 100. That becomes 2% fetal risk of having a Down syndrome. In other words, 98% chance that the baby will have a normal chromosome or will not have any Down syndrome. For a couple, 2% is very less and they can continue with the pregnancy. For another couple, 2% is very high and they may want to have a prenatal invasive testing. So for example, if both parents are carrier of beta thalassemia or sickle cell anemia, then it is an autosomal recessive condition. It is 1 in 4, that is 25% risk that the baby will have thalassemia major or sickle cell disease. If one of the carrier is chromosomal translocation, if the mother is a carrier, then there is little higher risk, that is up to 10%. If the just a minute. If the husband is a carrier, then it is around 5% risk of fetus being abnormal. Then we detect many malformation, and the chances of chromosomal abnormality is different for different malformation. So we determine, like this pedigree indicates, that both male and female are affected in this pedigree. The black dots are affected individual. Round is a female and square is a male. So both male and female are affected. Every generation are affected, as indicated over here. The first generation, it was affected at 52 years, subsequently 37 years and 17 years. So by this time we know that this is something to do with autosomal dominant condition, and as the generation is going increasing, the onset of the disease is earlier. So hence, for your information, this is a pedigree of one of our patient whose husband was suffering from spinocerebellar ataxia, and a pedigree analysis hinted about it, and a prenatal diagnosis was done, and the fetus was found to be affected. So hence, sometimes your pedigree drawing will tell you about the condition, and the detection of malformation, structural defects on ultrasound, like cystic hygroma or hydrops, early gestation, and or more gestation, like less than 17 weeks, you have got 80% chance that the baby is affected with aneuploidy or chromosomal abnormality. And hence, if you say that your baby has got 80% chance that there is chromosomal abnormality, then the patient to take a decision, it becomes easy for the couple. So it is taken from this technical bulletin of American College of Obstetricians, and there is different aneuploidy risk for different malformation that is detected. So coming on to which fetal tissue we will take. We know that it depends on the gestational age. If the patient has presented to you, say around 11 weeks, then you can do a chorionic villus sampling. But if the patient is already into 16 weeks or more, then the sample can be amniocentesis. And before that, you can't do an amniocentesis. So if it is more than 20 weeks and you are an expert in doing a chordocentesis, so probably you may prefer to do a chordocentesis, specifically if the placenta is anterior. So it depends on the operator also. So apart from gestational age, it depends on type of test that you want to do, which I will be highlighting subsequently. Then what is prerequisite of an invasive test is a blood group. A blood group is a must if the patient is Rh negative. Irrespective of husband blood group, get an indirect Coombs test done. If the indirect Coombs test is negative, the patient has to receive injection anti-D intramuscular in the deltoid region following this antenatal invasive procedure. Second thing is what we are coming across nowadays very often is fungal infection on the abdomen. So you need to look into any specifically fungal infection in the abdomen, and you can treat it before venturing into going into doing a amniocentesis or putting a needle into it or fetal sampling. Next is you have collected the sample, but what test to be done? This how to collect the sample, I will be individually dealing with it. But what test to be done with the sample available? So we know that there are the tests that are available are chromosomal analysis. Then is FISH, everybody says, that stands for fluorescent in situ hybridization for chromosome 21, 13 and 18. These are common chromosomal aneuploidy that is seen. And that is why the lab does a FISH for chromosome 21 or 18 or 13. Sometimes they do for all of them. The next test is microarray. Then is single gene disorder. Suppose a couple is at risk of having a thalassemia. So you the sample that you obtained, you send the lab to look for if the fetus is affected with thalassemia or not. Similarly with sickle cell disease, Duchenne muscular dystrophy, spinal muscular atrophy, and many other diseases are being single gene disorder, and the test can be done on that sample, fetal sample, but specific test to be done, and simultaneously parent sample to be sent to the lab for testing. Then comes exome sequencing, and sometimes enzyme analysis. We used to do that beforehand, but after this sequencing available, most of us have switched on to doing a exome sequencing for an enzyme disorder or inborn error of metabolism, what is called as IEM, or inborn error of metabolism. So enzyme analysis these days have decreased in this thing. So what is it? To understand this genetics better, I have made only one slide, and see your words make a sentence, sentences make pages, and pages makes a book. If we keep the book in a rack, that makes a book rack. So if similarly we have got ATGC or this adenine nucleotide, that three of them makes one codon which codes for one amino acid, and many amino acid together forms a protein, or many codons together forms a gene. The gene translates a protein, and that protein acts in our body, and many genes are stuck together to form a chromosome. So in other words, one chromosome, suppose we imagine this to be one chromosome, so it is in pair, and these chromosomes are nothing but packed of genes. So if I do a chromosomal analysis, I am looking into this book rack whether there is any deletion or duplication of books in this rack. So I can't know if there are pages which are missing. To know the missing pages, the test that is available is microarray, and to know if every page is written in exact order, then the test is known as sequencing. So to understand it better, BOCRAC stands for chromosomal analysis, pages stands for microarray, and lines stands for exome sequencing or gene sequencing. And if I'm going and seeing there are 2 BOCRACs of anatomy or 3, then that is called as fluorescent in situ hybridization for anatomy BOCRAC. So I will not be knowing about physiology BOCRAC. So hence, if I am asking the lab to do a FISH for chromosome 21, then the lab will say chromosome 21 are 2 in number, not about chromosome 18 or 13. So this is a basic understanding of chromosome microarray and exome sequencing that everybody should understand. And while counseling, we must know that prenatal and postnatal therapy option of pregnancy termination, place of termination and method of termination needs to be discussed with the couple. And a normal report doesn't mean that all genetic disorder, all disorder has been ruled out. Rather, one must emphasize that it is for that disease what was looked for has been ruled out. Not everything has been ruled out. This is very important because these days the patients are putting up cases off and on. So a pre-test counseling is done. The couple, preferably the couple is made to counsel, together counsel. A routine documentation of the counseling these days we are doing. What is depicted over here? See, 15th of March 2021, one of our doctor has counseled the couple about quadruple test, which was 1 in 313. So what is the procedure? That is amniocentesis that can be done. Advanced gestational is in this case like 24 weeks, and complication and cost. And what we have done is, in the department, we have got a department has made a one of our residents have made this video for this for patients to see and then can understand the procedure in a better way. So this is what the video looks like, though the video is long, and hence I will not be playing the video full, but one can see that the department, the video goes on like this, and then it explains the procedure. So this can be used also for pre-test counseling, so that the patients and the couple is better prepared to listen to you. Any invasive procedure, all these invasive procedure are OPD procedure, ultrasound guided procedure, and local anesthesia is not only given in case of CVS or very apprehensive patient, and then we do not give any local anesthesia except in cases of CVS. Spinal needle is used for all these procedure. For CVS, we use 18 gauge needle. For amnio and codo, we use a 20 gauge needle. Prophylactic antibiotics, we do give antibiotics, though international recommendation is not for antibiotics, but we give for amoxicillin for 5 days. No sedation, no tocolysis or analgesic is required. Analgesic, if at all required, if the patient is very apprehensive. So coming on to the individual, the procedure. So first I am coming on to amniocentesis, which is the most common and most easy procedure. So this is how the patient will understand that. Seeing this, the patient will understand that this will go in and then the aspirated, and this is what is being aspirated in this. And if you see that on the ultrasound image, it is the needle is going in, and initial the trocar will be taken out, and initial 2 ml fluid is discarded because of maternal contamination, and rest the sample is collected and transferred in a aseptic manner into a tube that is given by the lab, and they are sterile tube, not reused. So here we are trying to show you how the samples are collected. Patient is very sure that it was her sample only. Like only yesterday only we had 2 cases reported to be trisomy 21. So the patient are very sure that the sample sent to the lab was theirs only, not anyone else, because we had shown them, we show them, every patient is shown their sample after collection, the labeling of the sample after collection. So next is weeks it is 100 ml, and 16 weeks it is 185 ml, and the amount that is recommended is 1 ml per week after 15 to 16 weeks of gestation. In my experience, if I'm doing between 15 to 16 weeks, the cell number is less and the lab will have a difficulty in doing the whole amount of test, and hence it is always better to do it say at 16 weeks or afterwards, and you can jolly well take out 16 ml of amniotic fluid and send to the lab. Coming on to the procedure of chorionic villus sampling, as I have told, can is infiltrated into the skin, and then the needle is put on ultrasound guidance into the placenta, is localized, and into the placenta it is inserted. The syringe of 20 ml syringe is attached onto it, and the syringe has got the culture media inside it. 2 ml of culture medium is already inside the syringe, so the tissue that is aspirated are into the culture medium directly. So here is this video, and this video is not very correlating. I have pressed it late. So they are this thing, but what is being done is with a negative pressure is being generated. The needle is inside the placental bed, and the this is the needle tip, and this needle tip is with up down movement. The stellate is taken out. The syringe is attached with the culture medium, and with up and down motion, the this thing is the chorionic villi are aspirated onto the with this movement. This is the movement of the this thing, and then you aspirate it. And how it looks like is, then you put it onto a petri dish, the whole thing, and if you put light below it, you will see chorionic villi like this, what is shown in this petri dish. So these chorionic villi are collected into the Eppendorf tube and are sent to the lab. So this Eppendorf tube again has got those medium, or what is called as a RPMI medium, whereby whereas they will not, they have this chorionic villi are to be collected on this medium so that it can grow, it will not die down. So this is how we collect it, the chorionic villi. So coming on to next is how do we do a chordosynthesis, is obtaining the cord blood. And here is the placenta, and this thing is anterior. This is very very good position to obtain the cord blood. Here I am, for demonstration sake, I have used this video. This is not exactly, this is a video of mine of doing a transfusion. So you aspirate this cord blood onto a syringe and immediately transfer into the heparinized vial for your karyotype, and into EDTA vial for any DNA analysis or exome sequencing or microarray. So 1 ml blood is transferred onto a heparinized vial, and 2 ml into EDTA is quite sufficient for any of the test. So CBS and amniocentesis, how do we compare them? CBS can be done at 12 weeks, so it is early and good for DNA. Good amount of DNA can be extracted, but the main thing is that it requires little amount of training, and there is little more patient discomfort, because you are putting 18 gauge needle and moving it up and down and obtaining a tissue, whereas in amniocentesis you are obtaining fluid. So naturally you are not moving the needle up and down. So little patient discomfort is more. What is more, this thing is placental mosaicism. Placental
Hello, ma'am. Ma'am, am I audible, ma'am? I'm sorry for the slight delay of events. There has been a network issue on Mandakini ma'am's part. We are just sorting it out, ma'am. Good afternoon, everyone. As you can see, there is a Q&A box right next to the share screen option in the panel below. Kindly send us your questions if there are any. Ma'am will be joining us shortly. Ma'am, do we have you with us, ma'am?
Yeah, yes. Sorry for that.
No problem, ma'am. No problem, ma'am.
Got disconnected.
Yes.
Can somebody tell me till what this thing it got disconnected?
Ma'am, if you could just share your slides, ma'am.
Okay. Hmm. So
Yes, ma'am. you can resume from here, ma'am.
I had finished this.
Yes, ma'am.
What about this?
Yes, ma'am.
You had seen this prenatal diagnostic procedure, OPD procedure, and things like that.
Yes, ma'am.
Amnio?
Yeah, ma'am.
No?
Yes, ma'am. Ma'am, you have to resume from slide number 22, ma'am.
22. Okay.
Yes, ma'am.
Okay. Oh, so then I was here only.
Yes, ma'am.
Okay. Great. So not much. Okay. I'm really sorry for that. Am I audible?
Ma'am, you are audible, ma'am. No issues, ma'am.
Audible? No
No
issue?
issues, ma'am.
Okay. Great.
You are perfectly audible, ma'am.
Okay. So what I was talking about is, I'm really sorry for that, the break in between. But then this is, I have explained what is amniocentesis, CBS, and chordocentesis. CBS is done early, and it can be done at after 11 weeks. So and good for DNA. It gives a lot of material for DNA extraction. But it needs little amount of training because you have to reach up to the placenta and take out, and you are moving the needle up and down, so there is little more amount of patient discomfort. Whereas amniocentesis, you are aspirating a fluid, so the patient discomfort is less. CBS has got inherited properties of placental mosaicism, that one or two cases everyone has experienced that. Cord blood, the advantage is you can get an early report. See, in amniocentesis, the lab takes almost 2 to 3 weeks or maybe 4 weeks to give a chromosomal report. Whereas in chordocentesis, from the cord blood, it will give in 7 to 10 days time, the whole karyotype report. But then these days with microarray, we do not face that difficulty. But anyway, chordocentesis is with little more amount of risk. And other tests, however, can be done with the chordocentesis. So other rare aspiration that we do is fetal thoracocentesis, that is aspirating pleural fluid, which the fluid can be sent for the total counts, then different cell counts, protein, then along with amnio or cordo, it can be for PCR for intrauterine infection, then chromosomal analysis and microarray can be done, so that you need to venture onto a more therapeutic procedure for this fetus. So sometimes you do the fetal ascitic tap or a bladder tap, what is called as a vesicocentesis, or this ascitic tap or paracentesis is required to be done, specifically in case of posterior urethral valve. Then you need to fetal urine, different parameters are looked into, and it is not only one aspiration, 2 or 3 times it has to be aspirated at 2 to 3 days interval. And if the parameters are less or parameters are favorable, then this fetus, we can do something as fetal therapy. So the complication of all these diagnostic procedure, 0.5 to 1%. For chordocentesis, little more, that is 1 to 2%. Leaking PB, rarely it occurs. Bleeding, chorioamnionitis, these are rare complication in an experienced hand. So the next part of the talk was on therapeutic procedure. So I will move on to the therapeutic procedure. All of us are aware about this graph. As the maternal age increases, the incidence of Down syndrome increases. As the fetal age increases in weeks, the chances of Down syndrome decreases. That means if you are seeing a fetus at 18 weeks, its chances of having a Down syndrome is less as compared to what you are seeing at 11 weeks or 12 weeks. So please, in first trimester, must do and rule out Down syndrome. So coming on to the fetal therapy is divided into 2 parts, that is preventive aspect and diagnostic aspect. So preventive, all of us know about periconceptional folic acid. Actually, I've got a lot of videos, so hence I'm jumping onto this periconceptional folic acid for prevention of neural tube defect. Please ask your neurosurgery colleague and neurology colleague. If they are seeing any babies with neural tube defect, ask the mothers to take folic acid before the subsequent pregnancy. It will prevent 70% recurrence of neural tube defect. If there is ambiguous genitalia, it could be because of congenital adrenal hyperplasia, and dexamethasone may be given to the mother once she is again pregnant. And if it is a male fetus or an unaffected female, then it can be stopped. Not going into detail of when and what. But antenatal steroid, all of us are aware about it, and all this committee opinion and our ministry guideline are there even for ANMs to give antenatal corticosteroids from preterm. It reduces respiratory distress, intraventricular hemorrhage, necrotizing enterocolitis, and mortality. But then what is to be remembered is 2 doses of betamethasone or 4 doses of dexamethasone. But what is available in India is dexamethasone. Dexamethasone is listed in WHO Essential Medicines list, is inexpensive and widely available. The betamethasone salt, the salt that is effective is betamethasone acetate and phosphate. And this acetate and phosphate is not available in India. What is available in India is betamethasone phosphate. So friends, let us forget about betamethasone. Don't go into acetate, phosphate, phosphate acetate, and things like that. So let us forget B and remember D. And all of us remember D-Day, and so if we do remember D-Day and dexamethasone, then that probably solves our purpose of giving antenatal corticosteroid. And all of you know that all women before 34 weeks, and there are indication of doing to the same dose to be given in twins and triplets. I've seen prescription, if it was a twins, double the amount of betamethasone been given, and court case is going on. So please remember that the dose is same, and the mother will have abnormal blood sugar, and it needs to be monitored if it is already a GDM or diabetes on insulin or any hypoglycemic agents. So next is, it is not to be repeated. Then magnesium sulfate for neuroprotection are being recommended by every this thing, and we also practice it. Less than 32 weeks, and few committees say less than 34 weeks. So 32 to 34 weeks is little this thing. But 34 weeks, we must give Maxsulf if we are expecting a delivery within next 24 hours. The dose is 4 gram IV 30 minutes, and continue 1 gram per hour IV infusion over 24 hours. The monitoring is same as that we do for eclampsia, this thing. It can be given along with nifedipine. Delivery should not be delayed because I have given Maxsulf and it has not started working. Serum magnesium level not to be done. It is the same dose as in singleton or twin gestation. So I am coming on to cardiac rhythm defect, which we can treat or treatable condition. The first one is tachycardia. What is supraventricular tachycardia in the fetus? In 1 to 2% of pregnancy, we may see, and it can cause hydrops. Though I have written here is 1 to 2%, probably we don't see that 1 to 2%. I may be wrong in writing that, but it can be very well treated with antiarrhythmics. And in non-hydropic, digoxin works very well. But if the fetus has got hydrops, then along with the digoxin, you may have to have second line of therapy, which works and treats this fetus. So here is a fetus where fetal heart rate was 270. And if you see, it looks something like this. And if after treatment, you see this heart rate has come down like this. So this is the same fetus after 28th of March on 2014, and this is 14th of March. So at the interval of two weeks, the heart rate has become normal in that same fetus. So this was the heart. If you are seeing such a heart, it is very easy to monitor the mother and treat the fetus. So this is one condition I love it, because it is very easily treatable the patient, the treating obstetrician feels very happy, and the patient feels very happy. So we treated amiodarone, and the second line of treatment is digoxin along with amiodarone in fetal supraventricular tachycardia, and got it published. And fetal dysrhythmia also can be treated for any other abnormality. Coming on to the blocks, or where you are seeing a less amount of heart rate, or less heart rate is less, that is a condition where because of maternal autoimmune disease, the antibodies has crossed through the placenta and has gone and attached to the myocytes. And these are seen in SLE, Sjogren syndrome in mother, and Rho and La antibody, that is SSA and SSB antibody, can be positive in these women. So the always congenital heart block is not because of maternal autoimmune disease, it may be structural abnormality, one needs to rule out that. So here is a fetus where arterial rate is 153, ventricular rate is 45. So this is also the risk, if you have antibodies, then the risk of congenital heart block is 1 to 2%. If previous heart block, then it is more, and 18%. And in these babies, need of pacemaker is around 60%. So all babies will not require a pacemaker. Mortality is 20%. And this baby can have a late onset cardiomyopathy. So everything needs to be told before subjecting these women for dexamethasone therapy. And this prevents developing onto complete heart block. It doesn't treat it, unlike the digoxin. And if high drops, then dexamethasone doesn't work in this. That is incomplete heart block. If already complete heart block has set in, so you may try dexamethasone, plasmapheresis, maternal terbutaline, digoxin has been tried, but has got less success. So your ventricular rate will be something like this, and arterial rate will be normal. So a heart rate which is less can be because of congenital heart block, and you test the mother for Rho-La antibody. You give dexamethasone 4 milligram per day to the mother. If the heart rate is more than 200, then mother is given digoxin, and this is supraventricular tachycardia, and these babies do fine later on. Rarely, sometimes you see a neck mass, and which is vascular like this, and on a 3D ultrasound you see this. So it is nothing but fetal goiter. It can be because of hypothyroidism or hyperthyroidism. You need to identify, and accordingly L-troxin can be given into the amniotic fluid or the cord blood. Here is a baby who was seen in the intrauterine period, and with intraamniotic installation of L-troxin, this baby thyroid was absolutely normal. Hyperthyroid is a dreaded condition where the antibodies may cross the placental barrier and may affect the baby with tachycardia and high drops again. This is a mother with the eyes. You can know that she has got lid lag and hyperthyroid. She has C5th gravida with 2 previous term and 2 preterm. Previous LSCs being treated for Graves' disease, came with high drops. Fetal heart rate was 190. Here mother should be given antithyroid therapy. So now, if idiopathic polyhydramnios is a condition where you may give indomethacin to the mother, and this may be of any etiology between 26 to 34 weeks, 25 milligrams 6 hourly, but must remember that it can cause premature closure of ductus. So hence, strict monitoring of these women needs to be done. It is not that you just write indomethacin and send the patient back. You must call the patient back and have a relook into her cardiac chambers and try to see for if there is any, if the amniotic fluid is reduced and you have achieved your this thing. Then so transplacental fetal therapy is possible in Maxell 32 weeks for neuroprotection, steroid for long maturity, supraventricular tachycardia and congenital heart block. I talked about indomethacin for idiopathic polyhydramnios. And coming on to next is the image guided procedure like amnio reduction for polyhydramnios. If your indomethacin is not working, then you may go ahead and do amnio reduction. You may, in oligohydramnios, you may do amnio infusion. Then I'm coming on to one by one. This amnio infusion, when AFI is very less and specifically if your deepest vertical pocket is less than 1 centimeter. So then amnio infusion can be done, but however, you must rule out fetal malformation and rest of the things, specifically fetal kidney, and bladder should be visualized. So normal saline or ringer lactate can be instilled at body temperature. The volume and antibiotics, the volume is to be from this chart, which says that what is the gestational age at which 5th centile, 25th centile, and 50th centile. I usually aim to achieve a 50th centile of amniotic fluid, and usually in those babies, the pregnancy, it needs only one amnio infusion. Subsequently, the baby starts producing its own. Yeah, so it is meant for unexplained oligohydramnios. I'm again repeating unexplained, not relieved after your rest, hospitalization, high protein diet, and increased oral intake of water. Malformation has been ruled out. P-prom has been ruled out, and there is no maternal disease. Suppose mother has got preeclampsia, oligohydramnios, you should not start doing an amnio infusion. In that case, take care of your mother. Another this thing is fetal reduction, that is potassium chloride is injected into this. This is gradually it is the incidences is increasing. If the fetus has got some abnormality, you may have to do it. And that is called as a selective termination. And if you are doing multiple fetuses, then you are doing a multi-fetal reduction. Then here this is not zoomed, but however the needle is going and entering, and then into the thorax and into the heart, 2 ml of potassium chloride may be injected. There is 5% risk of abortion and 10% risk of leaking PB in this procedure. But then the outcome of those twins, or normally usually twins left behind, is very, very good. So we do this procedure, though we don't like it. So next, coming on to my favorite intrauterine transfusion and few rare procedures. For intrauterine transfusion, the fetus has to be anemic. So hence you need to detect fetal anemia. Prepare a bag of blood that is O negative, fresh, 5 days, within 5 days collected, cross-matched with mother sample. Hematocrit of the bag to be 75 to 85%. It is screened, liquor-reduced, and gamma irradiated. So the procedure is done. Apart from RH isoimmunization, we have few patients of minor antigen and isoimmunization because of minor antigen, and parvo B19 infection, where we have done intrauterine transfusion. So many of us know that to detect fetal anemia, it is middle cerebral artery peak systolic velocity. Let me show this video whereby you see that how the middle peak systolic velocity is taken. It has to be the other day I was seeing one workshop where the operator was showing the artery which is distal to your probe. No, it is the proximal artery, that is to be the anterior one to be sampled, and you need to have a correction of the angle, and it should be less than 30. If it is 0, it is best. You take 3 values, and the maximum value is recorded as the middle cerebral artery peak systolic velocity. Here is the patient where the maximum value is more, and hence this patient had a intrauterine transfusion. So to remember this, what is 1.5 MOA is the period of gestation in weeks multiplied by 2 usually corresponds to 1.5 MOM. So 28 weeks multiplied by 2 becomes 56. So if your value is 56, then it is definitely more than 1.5 MOM. And this fetus is, that indicates moderate to severe fetal anemia and needs a fetal transfusion. So coming on to how do we do a transfusion, here is a short video of doing a fetal transfusion. This is again a 20 gauge spinal needle that is being used, and this video that I have prepared is not correlating with the ultrasound image. So I'm sorry for that, but then I can't help it. I'm not technically that sound. So this is the ultrasound image, and the operator, what we are doing is trying to do is, this is, we have gone, we are taking out the stellate, and you can see the blood coming out, and blood is being collected not in a 10 ml this thing syringe that was being shown in the workshop. It is in a 2 ml syringe that, and slowly, like very minimal negative pressure, it is being collected. And if the first time it is being used, around 2 ml of blood is collected, and then immediately the this thing is given, the drugs that is to be given. Sometimes in high drops we have to give some agents, or we give this anesthesia to the baby, and the blood is this thing is attached to the this one end is attached to the bag, and it is a closed system in a 3-way cannula. The blood is pushed through collected through into the syringe and then pushed through this. So what is the operator is doing is, she is trying to take the blood from this and then pushing onto. So this is blood is directly collected onto this 3-way cannula, and then with the 3-way she will be collecting and then pushing it. So the amount of blood that is to be given is calculated as per the initial this. So what she is doing is, she is taking the blood onto the, collecting the blood into the syringe, and the blood is being collected. This is the blood is directly being collected from the bag into the syringe. We don't collect blood and keep it in separate syringes beforehand, and then 3-way is moved such a way that it is connected with the fetal end is open and then the bag end is closed. So this is pushed and the fetus is getting the blood over here, there. So once this is done, once the amount that is to be given is done, so then this is disconnected and the stellate is pushed in. We take a sample which is immediately collected. So we collect a sample which is immediate sample and call it as immediate. And if the fetal heart is normal and everything is normal, rest of the thing is normal, then we wait for another 1 minute, so that we collect a post 1 minute sample, so that our post hematocrit is good and we can correlate, we can identify what have we achieved, and hence the subsequent transfusion can be planned. So here I'm just taking out the needle and we take out the needle. This is how, and the fetal heart is monitored. So this is how the IUT intrauterine transfusion is done, and subsequently the mother is observed. If it is a posterior placenta, that was in the video was anterior placenta. If it is a posterior placenta, you have to go into the posterior part of the cord insertion. So this was in 2014 that I was doing this posterior placenta, and these days we have gone on to do the intrahepatic portion of. See, this is being the needle is being pushed into this cord, and here what is being done is, here the needle is coming onto the hepatic portion of the umbilical vein. So this is hepatic portion of the umbilical vein is targeted, and this is in fact this intrauterine transfusion was done yesterday only, 8/4/2021 at 4:12 p.m. So in the evening we were doing this for high drops baby who has lost 2 fetuses, and now with high drops during this corona time has presented to us. So once the needle is inside the hepatic vein, the stellate is withdrawn, sample is collected, and the blood transfusion will be started. So one can see blood going into this through this hepatic vein. So it is if the gallbladder is not coming onto this path, so it is easy, and one can see the blood flowing into this portion of this thing. And in between, what we do is we go on monitoring this fetus, and hence we monitor their heart also while the transfusion is being done. So we can monitor from the umbilical artery that is there. So the umbilical artery is being monitored, or here in this patient we can see the fetal aorta, and that can be monitored also for fetal heart rate. So this is, and fetal heart can be monitored. There is pleural effusion and lot of fetal ascites. So this baby is, let's hope that this baby survives. Yesterday we have done 110 ml blood transfusion to this baby. So still we could able to achieve only. So the baby is doing fine, at least till today, and I am at least hopeful for this baby. So let's hope that this baby does well. So next, coming on to the, so we have got a wealth of experience of IUT. Coming on to fetal pleural effusion, whereby we can put on a shunt onto this. Can anyone think that this baby will be surviving with this amount of pleural effusion, bilateral pleural effusion, and one can see the amount of skin edema that is. So we see 1 in 10,000 to 15,000. It may be unilateral or bilateral fetal pleural effusion. It may be secondary to some cause, which if it is secondary because of structural anomaly, infection, chromosomal abnormality, fetal anemia, then one should not put a shunt onto it. Whereas if it is primary and it is usually lymphatic, so you aspirate the pleural fluid and then look for it. If it comes as lymphatic, then you can put in a shunt. The course is unpredictable. It may regress, stabilize, or progress. If it is progressive and causing polyhydramnios and mediastinal shift, then only there is a role of putting a shunt onto it. Small effusion, you follow these patients. Large effusion, you put in a shunt. So shunt looks something like this. This is that patient with pleural effusion. And after shunt, one can appreciate the shunt double loop and then single loop over here. So this was the shunt and the whole team with the baby out. So this is, the shunt comes something like this. It has 4 parts. I will be showing. It has again a needle and a trocar, which is 13 gauge and 18 centimeter, a guide wire, a positioner, and double pictal stent. And it is the same 4 parts that for demonstration sake I have made this video with using a used shunt. And so you have a needle. This is a positioner that has got a expanded end and this thing, and you have got a, so this is a double pictal catheter that is put in. One end is in pleural cavity and another end is into the amniotic fluid. So what you do is, in the guide wire you put in your positioner and then cannulate your shunt. And suppose, for example, this is your fetus and this is your trocar and cannula. Under ultrasound guidance, you go on to the fetal thorax and you put in your needle into it. Then what you position your this thing, you take out your trocar, then the loaded shunt with the positioner is put into this needle. So once the tip of the needle, the guide wire is seen on ultrasound, so what will happen is, so it is at that position. So under ultrasound guidance, you see the tip of the needle, tip of the guide wire. So that is I'm trying to demonstrate, and you take out the guide wire. So the guide wire is taken out. Then with there are marker, and till the mark 1, you push it. So this thing is pushed, thereby the single loop comes out. and you hold it with the mark 2 and it is withdrawn. So pushing and then withdrawing. So because it's a this thing, somebody will help me out, and so we are withdrawing it. So see, the this thing has come out. So the placement of cannula, the shunt is like this. You put in your trocar and then take out the needle. So what is seen over here is in the fetal, so-called fetal chest, the shunt is the double pigtail is outside and the single pigtail inside, and it will drain. It has got, apart from the end, it has got multiple holes in the length of the shunt also. So here is a procedure, live procedure, whereby the fetus is anesthetized for the procedure, and the IM atracurium is given. Here I am because we have to do a procedure, thoracoamniotic shunt. So an IM injection is given to the fetus. Then this same fetus that I showed, I started with it. It is this fetus where initially we do a the thoracocentesis, and now we are putting in a needle. So the needle has gone inside the this thing. So I can show you. It is the trocar will be taken out, and this is the part of the loop that has come out, and the needle will be taken out. Now this is the needle being taken out of the thoracic cavity, and little amount of weight, because there is no free space between the placenta and the fetal thoracic chest wall. So sometimes the fetus helps you out. Like this fetus was a very nice fetus. So it helped me out in moving away, and then showing some amount of fluid, so that I could able to release the second end, the pulling things. So I'm trying here in that in this this thing. So still in the chest wall, and now here one can see that the this thing of the stent, and here the stent will come out. This is the stent, and the release of the stent will be done, or the pulling of the whole on the guide on the positioner will be done. So one can see that both the loops came out, and the needle will be withdrawn. And what is seen is, so you see something like this. So your shunt, one end is here, one end of your shunt is here, and then the double loop is here. So this way you can put in a shunt, and last week only we discharged another baby with a shunt. So different putting in the shunt. Okay, anyway, I just forgot. And you can put a vesicoamniotic shunt, the role of which is gradually decreasing, and I'm not going on to detail the long term, because of the long term prognosis of these children. So this was a shunt put by me, but however the baby came out being delivered outside a catheter, all meconium stent, very bad. So next procedure is the radiofrequency ablation that is being done for an cardiac twin, but then many of them will not require any intervention. So you may have to need to follow them up, but very carefully follow them up. If at all it is essential, then one can do a radiofrequency ablation. Here we have used this needle for a radiofrequency ablation of this fetus. So radiofrequency ablation is being done using this needle with this thermal generating, and then at the end you get a baby with this the ablated part of the cardiac twin. Another condition is chorioangioma. It affects, truly it affects 1% of all pregnancy, but most of them are small and hence doesn't need any intervention. You need to only follow them up. But which are the ones who need intervention is more than 4 to 5 centimeter, and they are called large or giant chorioangioma, and they are more than 4 to 5 centimeter in size, and they may cause fetal anemia and hydrops. So there are few reports of published reports of doing amnio reduction, intrauterine blood transfusion, transplacental digoxin, and that is supportive therapy. And there are reports of interstitial laser ablation, fetoscopic laser ablation, alcohol injection, and embolization for chorioangioma. What we did is we did embolization for this using these agents. And this is endocrine, and along with the lipoid that is injected onto this huge chorioangioma. And after delivery, this is that huge chorioangioma. And in fact, this this fetus needed a transfusion also because of heart failure. So coming on to conclusion of this 1 hour session is prevent those which is preventable. So my request to all of you is please prevent RHD isoimmunization. I'm flooded with patients, so much so that in a week we see 20 to 25 patients of RH isoimmunization, and many of them are high drops. I am really very, very upset about it. It's doing intrauterine transfusion during this COVID time, getting O negative donors. Donors are not coming, voluntary donors have decreased in a hospital setting. So at least 5 of them are waiting for to have a O negative blood so that they can be transfused. So if these are, we as a gynecologist were responsible if the patient was delivered with us by not giving RH injection anti-D properly. So hence this is my concern and my request to everyone that we aim for preventing occurrence of RHD isoimmunization, though incidence is very varied from north to south. We treat fetal anemia. Apart from RH isoimmunization, parvo B19 and minor antigens can also do. We treat very well supraventricular tachycardia, very easy to treat. Fetal goiter, we identify and treat them. Polyhydramnios, monitor them if required. Specifically, if a fetus who is chromosomally normal, pyloric stenosis, and then the baby can be operated. Post-operation, the outcome is very good, they survive. So in those cases, you want to deliver a baby who is mature enough to withstand a surgery. So then you can do a reduction of the amniotic fluid and the pregnancy can advance. Severe oligohydramnios, we are working on it, and though the publication is silent about it, but still I advocate in indicated cases of severe oligohydramnios, the outcome is very good. But again, I reiterated that it is indicated cases. So not those premature rupture of membrane or those who have got a malformation. There we don't do a oligohydramnios. Pleural effusion, putting in a shunt, the outcome is very, very good. So we need to send these women to a center where this can be done. And TTTS laser we do not do. We have done fetal amnio reduction and this, but I myself have not done laser for TTTS. There are centers who are doing in India. Radio frequency ablation we have done. So I must thank you all for this opportunity, the patient hearing and the listening to me. I'll be happy if anyone has any query regarding this procedure. But one of my requests is, please do not put in a needle if you are not trained. I have seen a pathologist being from one of our neighboring state. Pathologist herself was put in a needle once, twice, thrice, 4 times, failed, and then sent to me with a for amniocentesis for chromosomal analysis. Last week we had a patient where husband and wife, the doctor couple, tried, both of them, radiologist and a physio, tried to put in a needle and could not. Amniocentesis is not to be tried if you are not trained. If you are trained, it is very easy procedure, you can do it. And I think everyone should do, say, few in malformation and then can try it. Thank you so much, ISOPARB and specifically Dr. Tapan and Sir, Dr. PC Mahapatra.
Thank you so much, ma'am. Thank you so much for your enlightening your talk, ma'am. And special thanks to you for your showing us some live videos. It was very enlightening, ma'am. Ma'am, there are a few questions in the chat box. I would like to ask you the question, ma'am. This question is, ma'am, we have a question whether amniocentesis for karyotyping can be done after 24 weeks. And if it comes positive, what is the counseling and management, ma'am?
Okay, that's a common situation that many of us come across, that whether we should do it or not. And here lies the importance of pre-test counseling. And these days, to me, it's a written consent. Please take a written consent. Patient left and right are arguing, fighting, and every type of reaction being seen. And maybe because of this corona time. More than 20 weeks, as of now, our MTP Act has not allowed us. But if somebody wants to know that the baby is normal or not, specifically in a condition like I told you, pyloric stenosis, that we need to gear up our pediatric surgery team also, that chromosomally microarray wise this baby is normal. Please operate on this baby. Put in all your effort to save this baby. In other hand, if the baby is abnormal, then you may disregard complicated procedure on this baby. So after 20 weeks, say for example 24 weeks, you may have to do a chromosome and microarray testing. That your mode of delivery may change accordingly. Your postnatal management may change. Resuscitation, surgery, and things like that may change. So hence, you may have to do it. But again, I am telling you, with consent of the parents and the couple is a must. So you can do it. You should do it rather if the couple is willing. Many of them, they are not willing, so we leave them. So rather it may be more than 50% not willing, though we have not analyzed that data exactly. Anything else?
Ma'am, one more question we have. The question is from Dr. Shama Kanungo. What do you choose? Why do you choose the anterior limb MCA for calculating?
Yeah, this is see, it's the middle cerebral artery. The arterial flow is the anterior portion will be towards your probe. Okay, so if you take anterior the middle cerebral artery, which is near to your probe, it is not the left or right, it is the nearer to your probe, then your sensitivity of picking fetal anemia is more, because the basis of fetal anemia detection of the increased middle cerebral artery peak systolic velocity is that you the blood flow, in the systole, the blood flow in middle cerebral artery increases. So if it is increasing, and you will measure the one which is towards the probe, not the one which is going away from the probe. So the sensitivity will be less if you are doing this thing one, whereas the sensitivity will be more if you are measuring the anterior, the middle cerebral artery, which is the one which is nearer to your probe.
Thank you so much, ma'am, for answering all our queries. Now we would like to move on to our next session. Our next session is by Dr. B.S. Ramamurthy. The topic is fetal cardiac assessment and its implications. Dr. B.S. Ramamurthy is a consultant radiologist. Dr. B.S. Ramamurthy is a consultant radiologist in the Srinivasa Ultrasound Scanning Center, Bangalore. His special field of interest is fetal medicine. He is a chief patron of Medical Ultrasound Society of Karnataka and coordinator of Fetal Foundation of India. We welcome you, sir. Sir, kindly share your slides.
Is my slide seen now?
Yes, sir. Your slides are visible, sir.
Is the arrow moving around?
Yes, sir. Yes, sir.
Right. Okay. A very good afternoon. And first of all, thanks to the office bearers of ISOPARB for asking me to participate in this lovely event. Dr. Preeti Dubey, especially, who's coordinated my participation. Over the next 1 hour, we will look at fetal echocardiography. We'll look at what each one of us has to go through in the background of a mid-trimester anomaly scan. What I'm talking is not going to be a part of extended specialist fetal echocardiography. It's going to be a part of the mid-trimester anomaly scan, which we do in and out of our practices. Now, we understand that the incidence of CHD is a high incidence. In fact, it is the tops among all the systems which contribute to congenital anomalies.
Sorry,
You will
sir.
see that.
Sorry to interrupt, sir. Sir, can we use a earphone because there's some echo is coming, sir, in background.
Is that better? No?
Yes,
Is
sir.
that better now?
Yes, sir. Yes, sir. Yes, better, sir.
Right. So it's about 8 per 1,000, and about half of them need postnatal surgery or catheter procedures. Now, that is exactly why we need to screen for CHD, right? If you look at the number of cases that would need postnatal surgery or cath procedure, it's 4 per 1,000, whereas Down syndrome is about 1 in 800, 1 in 900. So it is almost about 4 times the incidence of Down syndrome. And therefore, we need to have a very robust screening procedure in place to pick up these lesions. Now, we understand that 80% of CHD, congenital heart diseases, come from the traditional low-risk group, which is an Amjanta group. You know, there are no high-risk factors at all. It's a young lady who's married now. There's no consanguinity. There's no maternal disease, no history of medication, no family history at all, right? On the other hand, only 20% of CHD come from the high-risk group. This is important to understand. The high-risk group is maybe high risk due to history, maternal or paternal or sibling history of CHD. It might be due to maternal diabetes, infection, antibodies, drugs, ART, so on and so forth from the mother's point of view. Or it could be a fetal kind of a situation which makes it high risk. For example, a thick NT, presence of TR or ductus venosus abnormal waveform, extracardiac anomalies, so on and so forth, can put this particular pregnancy into high risk. Now, if we say that we will do the study of the heart only in the high risk population, we would only land up picking 20% of CHD in the population. Why? Because 80% of CHD come from the low risk group, and this is something which we have to be cognizant of. And therefore, every pregnancy that comes under our care, irrespective of low risk or high risk, must undergo a full cardiac study, as we will discuss in the future slides. Now, the strategy that we use in the mid-trimester for screening of CHD is called the extended basic examination. Now, the extended basic examination consists of a couple of planes, 5 planes, the upper abdomen, the 4-chamber view, the LVOT, RVOT, the 3-vessel trachea view. I've put this all in white. You can have the 3-vessel view, which is a form of RVOT. Yes, you can also have the 5-chamber view, which is actually a form of LVOT. So you get it when you commute from the 4-chamber view into the LVOT, you get the 5-chamber view. And when you go from the 4-chamber view, crossing the 5-chamber view towards the 3-vessel trachea view, you would get the 3-vessel view en route. So these are actually en route stations which can give you additional information. Now, this is the minimum basic protocol to be followed in every mid-trimester anomaly scan. And to do this, we can use B mode, M mode, or color Doppler. In the basic, extended basic approach, we really do not use spectral Doppler, tissue Doppler, or 4D stick, so on and so forth. So first, let us look at the planes of section, because getting a hold and getting a good understanding of what is the basic minimum number of planes that we need to do is very, very essential. So the first plane, as I said, is upper abdomen, and the plane cuts through the liver and the stomach, as you can see here, right? So you have the left side and the right side marked out. We will come to the fact of how to assign the sides of the fetus in a short while from now. So what I need to understand is I have to, having marked the sides first, then I look at the stomach and say, yes, it's on the left side, not the reverse. I don't say that the stomach is here and therefore this is the left side. That is a big no-no. First mark off the sides and then allot the organ to the side. Stomach is left-sided, liver is right-sided, and of course the IVC is right-sided, aorta is left-sided, so therefore that's good normal orientation of the organs in the abdomen as far as the positional or the situs information goes. From there, of course, you have to understand that from the upper abdomen, which is an axial view, you have to go upwards of cephalad as a parallel shift, and that's the shift as you can see here. Now, how does it look on the monitor? Please look at this clip. From the abdomen, I have gone on to the 4-chamber view, right? So start with the abdomen, just move upwards. You might overshoot a little, but then come back, latch onto your 4-chamber view. A simple parallel shift, right? So therefore, you can get this very, very easily, no skill involved. And you will also realize that in the process of doing this, you have finished one connection of the heart, which is the IVC, which is connecting up with the right atrium. As you go from the abdomen to the 4-chamber view, you would actually have finished tracing the IVC into the right atrium. So one of the connections also can be done with this maneuver. Now, from the 4-chamber view, so therefore you get into the 4-chamber view, and that's the 4-chamber view that you can see here. From the 4-chamber view, if you clockwise rotate the probe through 45 degrees, as has been shown here, you will get the LVOT, a classical LVOT. That is the classical LVOT that you can see here, right? So what I'm now going to show you is the actual maneuver of how your screen unfolds, your monitor unfolds this changeover. So I've started here with the 4-chamber view, and I'm rotating gently, very gently, until you expose the LVOT. So 4-chamber view, you turn clockwise 45 degrees, and that is the LVOT. So you don't take a protractor and measure. No, that's not the idea at all. The idea of 45 degrees is just notional. When you go 45 degrees, you expect to see the LVOT, and you stop your rotation when you see this familiar as LVOT. That is the way that the hands should be trained when the eyes observe the monitor. So we know the upper abdomen, we know about the 4-chamber view, we've finished the LVOT, and now what I'm going to do is to go all the way. Instead of 40 degrees, I'm going to make it 90 degrees. When I go 90 degrees, you get the mid-sagittal view or section of the thorax, And that's exactly what the RVOT is. The RVOT is seen here in terms of anatomy. This is posterior, this is anterior. The substernal chamber is the right ventricle. You see the pulmonary artery, that's the infundibulum, pulmonary artery, pulmonary valve there, pulmonary artery, ductus arteriosus, and the descending aorta. So that's indeed the RVOT, the ductus arch view that you're able to see in the mid-sagittal section, right? So how do you actually look at the events unfolding on the monitor as you do this rotation? Please watch this clip. I've started from the LVOT now. I'm doing a further clockwise 45 degrees, and I'll end up getting the RVOT. That's the RVOT. So let us look at the bookmarks. I will get the first bookmark, which is actually the LVOT, and the second bookmark, which is the right atrium, pulmonary valve, pulmonary artery, and of course the ductus arteriosus that you can see here. So this is just one way of getting at the RVOT. That is a clockwise rotation from the axial view or the four-chamber view. You go 90 degrees all the way and make it a sagittal view, axial to sagittal view. That's just about one way. RVOT can be seen in a couple of other ways, and another way, which is again easy, is to go from the axial four-chamber view. You go anti-clockwise. Instead of going clockwise, you go anti-clockwise 45 degrees. You get a brilliant view of the LVOT. So how does that kind of view look? It looks this way. So you have a central aorta around which the entire right heart is wrapped. You have the entire right heart wrapped out over here. This is posterior, this is anterior. You have the right atrium here, right ventricle inflow, that's the tricuspid valve, the right ventricular infundibulum, that is the pulmonary valve, and then the main pulmonary artery. That's the right pulmonary artery going behind the aorta, and the ductus arteriosus going straight to join up with the descending aorta. So that's a short axis view, so to say, of the right ventricular outflow tract. Now let's stop this clip and look at this clip, which tells us, or which shows us, how to start from the four-chamber view, do this anti-clockwise and get at the short axis RVOT. So let me play this clip, four-chamber view. Watch carefully. I've gone anti-clockwise, and you see that central aorta there and the heart wrapped around the aorta. That is the pulmonary artery, which is actually bifurcating here into the right pulmonary artery that you can see here, and the ductus arteriosus there. So I've got my bookmarks again. So the first bookmark takes us to the four-chamber view of the heart, and the last bookmark takes us to the short axis view, shows you the aortic cross section. You can even see the cusps of the aortic valve. And this, of course, is the right ventricle. That is the pulmonary artery. That's the right pulmonary artery that you can see here. And this is the pulmonary valve. So that's the second method of getting the RVOT. And again, an easy method. And the last method is even more easier. And that is just a straight up. You can see the cursor moving here, the transducer position. From the four-chamber view of the heart, I have just gone all the way up as a translatory shift. No rotations at all in this, and I get at the three-vessel view. And the three-vessel view is easy for all of us to recognize. From the right to the left, you have the SVC, the aorta, and the pulmonary artery. The pulmonary artery is actually coming out from the substernal right ventricle that you can see here. That's the pulmonary valve, and you can see the division of the pulmonary artery into the right main and the right branch pulmonary artery, left branch pulmonary artery, and at a slightly superior level, you will find the ductus arteriosus coming out. So let me stop this clip, and I'll show you how the transition occurs on the monitor when you go from a four-chamber view into the three-vessel view. So that is the three vessel view. Again, you can see the same landmarks. The ductus arteriosus is well seen here. That's the right main pulmonary artery. So a classical three vessel view gives you an RVOT, and it's a very simple way because it's only an axial shift from the four-chamber view towards the mediastinum up. A little Keffelard would give rise to the three-vessel trachea view. So in fact, to look at the RVOT, this is what is recommended in ISWOG. So if you're a starter and you're actually coming to grips with the rotations, not really sure of yourself, just start off doing the RVOT in the axial plane. And then once you begin to practice your rotations, whether it's clockwise or anti-clockwise, your eyes will recognize the classical signature of the RVOT, and you will stop there. You will store your clip and put it into the folder. So after having done the three vessel view in the form of an RVOT, we will look at all the way going up into the three vessel trachea view, and that will be shown in this particular clip. You will see the clip play out from the abdomen up to the three vessel trachea view. So in this clip, which actually stores or is a sweep of from the upper abdomen into the upper mediastinum, we realize that you can see almost everything that you can catch in the axial phase. So one clip, if you store like this, is of great help as far as archival goes, normal or abnormal. Please put a sweep into your folder for every patient you do. So now let's extract out the actual planes. Here I've got some bookmarks. The first bookmark gives you the upper abdomen. You can see the IVC, which is anterior and to the right of the aorta. I know this is the right because I've done the real-time scan myself. This is the aorta, stomach, and the liver. The second bookmark takes you through a brilliant four-chamber view of the heart. You can see the pulmonary veins, you can see the crux, whatnot, yes. And then you go to the third plane, which is actually the five-chamber view. Why? Because you see the aorta, which has taken off over here in the center of the heart where the crux was. The aorta takes off from the left ventricle. This is the spine, this is the LA, LV, RA, RV, and you can see these two parallel lines, which are the walls of the ascending aorta, and this is the cusp, the aortic valve itself, which is lying in the center. So that becomes the five-chamber view. Why? Because you still can see all the four chambers of the heart and also the root of the aorta, which becomes the fifth chamber, and that's called the five-chamber view, which in fact is a form of the LVOT, right? Then we move on to the three-vessel view. You can see the classical ductus arch here, the aorta in cross-section, and the SVC. The right here, the left here. So the long section of the pulmonary artery matched with the short section of the aorta, classically telling us that these two arteries are at right angles. So this is one way you can prove that there is a great arterial crisscross. This is the trachea. You can see the trachea out here. That is the SVC. And then we move on to the three-vessel trachea view. You can see that's the ductus arch. This is the aortic arch. You can see the V to the left of the spine, and both these arches are going to the left of the trachea, telling us that the arches are normally placed. They are both left-sided aortic arch as well as left-sided ductus arch, and this is the SVC that you can see here. So as you play the clip, you will realize that you see the LVOT coming out in this direction and the RVOT coming out in this direction, again telling you that there's a crisscross happening out here. And here is another clip, shows you very elegantly a classical three-vessel trachea view that you can see here. Let me just bookmark that for you. And again, ductus arch, aortic arch, SVC. This is the trachea out here. This is the right side, this is the left side. The V, the apex of the V to the left of the spine, telling us that both the ductus and the aortic arches are to the left side of the trachea, which is the normal arrangement. So therefore, you have 3 axial planes, 2 non-axial planes. If you wish to use them, the RVOT, you have an option of not using a non-axial plane and going straight for your 3-vessel view, which is actually an axial plane. So these are the minimum planes that we need to not only study, but also to document in every case that we see here. Now, a word about the 4-chamber view. You can get the 4-chamber view in a lot of ways. I have shown you a 4-chamber view where the apex of the 4-chamber view is close to the transducer. And that is why we call this the apical 4-chamber view. In this particular instance, the apex is not close to the view, but it's the side wall of the heart, which is the right side wall, which is close to the transducer. So this is the lateral 4-chamber view. And of course, here the transducer is up there. The base of the heart formed by the atria are closer to the probe rather than the apex. So you know that this is the basal 4-chamber view. Now, why is it important to recognize these forms of 4-chamber view is guided by the principle that the best seen structures are always orthogonal to the beam. Now here you have the apical 4-chamber view. The ultrasound beam is this direction. So I know that the valves, the AB valves, are perpendicular to the line of direction of ultrasound. And therefore an apical 4-chamber view works extremely well if you have to study the tricuspid and the mitral valves because it's orthogonal. Now, what happens to the septum? You begin to see the dropout artifact. Why? Because the beam attenuates, the angle is not good, and therefore you have this artifact which creeps in. If I want to see the septum without the artifact, I need to go into the lateral 4-chamber view. And when you go to the lateral 4-chamber view, you see how brilliantly the entire interventricular septum comes and joins the crux of the heart. There is no question of any dropout artifact over here. So why? Because the septum line is now orthogonal or perpendicular to the ultrasound beam. You also see the interatrial septum very well. You can see the flap of the foramen ovale opening into the left atrium very well. And that's the foramen itself you can see. So if you have to see the septum very well without any dropout effects, employ the lateral 4-chamber view. But if you want to see the valves very well, you go for the apical 4-chamber view. Basal 4-chamber view works pretty much like the apical because the septae are going to be collinear with the beam of ultrasound. But if you go somewhere along, if you put the septum somewhere along the 45 degrees line, you begin to see the septum also very well. You see the valves also very well, both in the apical as well as in the basal views. And therefore, you can go somewhere in between and get the best of both worlds. You can avoid the dropout artifact and also get the valves very well as well. So that is why we need to recognize these forms of 4-chamber view. So having seen the planes of the heart, what are we going to do? And that's extremely important. Why? When we produce a section, we need to study the section. And to study the section, we need a certain checklist of findings. So we'll come to the checklist as this lecture unfolds. But first of all, let me take you through the concept of heart as a whole. The heart as a whole means when you look at the heart, you don't go jump into the heart and look at it in terms of chambers, vessels, and connections. No, I will just wait a minute, look at the heart as a whole. When I do the heart as a whole, I need to deal with the cardiac situs, the cardiac size, squeeze, axis, and position. And if you look at the acronym, it's PASSS. So let's quickly go through each one of these because it's a discipline. When you start doing the heart, I'm going to start with situs and nothing else but situs. This should be the approach. Otherwise, there is a big chance that we are going to miss sections, miss findings, and therefore miss out on the diagnosis. So therefore, the fact that we've got to bear in mind is we start doing the heart by looking at it as a whole. And when we recognize it as one whole organ, I'm going to start with situs, right? So for doing the situs, I need what is known as a survey scan, which all of us are used to doing. Before you actually get into the area by area or organ by organ, you do a survey scan. And during the survey scan, which hardly takes about 5 seconds, you get an idea of the spatial orientation of the fetus. Where is the head of the fetus? Where is the breech of the fetus? You can do the survey scan in the horizontal probe orientation going from up and down, or you can do the survey scan in the longitudinal probe orientation going from left to right, right to left. Either way, or you can do both. It's up to you. So imagine once you know the spatial orientation of the fetus, it becomes extremely simple. Imagine yourself in that position. Call your right as the fetal right, call your left as the fetal left. This is extremely simple. You don't need to have your clockwise, anti-clockwise, rule of the thumb, so on and so forth. All that's extremely confusing. Put yourself in the fetal position, call your right as the fetal right, call your left as the fetal left. Once you do this, you have to fix in your mind that this is the right and left, and then you study the organ orientation in the upper abdomen and in the 4-chamber view. For example, I've got a clip playing here. That's the same clip which I showed you a little while ago, and I have named it as right and left side, and I soon can well imagine what was the presentation of this fetus. In this fetus, the breech was down and the head was up. And that is why the right of the fetus is coming to the maternal right and the left of the fetus is coming to the maternal left. How did I get that? I just put myself in the fetal position. My head is towards the maternal head, my breech is towards the maternal rump, and I realized that my left, that is the fetal left, is this side, the fetal right is this side. And having done that, you allot and say the stomach and the other abdominal organs are properly oriented. The apex of the heart is to the left side, and also the descending aorta is a left-sided structure. So first assign the sides and then look at the organ orientation, not the reverse. Extremely important. Now here is a picture. This is a cephalic presentation or a vertex presentation, and I've put the transducer across the 4-chamber view. This is the plane of the section which I'm showing you now. That's the section. So quickly, I know if I imagine myself in this particular position, my arm, which is the superficial arm, is the right arm. My arm, which is deeper down, which is hidden in the diagram, is the left arm. So therefore, superficial side is the right side, the deep side is the left side, and therefore I know that this is a normal heart. The apex is pointing to the left side and the aorta is a left-sided. So how did I do? First the sides, and then telling ourselves that, or pointing to ourselves that yes, the heart apex is to the left side and that the descending thoracic aorta is also to the left side. So just imagine yourself and things will be very, very simple. Right now, here is a case which you will agree is abnormal at the outset itself. I'm showing you the left side here, that's the chest. The abdomen, left side here, that's the abdomen. So you have the apex of the heart to the left side, okay. But when you look at the abdomen, which is the first section, in fact, you would get this first before this, you find that the stomach is right-sided. So when the heart and the stomach talk different languages, you know there is trouble around. There is a problem with situs, and that is exactly why we start with situs. A situs which is abnormal increases the risk of CHD manifold. In fact, if it's a situs of this nature, you can almost be certain that 99% of times the heart is going to be abnormal, right? So therefore, looking at this heart, you will realize that it's abnormal from a mile away. You don't see the crux of the heart. There's only one valve opening and closing. There's an inlet VSD. The primum, septum primum is missing. The area behind the heart is huge. The left atrium is moved away from the aorta, and you have an extraneous structure here, which is actually an anomalous pulmonary vein, which is sitting here, which should not be seen normally, and which is refusing to connect up with the left atrium. So therefore, that's a total anomalous pulmonary venous drainage. That's a balanced, complete atrioventricular septal defect, and that's the situs abnormality. And putting everything together, I know that I'm dealing with a case of heterotaxy, most probably a right atrial isomerism. Why? Because the pulmonary veins are abnormal. Now, after having done the situs, we go on to the size of the heart. Size of the heart is 1. Hello, am I audible?
Yes, sir. Yes, sir. You're audible, sir.
Yeah. Okay. So the size is about one third the size, the 1/3 the area of the thorax. Lung 1/3, heart 1/3, the other lung 1/3. We don't go around measuring these ratios, that is the area CTR or circumference CTR in every case. We do it only if there is a problem. When you find that your eyes are telling you that this is unduly looking large, that I go and do this measurement. Now, we need to understand that if we are doing an area CTR, the area CTR, the area of the cardia divided by the area of the thorax should be 33% or lesser. It should not be more than 33%. Whereas if you're using circumferences, the cardiac circumference divided by the circumference of the thorax, it is 50% is your cutoff. So that's important to understand. You can use either of these. Now here is a case of cardiomegaly, global cardiomegaly. I'm not going to go around using ratios here. My eyes are telling me that this is a huge heart. In addition to that, I find that the ventricular myocardium is not contracting well at all. There is dyskinesia that I can see here, and the mitral and tricuspid valves are barely opening and closing. They are like clapping hands. You can see that they are not going far away at all. Here you see how far the valves are moving out and then coming in, whereas here they are lethargic. They are not moving at all. So that is global cardiomegaly, cardiac dyskinesia, and already you know that there's cardiac failure. You can see the pleural effusion that's happening there, and you can see the thick anterior, the thoracic wall in terms of subcutaneous edema. You also have to realize that the shape of the heart changes as a part of remodeling. So whenever there is a cardiac insult, a functional insult, it could be a placental insufficiency, a hypoxic heart, an acidemic heart, an asphyxiated baby whose heart is bearing the brunt, or whether it's a cardiomyopathy, or whether it's a TTTS, so on and so forth, the heart is challenged with a certain insult, and to cope up, the heart pulls out tricks. And one of the tricks it pulls out is a change in shape. A heart which is dysfunctioning tends to be more spherical than a heart which is normal, which is actually pear-shaped. You can see the normal heart here. That's global cardiomegaly, showing you clearly that the side-to-side the greatest transverse width is more in the failing heart, right? And that can be actually quantified in terms of a ratio called the sphericity index. Sphericity index is apical basal length divided by the greatest transverse width, divided by the greatest transverse width. The fifth centile is 1.075. So any sphericity index which is actually less than the fifth centile, which is less than 1.075, means that this is a abnormally globular heart, and it's an indicator of cardiomegaly and an abnormal shape. As you can see here, the GSI global sphericity index is 1.01, which is definitely lesser than 1.075, right? So here is another case. This was interesting case in monochorionic set of monochorionic twins. Twin A had a thick nuchal, and twin A at 12 weeks also showed a cardiomegaly. At 12 weeks, a cardiomegaly. Twin B heart is normal. You can see both the size of the heart is normal as well as the contractility is normal. Here, the size is huge, right? So there was actually no sign of TTTS at all. So we called her back. We know that we need to see them at every 2 weeks or even 1 week in cases where there are abnormalities which have already crept in. So at 17 weeks, I'm showing you the follow-up, shows you a huge heart, a thick echogenic ventricular myocardium, very poor excursion of the valves that you can see here, a pericardial effusion, and all this without evidence of TTTS. So we really do not know whether this was a cardiomyopathy. No other evidence of TTTS in terms of bladder, in terms of like a volume difference, nothing whatsoever. So that was for the size of the heart. Now we move on to the axis of the heart is an angle between a line drawn through the septum and an anteroposterior line, which has to be 45 degrees usually. The range that you deal with is 25 to 65 degrees, which is actually the standard two standard deviations on either side of the 45. So that is normal, and you can see that in the normal heart you have an angle which is around 45 degrees or even lesser. But why are we worried about the axis? In this particular case, you will realize that the apex of the heart is far out laterally. So when I put or draw the axis, I get about 90 degrees here, which tells me that this is a pathological axis, which is a left axis deviation close to 90 degrees, certainly more than 65 degrees. And whenever there's a left axis deviation, I'm worried about conotruncal cardiac anomalies. And as you can see in the same case, you can see the aorta overriding the septum. There's a malalignment VSD, and on color, you can see both ventricles are pumping into the aorta. And when I go into the pulmonary artery level, I see a narrow pulmonary artery, which tells me that I'm dealing with tetralogy of Fallot. And where did it start with? It started with a left axis deviation. On the other hand, if the apex of the heart, instead of moving out laterally, if it moves inwards medially, it becomes closer to the sternum and becomes substernal, and that is called mesocardia. Whenever I see a case of mesocardia, I need to rule out a couple of things. I need to rule out left congenital diaphragmatic hernia, because sometimes left-sided space-occupying lesions can also rotate the heart in addition to shifting it. So critically look for left-sided diaphragmatic hernia, look for heterotaxy syndromes, look for congenitally corrected transposition of great arteries, look for scimitar syndrome, and being a possible case of chaos. If you rule out everything, isolated mesocardia is good prognosis, as was in this particular case. So you will see here that this is the spine, that is the sternum, and you will see that the apex of the heart is bang under the sternum, which tells me it's mesocardia, but there's nothing else which was abnormal in this particular case going through this entire checklist. So the outcome is good. So after finishing the situs axis, we come to what is called the position of the heart. So when you actually look at the heart in vis-a-vis a midline, a median line here, you will realize 1/3 of the heart is to the right side, 2/3 of the heart is to the left side of this particular line. Now, if there's a space occupying lesion on any one side, the heart is pushed to the opposite side. And therefore, this 2/3, 1/3 relationship is lost. Or if there's a lung hypoplasia on one side, say suppose the right lung is hypoplastic, the heart moves into the right hemithorax. So therefore, it's a push pathology most often, but rarely it can be a pull pathology as well. Now let's look at a few examples. Here is a left lung which is hyperechoic and large, type 3 CPAM, which has pushed the heart all the way to the right side. Here is a left pleural effusion, which has actually pushed the heart to the right side. Now here is the right lung aplasia. There's hardly any lung here. The left lung is normal and the heart has simply swung into the area where the right lung should sit. Otherwise, everything else is normal. Only thing is, you will not see a branch pulmonary artery on the right side. You will not see the right pulmonary vein in these cases. Here, of course, you have a bronchogenic system, the lung pushing the heart to the left. And this, of course, is a more subtler finding. You find that this is the median, that is the heart, and your eyes have picked up a shift, definitely a shift to the right. So therefore, you look at the left hemithorax carefully, you find that this is not lung, but this is bowel. You can see the heterogeneous bowel look it has. So this is a case of a left congenital diaphragmatic hernia where the stomach is intra-abdominal, only the bowel has moved up. And because the stomach isn't there, the observing eyes can easily miss this. And that is where you can fall back on an MRI to show that this is bowel, this is lung, and therefore this is a left CDH more than anything else, right? So we come on to the pericardial fluid. Normally, we do see a sliver of fluid around the heart, but this is lesser than 2 millimeters in thickness. That small sliver is very well seen, especially with high resolution machines that we have now. That normal sliver of pleural fluid, pericardial fluid, can be easily seen, but that is normal and should not be overcalled as an effusion. Whereas here, this is definitely a pleural effusion, and this certainly is a pleural effusion. You can see the heart bobbing up and down in this tense pleural effusion, the cavity full of pericardial fluid. So remember, more than 2 millimeters for you to call this as a significant or a pleural pericardial effusion that is of importance, right? Okay, now let's look at this clip. I've shown you the grayscale as well as the color out here. Let's look at the grayscale first, right? There are plenty of findings in this 4-chamber view. There is a global cardiomegaly, there's an axis deviation, there's a bradycardia. If you look at the ventricles, they are slow, but the atrial heart rate is more, the crux of the heart is not seen, and the spongy myocardium that you can see of the ventricles, right? There are about 6 or 7, or if you take the regurgitation, the AV regurgitation, which is happening, you almost have 7 findings in these pictures. So each one of us could latch on to the first, any one of these findings as the first finding. So it's not uniform that all of us will see the first, the second, and third in the same order. But once you get one finding, you have to start looking at it in great detail and unravel all the findings that can be offered in this particular slide. You will also see that there are 2 reds happening here and 1 blue. That means 2 times the atrium is beating and once the ventricle is beating. So this is a 1 or a 3:1 heart block. You can see that the FHR is less than 100, and you will see when you do an M mode that there is a heart block which has occurred. The number of atrial contractions are double that of the ventricular contractions. For every 2 atrial contractions, you get 1 ventricular contraction. The other rhythm abnormality that can actually be seen in clinical practice and fairly common finding is, look at that. Yes, you can see that, you know, it just stops there and then it begins to. That is nothing but a premature atrial contraction followed by a compensatory pause. So you have a premature atrial contraction followed by, that is the proper atrial contraction. This is a premature atrial contraction followed by a pause. So what you see, your eyes pick up is actually the pause. It doesn't pick up that premature atrial contraction. It easily picks up the pause. And when you do an M mode, you find that there is a premature atrial contraction hiding over here. And that also has conducted, giving rise to a corresponding ventricular contraction here. So that's an irregular heart. Whereas here is a heart which is furiously beating. You can see the kind of, you know, it's just trembling over there. And when you check the heart rate, you're getting as high as 330 beats per minute. So atrial flutter, atrial supraventricular tachycardias, and atrial flutter can give rise to huge tachycardic heart rates. And any heart rate more than 180 beats per minute is tachycardia. Anything less than 100 beats per minute is bradycardia. So we saw a case of bradycardia in terms of a heart block, and we saw a case of tachycardia and also an irregular heart. So we've gone through the situs, we've gone through size, axis, position, rhythm, and also the contractility, which is the force with which the ventricles are contracting, right? After having looked at the heart as a whole, we need to go into the heart as a set of chambers and vessels. And to do this, we have the sequential segmental analysis as a concept, which can actually take us through it. Now, what is a sequential segmental analysis? We all know that there's a venous level, atrial level, ventricular level, and an arterial level. So you have the right side of the heart and the left-sided structures of the heart. So the venous structures connect with the atria with the ventricle with the arteries. So you have 3 junctions: veno-atrial, atrio-ventricular, ventriculo-arterial, and you have 2 sides. So 3 into 2 is 6 junctions. So if I show these 6 junctions normal by fetal echocardiography, I know that I'm dealing with a normally connected heart. And what are the views that will help us will now follow, right? So the first view is the 4-chamber view. And in the 4-chamber view, you will have to look at chamber identification. You have to look at the fact that there is no pericardial effusion. You've got to recognize the fact that the left ventricle is equal to the right ventricle. The left atrium is equal in size to the right atrium. This is the spine. This is the descending thoracic aorta, LA, LV, RA, RV, and these are equal to each other. The flap of the foramen ovale opens into the left ventricle. That is the crux of the heart. That is where the interventricular septum comes in and meets. Forget the dropout artifact. I have done the scan. I know that this is an artifact and not a true VSD. So that is the ventricular septal contribution. These are the valvular, the AV valvular contribution, mitral and bicuspid, and you find that the tricuspid is a little closer. The septal valve of the tricuspid is a little closer to the apex of the right ventricle compared to the mitral valve, giving rise to the famous offset that we need to recognize in each and every heart that we do. And the last component, of course, is the primum component of the atrial septum. So the crux is important mainly for its integrity and also for the fact that there's an atrial, there is a valvular offset that you can see here. Now, how do you mark out the chambers? The chamber closest to the spine is LA, also marked out by the fact that there are pulmonary veins which are joining the left atrium. The substernal chamber, the anteriormost chamber, is the right ventricle, as evidenced by the presence of the moderator band and the tricuspid valve, which is closer to the apex of the heart, right? You also have the other two chambers which can be identified because certain features are absent. And also, if you trace the SVC and IVC, they would connect up with the right ventricle, right? So the septum should be seen from apex to the crux and look for its integrity. No, there should be no gaps in the septum. The valve should open and move freely and close, open and close with freedom, and they should go all the way and not that limited movement that we saw there. The area behind the heart is extremely important. You have only one vessel there, that's the descending thoracic aorta, nothing else. You can see the esophagus and its fluid if the fetus swallows, but most often we don't see any other structure except for the descending aorta. Sometimes if you're using a very, very high-end machine and high-end probe, you can see the normal azygous vein, which is to the right of the descending thoracic aorta, right? So if there's anything more extraneous, I am worried. I am very worried in the area behind the heart. The myocardium should not be spongy, should not be hyperechoic. There should be no thickening, no hypertrophy, and so on. And when you do the four-chamber view, make sure that your the ribs on either side are actually symmetrical. They're actually symmetrical. You can do the study in terms of stills, in terms of diastole and systole. You will see that the AV valves close in systole, they open in diastole. Right? Now that is the checklist. That entire thing is the checklist. And until I see each and every one of these features, I will not consider my study of the four-chamber view complete, right? And this, of course, is telling us the morphology, which we did in the previous slide itself, as to the attributes of the internal attributes or intrinsic attributes of the various chambers, right? Now, we also should look at color Doppler, which is a must, which is a part of the basic extended examination. Now that I've seen the heart in grayscale, I turn the color Doppler on, and in the four-chamber view, I recognize two red streams of blood reaching from the atria into the ventricles, telling me that the movement of blood flow across these two valves is normal. It's equal to each other. And also, our settings should be such, the color settings, that I don't overwrite the septum. The septum and the walls of the ventricles should still be seen, only the lumen gets filled with color. So that is important, and that is how we use color Doppler, right? Now we need to look at abnormalities that you can potentially pick up in the four-chamber view, and they can be related to chamber asymmetry, they could be related to the crux of the heart, area behind the heart, or they could be related to chamber-specific features. So we'll now look at one or two cases of asymmetry of the heart. That's a symmetric heart. All of us are very conversant with this. Let me stop this here and start off this clip. Now here you can see that there is abnormality in the heart in terms of the crux of the heart and in terms of the size of the right atrium. The right atrium appears to be large because there is a displacement of the tricuspid cusp more towards the apex. And you can see the degree of offset is exaggerated. This is mitral valve, this is tricuspid valve attachment, and it's exaggerated. And once I see this, I know that I'm dealing with Epstein's anomaly, and this large nature of the right atrium could be due to a tricuspid regurgitation. And when you play the clip with the color, you will realize that there is a regurgitation, tricuspid regurgitation, and that the regurgitation starts from deep inside the ventricle and not at the level of the AV valve. Why? Because the AV valve itself is shifted towards the apex of the heart. Now here is another example. That's the 4-chamber view of the heart that you can see here, which is normal. Now compare this clip. Now compare this clip to this clip. You will find that this chamber is not at all contracting. It is small. It is echogenic. The myocardium is echogenic. And the apex of the heart, which you can see normally, is formed by the left ventricle. You can see that here, very well seen. But here, the apex of the heart is formed by the right ventricle, and the left ventricle is pathologically small. The other factor which I want you to see here is the opening of the flap of the foramen ovale into the left atrium here. Whereas in this particular case, the foramen ovale is bulging the other side. It's bulging into the right atrium. So there are a lot of findings that you can see here, and immediately you turn the color Doppler on, you find that there is no blood flow at all through the mitral valve. And that is a classical hyperplastic left heart syndrome. And when you look at the great arterial flow direction, you'll find that the pulmonary artery is carrying blood in the normal direction, and there's a reversed perfusion of the aortic arch through the ductus. Because no blood is entering the left ventricle, no blood is being pumped into the aorta, and therefore the aortic arch through the ductus gets its fill from the pulmonary artery, very, very well in this 3-vessel trachea view, right? And I also want you to look at the difference in the excursion of the valves, the tricuspid valve versus the mitral valve. No excursion here at all. So there are a lot of findings. It's for us to go through the checklist and find and get a diagnosis. In this case, it was a hypoplastic left heart syndrome. Now let's look at this case, 4-chamber view, and one thing which is very certain is that the left ventricle, left atrium are smaller than the corresponding chambers on the right side. When I move into the 3-vessel, I find 4 vessels instead of 3 vessels. I find an LSVC, a pulmonary or the ductus arch, the aortic arch, and the SVC, the right SVC here. And when you look at the aorta, it's definitely much thinner than what it is supposed to be. Remember, in the 3-vessel trachea view, the aorta is only slightly smaller in diameter as compared to the pulmonary artery. Here it is a lot more thinner in caliber. It's almost half or to 2/3 of the corresponding artery on the right side. And that's the beauty of the 3-vessel trachea view. It allows you to compare the 2 great arteries in one picture instead of going from section to section, right? So you have a left heart, a right heart dominance, a left heart diminutiveness. You have the right artery, which is normal. The left heart artery is diminutive, and you know that there is an LSVC. Putting all this together, you do your aortic arch view, you find an aortic coarctation. That is the descending aorta, which is nice in diameter, normal in diameter, but that is the arch of the aorta, which looks lot more narrow than what it should be. The color flow tells us that the color flow is normal. right? So therefore, that's a coarctation of aorta with LSVC. And once you find the size discrepancy, you must start measuring the heart and giving out the Z scores or the Z scores of the end diastolic diameter of the ventricles, of the aorta, of the pulmonary artery, of the ductus, and of the isthmus of the aorta. So all this will actually give the cardiologist who's going to counsel this couple a great idea as to how severe is this condition, right? And it's important to know that measurements have to be done in a very standard way. Right, now here is a 12-weeker, and at 12 weeks itself, I'm able to get cardiac chamber asymmetry. The left chambers are small, the right chambers are big, the right atrium is especially enlarged, and when I look at the color shows me a huge regurgitation starting from the center of the chamber here. No regurgitation on the left side, massive regurgitation on the right side, and that's the regurgitation that you can see on spectral Doppler. This entire blue is the regurgitation, and of course the fetus had a very large nuchal translucency, and that is a classical 12 weeks Epstein anomaly. Why Epstein? Because the regurgitant stream is starting almost from the mid cavity of the right ventricle, not at somewhere that level, but deep down, and that indirectly tells me that the tricuspid valve is pushed way down, right? Okay, here is the opposite. The right ventricle is small. There is a VSD. There is a VSD over here, and the foramen ovale is pushed pushed in an exaggerated fashion towards the opposite side. Why? Because there's a tricuspid atresia. Look at the mitral valve opening and closing. Look at the tricuspid valve. It's a diaphragm. It's a sheet of muscle there, a fibrous sheet. There is no opening and closing there at all. And when I look at the three-vessel trachea view, you find that the pulmonary artery is small. The aorta is well preserved. That's the SVC. The pulmonary artery is so small that it's smaller than the SVC itself. And when you actually do the color Doppler, you will find that there is no flow through the tricuspid. The flow is all from the right atrium goes into the left atrium, whole lot of it. And that is why the flap is pushed enormously to the other side, and the whole output goes here. A bit of it gets through the VSD into the right ventricle, and the right ventricle is still pumping blood into the pulmonary artery, which is actually accounting for a pulmonary artery that is seen, albeit smaller in size, right? So moving from a chamber asymmetry, we come to the crux of the heart, and this is how the crux of the heart should be appreciated. The valvular offset is very, very important. When I show you this clip, you will understand, or you will agree with me, saying that the crux is absent. So let me take you to the bookmarks. That is with the AV valve closed. There's only one orifice, AV valve closed. You realize that there's an inlet septal defect, and also a primum atrial septal defect, inlet ventricular septal defect, and a primum atrial septal defect, right? And when I go to the valve open, there's only one valve orifice which is opened by those valve leaflets, and in the open state or the diastole, you find a great big hollow in the center of the heart, a hole in the center of the heart, compared to here, which is normal, right? So that's normal, that's abnormal, and that's a hallmark of a complete balanced AVSD, right? Now here is a heart which shows you that there is no offset at all. There's collinearity of the atrial valve and the ventricular valve. I'm sorry, of the tricuspid and the mitral valve. That is the color, again showing you that two streams are present, but there is no offset again here. There's an absent nasal bone ossification, non-ossified nasal bone, and this is a calcific spot in the heart. So when you find multiple markers like this, karyotyping is important. And now we have data slowly building up that just loss of AV offset without the presence of a VSD or an ASD can itself act as a marker for Down syndrome. Now here is an ostium primum ASD. You will see that the crux is incomplete. The ventricular side is complete, the septum is complete, but the atrial side, there's a gap. That's a classical atrial septal defect of the primum kind. And this is the 3D showing you the primum atrial septal defect there. Now here is a 4-chamber view which looks grossly abnormal because there is no interventricular wall here at all. There's only one single ventricle and both these atrioventricular valves are opening into one ventricle. And you can see that by color as well. You will see both these jets going into the same ventricle. And of course, there is parallelism of the great arteries out over here in the oblique view. So a double inlet left ventricle again is a contributor to an abnormal crux of the heart. You will see that the crux is not seen because the entire septum is missing, and this single ventricle could be morphologically the right ventricle or left ventricle or indeterminate. Morphological left ventricle, of course, constitutes about 70 to 75% of double inlet single ventricle. Okay, now here is an example for area behind the heart. This is the 4-chamber view of the heart. This is the descending aorta, and you find that the distance is enormous. The heart has moved forward. Pulmonary veins seen, but they are not opening into the left atrium. It's an anomalous pulmonary venous drainage that you can see here. And when I turn the probe orthogonal, turn the Doppler on, I find that this transverse vein is getting connected from the middle by a vertical vein which is going down and draining into the ductus venosus. Draining into the ductus venosus. That means this is a total anomalous pulmonary venous drainage, infracardiac variety. And where did your clue come first? The clue came first by looking at the area behind the heart, realizing that the distance is enormous and there's a vessel that is not confluencing with the left atrium. And therefore, your thought process starts. You look for the vertical vein and you have picked up an infracardiac, total anomalous pulmonary venous drainage. Right? There's a case of heterotaxy, but I don't think we have time for that. And of course, intrinsic features are important. This is the normal heart that you can see here. And this is the heart which I want you to see in this particular slide. This is the spine. This is the left side, right side. So this is the left side. And therefore, I need to look at the chamber attributes. Now, once this is the left side, and I'm actually looking at it as the left ventricle, but there's a rude awakening which is happening, telling me that the moderator band is on the left side. Therefore, this cannot, although this is the left-sided ventricle, it cannot be the morphological left ventricle. This is a morphological right ventricle. And true enough, I look at the nature of the valve here. I want to know whether it is closer to the apex, which is the tricuspid valve, or far away from the apex, so this is the mitral valve. Now I find that the tricuspid valve is the valve which is associated with this chamber. So all in all, I have evidence that this is morphological right ventricle. This is morphological left ventricle. These are the pulmonary veins which are connecting to the left atrium. So left atrium connecting with the right ventricle, morphological right ventricle, and the morphological right ventricle is putting blood into the aorta, whereas the morphological left ventricle is putting blood into the pulmonary artery. The great arteries are parallel to each other. Classical congenital corrected transposition of great arteries, a condition which can be detected or suspected in the 4-chamber view, classically because of the intrinsic chamber attributes. On the other hand, the complete TGA cannot be made out on the 4-chamber view. So this is the difference between CTGA and CCTGA, right? So you have to look for the integrity of the interventricular septum, and in this case, you find the muscular septum. There is a defect out over here, and when you do the color Doppler, you find the defect being filled with bidirectional color, red, blue, red, red, blue, red, that you can see here, red, blue, red in the multiplanar stick view that I'm showing you here. That's a mid-muscular VSD, right? Now, a mid-muscular VSD need not be always seen on grayscale, and that's one of the utilities of color. If you turn the color on a routine basis, you find that here there is a jet going across the ventricular septum. In fact, it's a bidirectional shunt. You have a lot of blue and a brief red there, and that's a muscular VSD, which is not seen on grayscale, seen only due to color Doppler assessment, right? Now, LSV connections to deal with. When I play this clip, you will realize that yes, two connections that I can straight away see is the left atrioventricular, right atrioventricular. So both atrioventricular connections are dealt with here, and there is one veno-atrial connection in terms of the pulmonary veins joining the left atrium. So three connections, two atrioventricular and one veno-atrial, the left veno-atrial are over here. So out of your 6 connections, you have managed to finish 4, and that's exactly why the 4-chamber view is of importance again. So after having gone through all the checklists that we have done, I'm just showing you the ISOPARB checklist, which tells us the same, but in a different format, right? So from there, we move on to the checklist for the outflow tract. So what is the checklist for the left ventricular outflow tract? In the left ventricular outflow tract, you must realize that there's a great artery coming out of the left ventricle. It points to the right shoulder, right shoulder. The anterior wall of the aorta continues with the atrial septum. The posterior wall of the aorta continues with the mitral anterior leaflet of the mitral valve. The aortic valve is blinking. It is not seen as a constant structure. It appears and disappears, which is absolutely normal. The cusps are thin, and the ascending aorta is not going to show you any branches because it doesn't have branches. The ascending aorta does not branch at all. The branching occurs in the arch of aorta. So these are the checklist points that you should run through the LVOT before you say my LVOT is done, right? Now here, let's look at this LVOT here. Look at this LVOT here. The aortoseptal continuity is lost. There's a gap out over here, and that is a membranous VSD, right? That's a membranous VSD, and here you have an overriding aorta and a malalignment VSD. So you have the differential diagnosis of whether this is a tetralogy of Fallot, an absent pulmonary valve syndrome, or whether it is a PAVSD, pulmonary atresia with VSD, common arterial trunk, or a DORV, right? So the crisscross is important when you do the outflow tracts. Now I'm going to take you through a real-time sweep, and I just want you to concentrate on the LVOT, which is in this direction, and the RVOT is in this direction. To facilitate that, I'm going to use bookmarks. The first bookmark is LVOT. I have taken this picture, pasted it here, and put the straight line along the aorta LVOT. The second bookmark is the pulmonary artery or the ductus arch, which I've pasted here, and I've drawn the ductus arch, that is the right ventricular outflow tract, in using the blue arrow. I have taken the red arrow and the blue arrow and placed it or juxtaposed them or superimposed them. I realized that the great arteries are perpendicular to each other. So looking for perpendicularity, there are many ways to do it. One way is to look at it real time. real time. Another way, if you're not convinced, is to actually do this kind of an stop stills and looking at the axes and working out the perpendicularity. But with practice, you will see with your sweep, you will be able to make out whether the two outflow tracks are actually crisscrossing or not. Remember, the LVOT points to the right shoulder, but the RVOT points directly to the spine. We'll come to that in a short while now, right? Now, here is a clip which I'm playing, and as I'm sweeping, you will realize the great arteries are parallel to each other. There is no crisscross at all. And similarly here, you look at this four-chamber view. As I come up, the aorta and the pulmonary artery are parallel to each other. So let me take you, that's the four-chamber view of the heart, and this is the parallel relationship. So once you do your sweep and your eyes are glued, you know that there is a parallelism which is occurring here. So with the left ventricular outflow tract, you have added one more junction, which is the left atrioventricular junction. So you have finished 4 junctions. Then you come to the right ventricular outflow tract, and in the right ventricular outflow tract, you will realize that the pulmonary artery is a direct posterior course, and there is an axial branching. In contrast to aorta, which does not branch in the LVOT, in the RVOT, especially if you're doing a RVOT, which is a short axis RVOT or a 3-vessel view RVOT, you will find the branching very well. You can see the branching here, branching there very, very well, and the direct posterior course as the ductus arteriosus coming into the aorta, right? Again, mark the pulmonary valve. It is blinking, comes in, goes out, comes in, goes out, and the cusp is extremely, extremely thin, as you can see here. Very, very thin cusps, right? So the substernal right ventricle giving rise to the great artery. That is your checklist for the great RVOT. Now here I've got a case which shows you an RVOT, but straight away you will agree with me telling me that this valve is abnormal. The pulmonary valve is thick. It is not appearing, disappearing. It is seen constantly throughout the cardiac cycle. The heart itself is a little enlarged. You can realize that as well. And when you actually look at the color, you have intense aliasing, which is occurring here. In the forward flow, that's the blue flow, there is a little helical flow because the pulmonary artery, main pulmonary artery, shows you flaring post-stenotic. And what more, there is a leakage of blood back into the right ventricle in terms of a pulmonary regurgitation. So you have a regurgitative lesion here, a pulmonary stenosis, which is critical, and the velocities through the pulmonary valve are reaching up to 210 centimeters per second, which is telling you that this is a critical PS or a pulmonary stenosis, right? Now here is a PAIVS. Again, here the right ventricle is small. It is not contractile. The tricuspid valve is not getting opened and closed. The mitral valve is nicely opening and closing. And when I do the right ventricular outflow tract, you find that the right ventricular outflow tract is very well seen. But let us see what is the surprise the color has. The aorta is taking blood in the antegrade direction, but the pulmonary artery, instead of coming in the same direction that is blue, is showing me red, telling me that this is ductus dependent flow into the pulmonary artery. And why should the flow be reversed in the pulmonary artery? It's reversed only because the pulmonary artery is atretic. So this is a pulmonary artery. This is a pulmonary atresia with an intact ventricular septum. That's an intact ventricular septum that you can see here. And of course, when you do the color Doppler on the 4-chamber view, you find that the entry of blood through the tricuspid valve is very, very limited, but there's a good huge tricuspid regurgitation which is occurring. So in the four-chamber view itself, we have a lot of clues in terms of a hyperplastic right heart, in terms of limited entrance of blood into the right ventricle, and of course a holosystolic tricuspid regurgitation that you see. The cause of this tricuspid regurgitation and the right ventricular findings are very, very evident when you understand that there's a reverse flow in the pulmonary artery telling you that this is pulmonary atresia. So once you're done with the RVOT, you've added one more connection. So 3 + 1 + 1 is the figure 5, and you have finished 5 of the 6 connections. What is remaining is right veno-atrial. You can do it in the hammock view. You can see the SVC coming into the right atrium, IVC coming into the atrium, right atrium there, showing us that this is normal. But in day-to-day practice, if I've demonstrated 5 junctions to be normal, I don't need to add on to this view, because I've already seen the IVC in the upper abdomen, and I'm also going to see the SVC in the 3-vessel view, which we will deal with now. So the 3-vessel view, you have the SVC here. So SVC in its proper position, IVC in its proper position tells me that all is fair with the IVC, SVC, and the right atrium. So in the 3-vessel view, it's the pulmonary artery, aorta, SVC, which you see over here from the left to the right side, size-wise, biggest, intermediate, smallest, apex of this V to the left of the spine. And this view enables me to compare the aorta with the pulmonary artery. You can also see the thymus and the lungs in the same section. On color, you must demonstrate both the vessels taking color in the same direction from anterior to posterior. Why are they V-shaped? Because both the ductus arch as well as the aortic arch are converging towards the descending aorta. This is the trachea. So left-sided ductus arch and aortic arch, that is normal. So color Doppler is important in all the sections from the 4-chamber to LVOT to RVOT to 3-vessel trachea view. Right. Okay, now here is a 3-vessel trachea view. You can see that this is a CCTGA and PIVS. That's okay. So you can see the common arterial trunk here. You see the aorta and the pulmonary artery arising from posterior aspect. When you go to the 3-vessel view, you have only one artery there instead of 3 vessels. You have only 2 there. You have only 2, right? So you have the aorta here, you have the SVC here. What happened to the third one? The third one is actually coming from the common arterial trunk. You can see it in the long axis views. And here in the short axis view, when I go from the 3-vessel view down below, you can see the pulmonary artery emanating. So common arterial trunk is classically a condition where in the view, you may see only 2 vessels, and the same thing happens in the pulmonary atresia with intact ventricular septum. We saw a case there where the artery was big. You can also have cases where the pulmonary artery is small, where there are major aortopulmonary, very small, where you don't get to see the artery on the grayscale itself. Only on the color Doppler, you will find that this reversed perfusion is occurring into the pulmonary vein, right? So when you have more vessels, it is the persistent left SVC that you are concerned with. That is the coronary sinus. So the extra vessel is always to the left of the pulmonary artery that you can see here. So there are 4 vessels in the 3-vessel trachea view. The differential diagnosis is supracardiac TAPVC. So you also have an extra vessel here, but in LSVC, you have a prominent coronary sinus. You have a prominent coronary sinus in the 4-chamber view, and you have a bleb sign here. Whereas in the supracardiac TAPVC, you have an anomalous pulmonary vein here, and there is an increased area behind the heart, which distinguishes and tells you that this is a supracardiac form of TAPVC, a vertical vein, whereas this is a persistent LSVC. So, so therefore, we have to consider there are a lot other lesions which I can show you in the 3-vessel trachea view. For example, all the 3 vessels should be organized and seen in one straight line here, whereas here you can't. In TOF, the aorta is anteriorly displaced, it's large, you can't draw a straight line. So there are a lot of other skills that you and findings that in the 3-vessel trachea view that can be of great importance to build up your case for a diagnosis. So therefore, in conclusion, we need to have the fetus in a proper position, operator skill, and most importantly, study protocol for each plane is important. Whether you're going to proceed to a full-fledged fetal echocardiography, or if you're happy with your diagnosis and of normality or abnormality, will you stop there? And once you find an abnormality, are you going to do a karyotype, chromosomal microarray, clinical exome sequencing? You'll have to think of chromosomal syndromes. You've got to think of single gene syndromes. You've got to get a genetic counseling done. And of course, a pediatric cardiologist is actually central to counseling, telling this couple the gravity of the situation and the postnatal possibilities of therapy that are open, the morbidity, mortality associated with such therapies. All this is best communicated to by the pediatric cardiologist. So the first abnormality is very, very important. And then you can go on to the other abnormalities step by step, put everything together and get your diagnosis. In this sense, fetal cardiology is more of a mathematics. If you have 1 + 2 + 3, it is 6. Right? That mathematics is good in fetal cardiology, unlike in the fetal brain. So documentation, clips and stills are extremely important. Thank you very, very much for a very patient listening. Thank you.
Thank you so much, sir, for giving us such a detailed talk. Since we are running short on time, we'll not take a coffee break, sir, and we'll directly go to the panel discussion, sir. For panel discussion, the topic of our discussion is image-based decision-making for deliveries. We have the moderators for our panel discussion is, of course, Dr. B.S. Ramamurthy and Dr. Chinmay Rath, ma'am. Sir, kindly introduce our other panelists who are in this panel discussion.
Would you want to do it, please, Dr. Chinmayi? Would you want to?
Sir, please be there, sir.
Yeah, I'll be there. No, not an issue. I'll be there. I'll be there. Thank you.
Because the topics that they have given are very, I mean, there are no clear-cut guidelines to say yes or no. So I want you as the referee there to tell us when we are stuck, whether yes or no.
Sure enough.
Yes, sir. So it's been a brilliant day actually today. I've been listening to, I'm actually cheating on my clinic because I'm sitting here and listening to the sessions. And it's really been so nice. All the sessions today have been so informative that I'm sure the audience by now is quite enlightened. And we have a very nice panel of experts with us, Dr. Jyotsna Rani Panigrahi, Dr. Preeti Dubey, Dr. Sucheta Agarwal, Dr. Shashmita Das, and Dr. Soumya Srivastav. Actually, I don't have their CVs here. Do you have the CVs? Do you want to present them, Preeti?
Ma'am, we have the CVs. I'll project it on screen.
Yeah, I'll just stop sharing. Will you please project their CVs,
Yes,
please? So I can see Dr. Soumya, I can see Preeti. How are you doing, Preeti? Holding on. Dr. Sashmita and Dr. Jyotsna. Hello, namaste. Dr. Jyotsna, we cannot see you.
Am I audible?
Yes, you're very much audible. Why don't you become visible as well?
Am I visible now?
I am not so sure. Yeah, now, yes. Yeah, that's nice. Nice. It's an imaging topic, so we need the image.
Ma'am, can you see the CVs now?
Yes, yes. So I'm sure Dr. Jyotsna doesn't need any introduction in a ISOPARB conference that is being held in Bhubaneswar, because she's really taken the leap, going on and specializing in fetal medicine and starting a very reputed fetal medicine center in Cuttack. And she is also a very active member of all our fetal medicine societies. And we keep meeting and hearing her on various occasions here. So welcome, Dr. Jyotsna, onto the panel. And your special interests are first trimester scan, fetal echo, and fetal growth restriction, but I'm sure you do a lot of other things also. So that's nice. Welcome to the panel. Can we have the next slide, please? Can we have the next CV, please?
Yes, ma'am. Just a second.
So Dr. Preeti Dubey, it's really a joy to introduce her. She needs no introduction. She has introduced us to the Orissa peer group so often, and a very, very dear friend, very dynamic fetal medicine doctor who really doesn't take no for an answer, and she always tries to improve the standards of scanning and services in Orissa. She is the director of the Orissa Fetal Medicine Center and has organized a number of very, very well designed scientific programs in Bhubaneswar. Thanks to her, we've been visiting Bhubaneswar very often, and she's received the Amarendranath Dan Prize for the best paper in maternal and child care by Foxy in 2012. And I'm sure her best is yet to come. So wish you all the best, Dr. Preeti, and seeing your CV to become bigger and bigger in years to come. Can we have the next CV, please? Dr. Suchita Agarwal, she is a obstetrician and gynecology with a fellow in advanced obstetric ultrasound and a fetal medicine consultant at the Amri Hospital in Bhubaneswar. She is a member of the Society for Fetal Medicine Orissa and ISWAG, and her presentation on follow-up of fetuses with DORV in the Fetal Cardia Conference was very much appreciated. And that's quite a nice, I hope you had a good number. Dr. Ramurthy is here, and I'm sure he'll give you some insights into DORV. And fetal neurosonography, fetal echocardiography, and genetics are her special interests. So welcome on board, Dr. Suchita.
Yes, thank you, ma'am.
But we can't see you again.
Ma'am, there's a problem in the video, ma'am. I'm just starting now.
Okay, please do that. So the next CV, please. Dr. Shashmita Das. She's an MD FICOG from the Department of Obs Gynae of the SUM Hospital, and life member of Foxy, SFM, and ISOPARB with several publications in national and international index journals. She's trained in fetal ultrasound by the FGI, and her areas of interest are high-risk pregnancy and fetal medicine. Welcome, Dr. Shashmita.
Thank you,
and Dr. Soumya Srivastav.
Yes,
She's a PD certification course from the SGPGI Lucknow, and she runs a fetal medicine center called Sanskriti Fetal Medicine Clinic, Hazaribagh, and works in Santevita Hospital in Ranchi. So member of ISWAG, Society for Fetal Medicine, and Foxy, an FMS certified operator, and has won the CS Don Best Paper Award at the 11th NARCHI World Congress. So congratulations and welcome to the panel. So we have really young, dynamic, and dedicated fetal medicine doctors here. And can I start sharing my screen, please?
Yes, ma'am. I've stopped sharing my slides.
Yeah, thank you. Thank you. So our topic is image-based decision making, but we were given not much to choose from. So I tried to put together some clinically relevant points, which I'm sure all of you face in your day-to-day practice, and you take decisions based on whatever images you've taken, but with a good clinical backing. So I was thinking, why did we have this discussion on image-based decisions? Because just like an idea can change your life, suddenly you're sitting and you get a bright idea and something changes in your life, an image can change the course of a pregnancy. So interpretation of these images is vital, and theoretical possibilities and practical situations need to be analyzed rationally. Your pregnancy and delivery decisions hang in balance depending on what your image is suggesting. So we have to take our imaging little seriously. At the same time, we have to understand the clinical background that goes on. So this is the first case where there is a lady who is about 24 weeks, 4 days pregnant, and she has like all her biometry is falling below the expected centiles. So Dr. Preeti, would you like to start? What do you think is going on here?
Her BPD HC falls below first centile.
All of the biometrical parameters are below the first centile. Her overall weight is 343 grams. And this is how the imaging is looking like.
First of all, I want to see her first trimester scan. If there is any dating of...
No, first trimester scan was done, and I don't have the pictures here, but her dates are confirmed. There is no dating issue here. But if you see these images, do you want to comment on that placenta?
Yeah, the placenta is enlarged, and there is having areas of hemorrhage and necrosis seen within the placenta. That looks like a very bad placentation. There must be some placental insufficiency, I suspect.
So there is oligohydramnios, there are echogenic bowel, and in presence of a normal fetal anatomy, because of the images of the placenta that you see here, you are thinking in terms of early uteroplacental insufficiency. Dr. Soumya, what would you think are the common causes of very early onset IUGR?
Most common will be chromosomal abnormality and followed by fetal infections, which includes mainly toxoplasma, CMV infections, and even rubella may cause an early onset IUGR, as well as a very severe uteroplacental insufficiency from early on in pregnancy may also lead to early onset IUGR. And maternal nutrition is definitely a factor, but usually responsible for late onset or later after 30 weeks of gestation, where maternal nutrition anemia may be a reason for IUGR.
So you're thinking of all these things, but when you, in this particular case, those kind of problems were ruled out because of different tests that were done, but early onset uteroplacental insufficiency was possible. And the reason it was possible was we saw the kind of large jelly-like placenta. Dr. Shashmita, do you see these kind of placentas often in your practice?
2 cases we get. 2 cases with chronic hypertension, with antiphospholipid antibody syndrome, not treated, and PIH rarely, but with chronic hypertension we get such placenta.
So you do see this placenta differently. And Dr. Jyotsna, how do you describe the image of this placenta?
Placenta looks inhomogeneous, and there is that is the only thing, and it looks large as well. So it is there is placentomegaly, and there are multiple cystic lesions, and increased placental thickness may be there, and multiple cystic areas inside the placenta.
So we suspect something like mesenchymal dysplasia in these cases. So here the baby had growth restriction. There were multiple possibilities for that growth restriction, but because the baby was structurally otherwise normal and this placenta's image was looking so phenomenally different the possibility of a very early onset uteroplacental insufficiency was considered. And then she was followed up, but gradually the Dopplers became worse and worse, because even at 22 weeks, she was having an absent and reverse diastolic flow in the umbilical artery. Estimated fetal weight was less than 3rd centile. She was already on ecosprin based on her first trimester screening. And she was counseled about the guarded prognosis. and we asked her to come after 1 month. Would anybody differ from that decision? I mean, would you want to call her earlier or at 22 weeks? That is the picture that you're seeing there. So based on the findings at the 22-week scan, would you do anything differently rather than call her early or call her after 1 month? We decided to call her after 1 month.
Because the umbilical artery.
Umbilical artery is showing absent and as flow.
So a very guarded prognosis
call
was
her after 1 week rather than calling after 1 week.
But if you call her after 1 week and it shows the same thing, again you call her again and you don't offer anything different. That was one of the reasons why we called her after 4 weeks. This was discussed with them. The problem was we can't deliver them. See, the reason you call people after 1 week when you see an umbilical artery absent or reverse diastolic flow is because you are thinking in terms of delivering them before an IUD happens. But at 22 weeks, we could not think of those possibilities because we would not deliver her even if that got worse. So our rationale of calling her back after 4 weeks was that if it survives till 4 weeks and things are still going on, then probably we will think in terms of delivery and neonatal support. But a guarded prognosis was explained, and unfortunately, it actually, by the time she came, it was already an intrauterine fetal demise. So in such a case, after having seen the picture of the thing that it was, what would you offer in terms of postnatal investigations? Dr. Preeti, you want to take this?
Yeah, first of all, I want to know whether FTS was done or not.
It was done and there was low PAPE.
No, low PAPE, yeah. That because of that, there is placental hemorrhage and she has landed up in trouble. Was the aspirin 150 milligram was started immediately?
It was started. It was started.
But in few cases, it doesn't work. So first of all, I will ask I will explain the cause of the IUD and I will explain the couple that the risk of such problems can exist in the next pregnancy as well. So they need to do detailed evaluation for the fetus as well as for the placenta, including fetal autopsy. And if possible, we can take fetal autopsy. We can do fetal thigh muscle. We can cut those muscles and we can give them for karyotyping and if possible for microarray to know any chromosomal association of that. And we will do detailed placental examinations and fetal autopsy for the next pregnancy and for the couple to help for the next counseling.
So you will try and do tests in the postnatal period still so that you can optimize conditions in the next pregnancy. Now here we had the scenario where there was oligohydramnios. The placenta was very big and there was oligohydramnios on the report. Now how exactly do we look at fluid in the second trimester? Dr. Shashmita, do you want to take this? What is the ideal method of doing fluid assessment in the second trimester?
Second trimester, if around the fetus the fetal structures are seen adequately, then that is roughly visually good. And if we want to take a single vertical pocket of amniotic fluid of 4 centimeter, it's sufficient. If we want to take one single vertical pocket, we can measure.
Okay, does everyone agree?
Actually, it is better to.
Let's go one by one. Dr. Jyotsna?
Yes, it is better to take the maximum vertical pocket, but as well we can measure the all 4 quadrants. But one should be very, very particular with not putting any pressure on the probe so that the measurement will be wrong. That is the most important.
And what is the cutoff that you will take for a single DP spool?
It is up to 8 centimeters.
And minimum?
2 to 8.
2 to 8.
Yes.
So at least 2 centimeter and
Okay.
maximum 8 centimeter for you to call it as oligohydramnios or
Yes.
polyhydramnios based on a single deepest pool. But what my question is, in second trimester, is it essential to do a AFI assessment or a subjective assessment is enough?
You can do eyeballing. You can do eyeballing. And
So,
if the baby is moving well, that again indicates that there is fluid is adequate. And if you can subjectively assess that fluid is normal, you can leave that. But in some situations, you are directed to estimate the fluid pockets. There are few situations, as in twin.
I think both of you said the same thing, that if you are able to see the fetus moving very well and you are able to analyze all the structures, then you can assume safely that that amount of fluid is enough for the fetus inside. However, if you don't feel that this is the case and you want to put an objective value to it, then you will measure it. You can either measure by a single deepest pool or by 4 quadrant. Now, there are two ways of measuring it, and all of us are saying we can do this also, we can do that also. Which is a better method? What are the advantages and disadvantages of single deepest pool and 4 quadrant? Dr. Soumya, do you want to take this?
Yes, single deepest pool is the most recommended method, but if when subjectively, if we are seeing that the lighter is less, and then if we are relying only on a single deepest pool, then our reporting or the representation of our report might become wrong at that stage, because we can get a single pocket which might be the only pocket of about 2 centimeter or 3 centimeter. So an overall assessment of the Leica should also be mentioned at the same time, that overall it appears reduced or increased. But for second trimester, single deepest pocket for objective representation is sufficient. And wherever we are thinking of an increase where subjectively it appears that the Leica is increased, then 4 quadrant measurement is better, especially beyond 24 to 25 weeks gestational age. I think a 4 quadrant measurement and mentioning it in the report is better.
So I think that's good that you have said that if you want to rule out oligohydramnios, a single deepest pool is better, because you will not overdiagnose oligohydramnios if you're doing a single deepest pool method, because at least one pool if you get which is of sufficient depth, you can avoid the diagnosis of oligohydramnios. Whereas if you're trying to rule out polyhydramnios, you may be underdiagnosing. If you're doing a single deepest pool, it may be better to do a 4 quadrant.
Overall assessment.
But whatever, the single deepest pool has been considered a better method because it avoids false positive diagnosis. It avoids overdiagnosis of lighter abnormalities. So, and the method of measurement is pretty straightforward, but because we were asked to cover this in this thing, I have put that. I think one of you can explain. Dr. Sashmita, I think you can just explain it, the method of doing AFI.
Like the abdomen with the baby, which should be divided to 4 quadrants, taking the umbilicus vertical and transverse. Among the 4 quadrants, the maximum vertical in that quadrant and without any pressure should be taken as the, and there should not be any fetal part or cord loop in that pocket. So that is for a single pocket, and all 4 quadrants should be measured and added.
So the probe should be perpendicular to the surface where the woman is lying, and the movement has to be like this, not like tilted on the sides. And then you hypothetically divide the amniotic cavity into 4 quadrants and take the single deepest cord-free, limb-free pocket in each vertical pocket in each quadrant, or just one, and consider that. So that is exactly what we have said there. And in terms of the deepest pool, the cutoffs are less than 2 centimeter for oligohydramnios, more than 8 centimeter for polyhydramnios. So in terms of 4 quadrant, it's something 5 to 25 or 5 to 24 is what is the limits that are taken. In terms of deepest pool, it is 2 and 8 centimeters. So I think that should sort out the confusion regarding fluid measurement techniques to the audience, which the organizers were very particular about. So Ramurthy sir, you want to add something here, sir?
I think we've taken the discussion in the right direction. There's just one point which I want to make. In the second trimester, especially when you're dealing with the kind of IUGR case that you showed, dividing the uterus into 4 quadrants itself becomes dicey because the whole uterus is not that big. So when you try to say I'm in the upper right quadrant, your transducer is so big that you might be straying into the lower quadrant as well. So for that alone, I would rather prefer to do the vertical depth of a single largest pocket rather than the 4 quadrant index. If you want to do it in polyhydramnios and the uterus is big enough, yes, that's a different thing. But in the classical case of an IUGR with oligohydramnios, where you want to quantitate, I would rather depend on a single depth of the single deepest pocket. And it's best that we do it with the colored Doppler box open, as you have rightly shown in this picture, the picture to the right side, because you can sometimes think of it as a fluid pocket, but it's completely clogged up with the cord. So I would trend to do the single deepest pocket rather than A5, especially in the case of second trimester IUGR, where the uterus is small.
Absolutely correct, sir. And I think that's a very, very practical point that you pointed out regarding that color flow, putting the color flow on, especially when we are trying to rule out oligohydramnios. And the only important thing that I feel is whatever we use, we should continue using that same thing and comparing that same parameter in future. Because sometimes you write AFI and you write AFI5 and oligohydramnios, that is not correct if you're doing it by the deepest pool method. If you're doing a 4 quadrant, then that time might be correct. So it's a good practice to mention in your report what method you have used, whether you have used the 4 quadrant method or the single deepest pool method. Now, this is again for just general information. Dr. Soumya, common causes of polyhydramnios, would you want to enlighten us about?
The most common cause is definitely maternal diabetes, which incidence currently is has greatly increased and is one of the most common causes. And these are followed by fetal infections, fetal anemia, structural abnormalities of the fetus, particularly those that interfere with fetal swallowing, fetal neck masses, esophageal atresia, duodenal atresia, or neural tube defects, which may cause an increased liker, as well as certain chromosomal abnormalities. Even without any structural malformation, we may find an unexplained increased liker. And infections, similarly, toxoplasma, CMV, even varicella infections can cause an increased likers. And twin-to-twin transfusion syndrome in monochorionic twin pregnancies is another reason for an increased liker polyhydramnios. Fetal anemia, I think I missed out. Yeah, fetal anemia, which may be related to the infection or RH isoimmunization, where we can find polyhydramnios.
Basically, what I can take from your message is, if you see polyhydramnios on a scan, your image will be polyhydramnios. But the thing is about decisions based on imaging. So once your image is there, you need to give a comprehensive analysis whether you saw anything else which is suggestive of any of these causes. So I think there should be a checklist while reporting polyhydramnios, where all those anomalies which you mentioned, that there's a good side stomach bubble, the lips and nose are seen normally, the palate is seen properly, spine is normal, so that whatever we can rule out, we can rule out. Rare causes we may not rule out. Even to this day, connected tracheoesophageal fistulas, we may not be able to rule out completely on antenatal scanning. So lower anorectal malformations, we may not be able to rule out. So it's a good idea to write that in the thing. And whatever we can rule out in terms of infections and genetic syndromes, to the extent possible, we should mention that. So otherwise, the reporting is incomplete, and it still leaves a lot to be, to confusion and other issues. Similarly, oligohydramnios is the other problem. So I'll go to Dr. Shashmita. What do you think are the common causes of oligohydramnios in our regular practice that we deal with?
Fetal growth restriction is one of the commonest. Then in second trimester, renal anomalies, and like other placental insufficiency I have told, and maternal, like chronic hypertension, antiphospholipid antibody syndrome, like maternal causes. and this twin to twin transfusion syndrome, selective fetal growth restriction in twins, and this smoking, this can cause oligoamnios. Along in many cases, it is associated with fetal growth restriction and anomaly.
So, Dr. Jyotsna, when you are reporting oligohydramnios, would you like to again elaborate all this in your report?
So first I should ask the question to the patient, is there any history of leaking? That is very important, and this should be noted. And the second is, I should look for the previous report, whether the amniotic fluid was normal in the previous report, whether it is reducing. Third thing, I want to see that, because the amount of amniotic fluid usually comes from the kidney after 16 weeks. So if there is anomaly in the kidney, renal anomaly, I should find out. If I find any renal anomaly, I will go accordingly. The main cause being could be ARPKD. Accordingly, I will search for. And after that, I will go down to see the bladder, whether the bladder is of normal size or not. If there is bladder is absent, or there is small bladder, or there is large bladder, accordingly the cause will be determined. And the next I will look for the lungs. Due to oligoamnios, is there any sign of pulmonary hyperplasia or not? Because my decision depends on that. And then I will go for the Doppler of the baby if it is normal. And first of all, I should see the correct dating and the weight of the baby and the growth. These are things. And skeletal dysplasia may at times associated with polyhydramnios, but it could be with also oligo, but usually it manifests with polyhydramnios. So then I will look for the placenta. The placenta is good enough, and the blood supply, umbilical artery, and everything is good enough or not. And then
fetal medicine assessment, while you are assessing Liker, if it is normal, then it's fine. If it's more or it's less, then you definitely try and include all the etiological points in your report, either ruling them out or ruling them in or keeping them as a differential diagnosis, so that it is just not an imaging report, but a report which will make clinical sense to the obstetrician, and some decision for further antenatal care can be taken based on that. So that particular case that we had, of course, things were not good. The fluid was, I mean, the Dopplers were also bad. But suppose things are not as bad as you need a delivery, but the Liker has suddenly come down. Do we take a decision for delivery based on AFI alone? Should we do that?
It depends on the gestational age actually.
Okay, suppose the gestational age is 38 weeks.
38, 39 weeks you can, and if the Doppler and everything is normal, you should take a decision. Oh, that your question is alone.
My question is alone.
Alone, if there is severe oligoamnios at 39 weeks or 38 weeks, you can take a decision to terminate the pregnancy.
Yeah, but then we won't detect it unless we were scanning for fluid at 39 weeks, which we won't do normally, isn't it? If a pregnancy in today's day and age, despite all of us, reaches 39 weeks, then I mean,
even if 37 weeks, after complete 37 weeks, you can terminate the pregnancy. But nowadays, according to Barcelona, they are saying it can continue up to the 39 weeks.
Yes. So, what does my panel say? We have 4 extremely important people there.
No, so for alone AFI is less, we should go for a non-stress test.
So you're
along
not
with
going
that.
to. Yeah. So you are not comfortable with AFI alone. You want something else.
Yes.
Preeti?
And at least
Preeti
we can.
is very good at scans. Preeti, if she says AFI is less, it is less. So if Preeti says AFI is less, can we go and deliver?
No.
No.
If the CT is reactive, we can continue the pregnancy and wait for spontaneous onset of labor.
Okay, she's more ambitious. So 3 out of 4 want to do something else. So Dr. Soumya?
I would also like to wait and see and assess other parameters as well. What can be the reason for a reduced Liker? If everything else is normal, if maternal parameters are normal, then we can always wait and watch if fetal movement is
Suchita, I
good.
think because we can't see her, we are not asking her. So Dr. Suchita, are you still listening to us?
Yes, ma'am. My video is on, ma'am.
Oh yeah, now we can see you. Thank you.
Yes.
Okay. So what is your take on this?
Ma'am, I would like to see the first. I will see the growth, whether the growth is okay or not, the interval growth
Everything
is
else is
maintained or
okay.
not.
It's AFI.
Ma'am, except AFI, if the AFI is less than 5, and decision making has to be done. Otherwise, if it's more than 5, then I think we can wait and watch and tell the mother to keep a strict watch on the
Okay, if AFI is less than
movements.
5, will you go ahead and deliver the baby?
Yes, ma'am. If the baby, if she has reached 38, 39 weeks, I think we should.
So again, it's not, you waited till you found out the gestational age of the mother, and she's reached 38, 39 weeks. The AFI is now 4.5. Will you deliver the baby today or tomorrow or by section right now or by section tomorrow morning, 9 o'clock? What will you do?
Ma'am, that again, that NST, ma'am, I think NST plays a role in
So
this case.
that is where you all have to think that it is not the liker alone.
Yes.
So it's not the liker alone. You have to look at the entire clinical picture. Gestational age is very important, but even if gestational age is important, you know, when we see a patient at 37 or 36 weeks and we've done the last scan at that point and she comes in labor later on, we really don't know what is the actual liker at that point. Nobody does a scan at the admission in the labor room. So that may be a physiological reduction in that fluid. So just looking at the fluid and jumping and doing a delivery right now won't be a good idea, but we should look at it. And at that stage, after 36, 37 weeks, doing an NST and checking if the baby is comfortable inside makes more sense than just jumping in, delivering based on liker alone. So that case where there was liker was less, we already had that discussion earlier, but I'd put it again that would we have done anything differently at that point? Suppose all of you had said, yes, if there was oligo, we should have delivered. So could we have done anything? We couldn't have, because at 22 weeks, we would not have been.
Madam.
Yes.
Hello. Actually, I want to say in 2-3 cases after this, like not absent end-diastolic flow, but with increasing umbilical artery Doppler, I have done this antiphospholipid antibody syndrome. Few cases have come positive, and after adding enoxaparin, they have responded well. I could continue up to 30 to 34
you
weeks.
should record your findings and see how they work.
As
of now,
it's
as
not
of,
a recommendation, only.
as of now, we are still wary of doing the thrombophilia profile in pregnancy itself, because pregnancy also changes the parameters. So when we have to screen for antiphospholipid antibodies and all, the current recommendations stand to do it 6 weeks after the delivery.
Yeah.
So that, you know, the pregnancy related changes are gone. So that's an interesting thought, but that's for another discussion. So we'll move on to one more.
Can I have a word here?
Yes, sir.
Now, estimation of amniotic fluid in the third trimester, especially during the last stages of the third trimester, there's a gross overcalling of oligohydramnios. We have enough literature and we have enough meta-analysis and systematic reviews to tell us that. So there is a trend to overcall oligohydramnios by doing an AFI. And therefore, if you notice all the protocols, tell me one protocol which includes Leica volume as a parameter of surveillance or as a parameter to precipitate delivery. Not one of them. Are you all in agreement with me?
Absolutely.
It's
part of the biophysical profile.
That's it. And remember, biophysical profile and NST is the gold standard, is the last thing to change.
Yeah.
Whereas you have another very powerful tool in terms of Doppler. When you say only AFI abnormal, all other things are normal, I assume that the Doppler was normal. When Doppler is normal, there is no question of an NST showing you an abnormality. There's no question. You have a long way till the NST is going to turn positive. So therefore, I still feel that oligohydramnios doesn't have a big say in surveillance, doesn't have a big say in calling for delivery, though I'm not an obstetrician, though in practice, interacting with obstetricians, I know a lot of obstetricians who deliver just because of oligohydramnios upwards of 37, 38, 39 weeks. You know, I have seen that. I really do not know on what basis they do it, but as far as fetal medicine and fetal well-being goes, I don't see any big role for Leica to actually precipitate the decision to deliver.
Sir,
that's all.
with gross oligohydramnios, it is not the antenatal problem. The fetus can cause the intrapartum problem if we are allowing for delivery because of cord compression. That's it.
Yeah,
And that
so
will be detected by a non-stress test when you're doing the
Non-stress
CTG.
test.
That's why we
Sure.
do a non-stress test to monitor during delivery.
Yes.
No, like sir rightly said, that's an important thing, that we should not take a call based on the just oligoamnios, but more
Just
importantly, sir, the reporting of oligoamnios is also equally variant. So that is why we clarified that either we do a single deepest pool between 2 and 8 or an AFI between 5 and 25, because sometimes I have seen single deepest pool 5 centimeter and oligohydramnios. So that the understanding of that oligohydramnios needs to get better. And physiologically, the fetus is able to take care. Nature has made the umbilical cord very slippery and contractions as only intermittent phenomenon. So there is a method of overcoming that. If it doesn't happen, then the CTG will tell you. So intrapartum monitoring only by the methods of computerized or non-computerized CTG.
Chinmay, just I want to add one thing.
Yeah.
I have faced so many, I've got so many cases of oligoamnios in the last trimester. But to me, the most important is revisit your technique and calculate it again. Don't put pressure. Put the probe correctly vertical to the plane. Then even if I will do thrice, my report will be changed.
No, very important points. I think what you all are bringing us to the final take-home messages, which I had thought of, because in imaging, one of the most important things is image correctly, and then, of course, interpret it correctly. So both the things that have been highlighted in this Leica assessment discussion. Thank you. So here is another case. I think Dr. Sucheta, you haven't got a chance to say much so far. So she is primary, 23 weeks, 6 days. I'm just going to switch on. With no medical or obstetric history significant so far, no scans, no ANC so far. Checked for book for the first time. I'll just get it. Has it come?
Not yet, ma'am.
Are you able to see the slide? No.
Yes.
Yes.
They are able to.
Okay, Dr. Sucheta, I think it's at your end. Everyone else is able to see the slide?
Yes, yeah. I'm able to see the slide.
Okay.
Can able to see the slide.
Oh, Dr. Sucheta is not able to see the slide. So nothing, it's just basically a woman has not had any antenatal booking in the first trimester. She's come directly in the 4th month. And from her last period, it is about 24 weeks and the scan shows severe growth restriction. Everything is falling less than 5th centile. What is the next thing to do?
Then first of all, since she doesn't have any first trimester scan, so dating scan is not there. So I'll first ask her whether she's sure of her LMP or not. If she says yes, then it's okay. I'll take it as a growth restricted. Otherwise, I would also look.
She says yes. She remembers her LMP. No, we can't hear you. You're muted.
Okay, ma'am. Okay, ma'am. Yeah. Yeah, ma'am, I will consider it as a growth restricted baby only and ask her. Yes, ma'am. I'm not able to see the slides, ma'am, actually.
So very early onset growth restriction, early symmetric IUGR, you're thinking of?
Ma'am, again, I will see the uterines, ma'am. I'll see the uterines. I'll see whether any placental insufficiency is there or not. If it's an increased uterine RTPI, it may be due to
utroplacental insufficiency. You will think of chromosomal abnormality, fetal infections. First trimester screening Preeti wanted to see, but this lady never had any test in the first trimester. So you can ask her history of fever or rash, any medication intake or hyperemesis, everything. You actually burst my bubble by saying that I mean, you wanted to check her dates, but the problem is she was very sure of her dates yesterday. Next day, she suddenly remembered that, oh, sorry, she got confused between June and July. And therefore, after you did all the hard work yesterday, she came back today and told that, you know, doctor, my mistake, I forgot my dates. And actually this is. So all the heartburn that you had that day was, I mean, unnecessary. But that's exactly the point, because dating, wrong dates is one of the commonest reasons of our growth disorders. The actual incidence of growth disorders will be lesser than what is diagnosed in our clinics, because dating is often missed for various reasons. Now, sir, one of the things, of course, is this patients forgetting their dates. But nowadays, I see a lot of IVF centers where there are scans done almost every week. And those are the places where the date of conception is also supposed to be very sure. But every time they have a scan, they have a different date given there. And we are stuck, sir, because we say that the early pregnancy scan is supposed to be the most accurate. But sometimes the fetus has not been taken in the longitudinal axis, and therefore it has been like malaligned during the assessment. So what is your take on dating, sir? Which scan should we follow for dating?
If you look at, I'm not talking of the ART group or the IVF group. If you look at the general crowd, I would scan done between 11 and 13 weeks and 6 days, a classical NT window. That is enough for me. I mean, I know dating is more accurate if you go a little earlier in terms of 8 weeks, 9 weeks, and 10 weeks. But that would mean 2 visits to the lady. So if she's done an 8-week, 9-week scan, I would look at that scan, number one. And the first thing I would ask is, so show me the pictures. Is it a vaginal scan? Is it a transabdominal scan? Look at the picture of the fetus, look at the cursors, and then give credence to the report. Otherwise, a second trimester, NT scan report, the 11 to 13 weeks, 6 days would be good enough for me. Good enough for me.
So another important thing I just want to discuss here is lots of obstetricians do early pregnancy scans for their patients, but they don't keep a picture. So the point that they have done a scan means they have done the scan. So PCPNDT is on any which way. So at least write down the CRL that has been mentioned, because very many times they just write SLF 6 weeks. And then you really don't know whether that date was given or not. So I think like all the people on the panel are like dedicated in imaging people, so they will be doing it. But all the people in the audience, at least if you are seeing your fetuses in the first early pregnancy, just note down the CRL on the date that you have seen that baby, because that really helps us a lot later on. Yeah. For everything in pregnancy, starting from first trimester screening, biochemistry, or allocating growth parameters, we need the dates to be accurate. To the extent that when you take the decision for delivery, you should not be off by a week or something, because that can be very disastrous for the baby's future.
As per ISOPARB criteria, they are mentioning that it should be in the first trimester scan, as Dr. Ramamurthy sir told, because in the early scan, we are measuring the neck rump length, because the baby is hyperflexed. We are not able to measure exactly the crown and rump. So we are measuring the neck rump length. In an ideal
world, we would want that. Yes. But suppose that's not there, and suppose we don't have the pictures, then at least the person who's done the first scan should mention, whenever a scan is done, the biometry should be mentioned with the date.
But as per dating, as per sir told, the first trimester 11 to 13 week scan is the best time.
So now after corrected dates also, suppose a woman has IUGR and it's like a late onset IUGR. We discussed early onset IUGR earlier. Now this is late onset IUGR, everything normal up to 34 weeks. And after 34 weeks, there are changes that are happening. Now, what is CPR? I'm directly cutting to the chase. What is CPR?
CPR is cerebroplacental ratio. That is.
You muted, Preeti.
Yeah. Umbilical RPR. And it should be always more than 1. If it is less than 1, it is indicative of hypoxia.
Now we know how to do umbilical artery. We understood everything about the cascade of umbilical artery Doppler going from high resistance to absent to reverse MCA. Why the ratio is so important? Why can't you just look at the two things? You all are very clever people. Why can't you just look at those two things together and understand? Why do you need another ratio? Again, another thing to measure.
Hello. Hello.
Yes.
Now, actually, umbilical artery shows the flow from the placenta to the fetus, and
fetus to placenta.
Sorry, fetus to placenta. But when there is hypoxia, the fetus, what is the capability of the fetus to adjust to that will be shown by the middle cerebral artery.
Correct.
So,
You are anyway doing umbilical artery separately and middle cerebral artery separately. Why do we need to do this ratio again?
Because the predictive value of the hypoxia is more when you consider the ratio. When you take
it predicts early.
It beats me.
It predicts early. It predicts early. Before the umbilical artery Doppler changes, so there is fetal hypoxia. Cerebroplacental ratio shows the brain is adjusting to the hypoxia by dilating. So it's in the early phase of hypoxia, and so that the flow is restricted to the lower part of the body.
No, we understood that. We understood that there is redistribution in the brain. My simple question is, why should CPR be more useful as opposed to the umbilical artery PI and MCA PI separately?
It takes two things, supply and the adjustment of fetus. So two points it takes together.
Okay, now in very simple terms, what I understand is that when there is a change, parallelly two things are changing. When the placental resistance is increasing, the umbilical artery Dopplers are getting worse. When the hypoxia is increasing, the middle cerebral artery is getting worse. So each parameter, say it changes 1 unit in one direction. When you use the ratio, you get both of them changing one unit in opposite direction. So you get double the change in the ratio. So a ratio by itself, even without any of its individual parameters going completely abnormal. Suppose the normal would be 50th centile for both, and the umbilical PI has now reached 80th centile, which is still within normal limits, and MCA has reached 10th centile, which is still within normal limits. The ratio might get abnormal even if both these parameters are normal. So it is a more sensitive indicator and a quicker indicator of things going wrong. Sir, will you like to explain this better? You will explain it.
Oh, you've done a wonderful job, Dr. Chinmayi, by taking the 80th centile and the 20th centile. You know, one is high normal, the other one is low normal. Umbilical artery, high normal, low normal. So if you were to look at these two indices in isolation with each other, you would call them normal. But if you do a CPR, the CPR would be definitely lower than normal. There's one thing I'd like to point out is that CPR also is chart driven, nomogram driven, and it goes with the gestational age, right? A single cutoff really doesn't help, and we have calculators online. You can go to the FMF calculator or the Barcelona group calculator, put the gestational age, UA, PI, MCA, PI, and you have the CPR calculated and also the Z scores, the centiles for the CPR given. So a CPR lesser than 5th centile for the gestational age is abnormal and is indicative of hypoxemia. And it's, as you very rightly pointed out, it can be abnormal even if individually umbilical artery and MCA PIs are normal.
Yes.
Yeah.
Thank you, sir. So this is what Dr. Shashmita was trying to tell us, that whenever there is a redistribution, the body tries to shunt in more blood towards the extremely critical organs like the brain, heart, and adrenal glands. And comparatively, the kidney, gut, and lower extremities receive less blood. And that is what is reflected when you look at these Doppler changes that happen. So if you see here, your CPR changes will happen earlier than the actual critical hypoxia sets in. So umbilical artery PI will change, middle cerebral artery PI will change, but even before that, you will see the change in the CPR. And therefore, in this cascade, using the CPR for late IOGR helps in picking up problems early, because all we are doing by this Doppler assessment is just, preponing our assessment of problems so that we can make an optimal arrangement for a timely delivery. So that is the brain sparing effect. Again, we had some very strict organizers who told us that these are the topics which have to be covered. So that is the brain sparing effect. And that
Can
is.
I add a point, Dr. Chinmayi?
Yes, sir.
An important point is that in late onset IUGR, you barely ever see an umbilical artery which is abnormal. Right? It's not a placental lesion, a vascular lesion which reflects in the umbilical artery PI. And therefore, CPR, especially for late onset IUGR, is a very sensitive marker, because umbilical artery tends to be normal throughout. And MCA change, although there is an MCA change comes later.
Yeah.
CPR change comes early. And especially for a late onset IUGR, we are very, very crucially dependent on CPR. I just wanted to make this point regarding late onset IUGR and CPR.
Yes, so these are some standard sentences about Dopplers. Dr. Jyotsna, will you just summarize it for us?
Umbilical artery Doppler is the only parameter for the diagnostic and prognostication, but umbilical artery is not the only thing which we should consider in the late onset IUGR, because umbilical artery depicts the flow which is before the placenta, and in the late onset IUGR, our problem is in the diffusion process, that is in the brain. So although there is good adequate amount of blood supply in the placenta, there may be change in CPR or middle cerebral artery redistribution due to fetal anorexia. That's why the ratio between the middle cerebral artery Doppler, which is always a high resistance flow, and the umbilical artery Doppler, which should be a low resistance flow, the ratio between two is considered as the golden standalone parameter to consider the late onset IUGR. And because we don't have enough time, and the baby is not have a chronic hypoxia like the early onset IUGR, everything starts very early, and the decision making should be also that early, because we don't have any time to wait. And other changes of other Doppler changes like ductus venous change and all these things in cascade doesn't happen in late onset IUGR. Also, we have to consider the biophysical parameter and the MCA CPR ratio and uterine artery Doppler, and accordingly we want to stage the
and when we are looking at Dopplers per se, the CPR definitely works better than MCA and umbilical artery put together. And the ductus venosus is the strongest single marker for short-term risk of fetal death, because ductus venosus is the inflow of oxygenated blood into the fetus. So when that becomes abnormal, the risk of fetal death is very high. Aortic isthmus is a Doppler, which we are just mentioning here. We haven't done cases like that in this discussion, but this is just to remind you that this is a Doppler which is done for triaging fetuses when we are trying to discriminate between survival and intact survival. So if survival is not a problem and aortic isthmus is still normal, you may still continue the pregnancy without risk of more neurological damage. But if aortic isthmus becomes abnormal and survival is not such a big challenge, it may be better to deliver the baby to prevent further neurological damage because of less oxygenation inside. That brings us to another.
Dr. Spanner predicts the acidosis. We should not wait up to the acidosis in this scenario. At least we should cut off between acidosis and hypoxia, so that any changes, at least aortic isthmus changes, we should be
that
alert.
Discussion we will have, Dr. Jyotsna, hopefully in another session with IUGR, because those are very important messages to go, and they should go in the full context. Dr. Suchita, you were saying something?
Ma'am, this is just a query regarding the ductus. Since ductus is a marker for early, it's an early marker for the venous changes. At the late onset IUGR, ma'am, we hardly find any ductus changes. So should we routinely
this
take
is not
ductus?
about late. That is just take-home messages for any kind of Doppler problems which have been given in that paper by Figueras, where they have mentioned about use of Doppler in fetal growth restriction. So whenever, even in late onset IUGR, by chance, if you have a ductus abnormality, then you know that things are really bad. The thing with late onset IUGR is it starts after 32 weeks. And by the time it's 37 weeks, there isn't enough time for problems to go to that extent. But the IUD case may still happen even if ductus abnormalities are not there, because the baby doesn't have that much of reserve to carry on any compromise that takes place at that point. So, but I presume that just prior to the fetal death, there would be a ductus venosus abnormality, because that is how it would, that final cascade of death would happen. But anyway, right now, the other thing that we had to cover here was nuchal cord around the fetal neck. How many of you report nuchal cord on your scan reports, fetal scan reports?
I report.
In every scan, first trimester,
Ma'am,
second
I
trimester.
report only, no ma'am, 38, 39 weeks, ma'am, I report.
I report after 37 weeks of pregnancy.
Okay, 37, 38, 39, always. And two more opinions?
I report it usually whenever there are 2 or 3 more loops. For a single loop, I never report it.
Sir, we want to listen from you.
You want me? I don't do cord around the neck, and I don't agree with people who do cord around the neck at any stage. I wouldn't do it. 20 to 30% of
Sir,
all.
I'm showing you a picture, so you see it's all around the neck.
Yeah, let it be. Let it be. Those colorful garlands shouldn't distract anybody. Now remember, we are talking of two things. We are talking of cord around the neck, looking for cord around the neck as a screening modality, which I know my colleagues are talking about. Also as an indicated. So what is indicated? What is screening? Screening is I do it for every third trimester case that I'm seeing. That is screening, which I don't agree with. Indicated, I agree with. Here is a lady who's had an NST done and she's got a cord compression pattern, a late deceleration pattern coming in, or a W or a shouldering or whatever you call it. Or if there's a history of loss of fetal movements. These are the two circumstances which will force me to look for cord around the neck. And what sin have the other fetal parts done? Why are you only looking at the neck? I would go ahead and look at around the limbs. There are times where I have picked up around the limb, around the lower limb, 2, 3 tight loops around the cord. So I do it as an indicated. I am not for a screening modality, cord around the neck, because cord around the neck does not mean cord compression. I hope all the panelists agree with me.
Yes.
Is cord around the neck equal to cord compression?
No.
So cord compression would manifest as other Doppler changes in that loop or around it.
Yes, or other NST changes as well. Okay, so cord around the neck, which is not compressed, your NST also won't pick it up because there's no cord compression. So since you're not able to diagnose cord compression, you're only able to diagnose the position of the cord. It is going to increase the amount of tension in this couple and the obstetrician. It has a big potential to push up C-section rates like mad.
Yes.
And I'm really not. And if you see literature, in one voice, they say that 20 to 30% cord around the neck is usual. You just slip the cord around and deliver. Or if it's not slippable, you cut, clamp, and then deliver. At the shoulder, where the head is out, the shoulders are being delivered, you cut, clamp, and deliver. That's
the basic training in obstetrics. All of us have gone through that, and I don't know why we continue to fret over it. Now, the thing is, it's not completely without reason to be anxious about this finding. But like Sir said, we have to have a threshold and we have to have a rational approach towards this. So when you say cord around neck, it has to be 360 degrees around the fetal neck. So while in first trimester, this was one odd occasion where I got this garland around, so I kept that video. But otherwise, it's not so easy to see it all around the neck, and we really don't know whether it is around or it is across or is it just lying near the neck there, and we don't know whether even multiple folds can be just there on one side and not across around the neck overall. So this is one interesting article I just read, and I thought, okay, I'll just put it there, that there is something called a tight cord around neck syndrome that they have explained there, because although about 10 to 30% incidence they have mentioned that people can have cord around neck, a few few of these babies may unfortunately suffer from the tight cord around the neck syndrome. And I mean, there could be signs of perinatal asphyxia, because it would be an antepartum asphyxia in these patients. This is known, this is documented, but it still does not give you enough numbers or enough justification to act on a scan report of cord around neck. It still does not give the sort of guideline that you must see cord around neck in the 3rd trimester scans. If you have noticed it, and it is multiple loops like Dr. Soumya was saying, then you know that there are multiple loops. It's a good idea to mention it if you want to, but do not fret over it. And your obstetrician should know that it's only an indication to monitor fetal heart and liver. That there are 2 things. There is one free sliding pattern of the fetal cord, and there is a tight locked pattern of the fetal cord. Now, again, I don't think this has gathered more interest than that, and we still don't have guidelines and patterns of this said properly. So I think that will be an individual discretion when you do the assessment. And multiple cord loops, if you can see like this, and sometimes we see this during delivery, these are all one chance findings. They're exciting. People put up these pictures immediately as they find it. When we see the true knots, all of us who've done obstetrics for a reasonable time know that we found true knots in normal deliveries. We found true knots in cesarean sections with live babies. Yes. And of course, when we find it in an IUD, we somehow put the entire reason of the IUD into this, whereas we have had IUDs without any knots and without any cord loops. So I mean, we really don't know whether this is significant or not. Therefore, the take-home message from this panel should be that cord around neck alone cannot be an indication for delivery. Ultrasound cannot detect around or across for single loops near the knee. Multiple loops, you have to be cautious. And if you see some Doppler changes right there, or like sir said, movement changes are there, fetal heart rate abnormalities are there. Till now in ultrasound, I have not seen heart rate abnormalities or Doppler changes due to this. Yes, once I think I got one true knot. I got excited, but then that was very early and the patient never bothered about it after that. And she never came back actually for the scan, but it was about 24 weeks and we had seen a true knot and we were doing that. So, sir, the final take home from you on this cord around neck. Should we report? Should we not report? If we report multiple, suppose we see multiple loops, what should we do?
Let me go to a question more basic than seeing. I want you to address the question of whether you're going to make an effort to see at all or not, because you in ultrasound, unless you make an effort, you're not going to do it. Is the effort going to be there in the protocol? Only if the effort is there that you're going to diagnose multiple. And for that, those few cases of multiple cord loops, and again, another thing is you cannot assess the tightness. You have a sign called the DeWatt sign, but you know in the 3rd trimester how hard it is with the fetal position, with the shadowing. To get a DeWatt sign is extremely, extremely hard. So the first and the more basic question is, are we going to look for cord loops at all? Only if you look at it, you will have to report 3 loops or 2 loops or 1 loop. And you will say that I will not report 1 loop, but if it's multiple, I am hitting at a more basic level. I don't look for cord around the neck at all. You might say, we don't fret. You might say, tell your referring obstetrician not to fret. But what about the patient? They will forget 1,001 things which are normal, and they'll just hold on to this cord around the neck and keep on worry, right? The tough situation I face in practice is where a couple comes to me with previous history of a fetal loss due to cord around the neck, purportedly due to, I'm not sure, yeah, purportedly due to cord around the neck. And that becomes hard because they are going to force you, sir, tell me. So it's easy in the 2nd trimester to push them away. You can always say cord around the neck, it keeps on changing. What is in the 2nd trimester doesn't come in the 3rd trimester. But in the 3rd trimester, if they corner you, I don't know it. For the patient's sake, you might want to look at it, but those are one-off conditions, very special circumstance conditions. Out of run-of-the-mill case, I would not put in that extra effort to look at cord around the neck, both by grayscale as well as by color Doppler. I wouldn't do it. Only if I do it, I'll have the idea of reporting or not. So I don't do it.
I think thank you very much, sir, because coming from you, it makes a lot of sense because you've been doing this for years together. And now if you tell us that really it has not made any hindrance in your reporting, I don't think it will make for the others because it is really becoming a noose around everyone else's neck. Because if you report it, the cord around the neck, like sir said, the anxiety in the parents is so high. And whatever the outcome, all the IUDs where we have mentioned cord around neck, need not be when there is an unexplained IUD in the third trimester. And now we know late onset IUGRs undetected are an important reason for that. So when we do not know what reason to allocate and we are finding a cord around neck, it is very easy to say that at that point.
That's correct.
And therefore that importance also we are not sure. So better not to report. If all of us don't report, obstetricians will also lose interest in it.
No, another point. I have obstetricians who have asked for cord around the neck. Who specially asked for cord around the neck. How do you handle that? I handle it like this. I always tell my patients that cord around the neck doesn't mean compression. It means that it's positioned over there. It could be comfortably sitting over there. So what I say in my report is cord compression cannot be detected by ultrasound. Please do an NST if you wish to look for cord compression, whether intrapartal or whether during the course of the pregnancy. If you find a cord factor, please come back to me. I will make that extra effort to tell you where the cord is going.
Absolutely.
That is how I deal with cases who come to me with cord around the neck request. And at the counter itself, they are explained. If you want to do the rest of the scan, you get in. If it's only for this, you please go back with this statement and I give them the statement.
Yes, sir. Because I think that's something which we all should stick to because otherwise it leads to a lot of harm. And that's the first principle that we have to follow is that do no harm, isn't it?
True.
So we are, I think, transgressing our time. So quickly about biophysical profile, because that's another thing that we had to do. So Preeti, are you going to just take this quickly, take us through biophysical profile? Why do we do biophysical profile? What is biophysical profile?
The biophysical profile we are doing to see the baby is hypoxic or not. Usually this procedure is now obsolete because it is been replaced by Doppler, which can be easily done. And in biophysical profile, we used to see the fetal breathing movement, fetal tone, amniotic fluid index, and the fetal heart rate. Fetal heart rate can be replaced by a non-stress test also.
So does it still have some value in some cases?
Yeah, definitely in some cases, because
suppose you're following up a woman with pregnancy-induced hypertension or gestational diabetes and you just want to be sure that the baby is doing well, then I mean, doing a biophysical profile and getting a normal biophysical profile has some predictive value towards the well-being of the baby for some time. If the biophysical profile is abnormal, it does not always mean the baby is hypoxic. But if it is normal, you at least know it is not hypoxic. So it has got a good negative predictive value in that way. So we do use it sometimes. And the Cochrane still says that there isn't enough evidence about using it in all kinds of high-risk pregnancies, but in pregnancies with diabetes, they still have made an allocation, and biophysical profile continues to be a method of fetal surveillance in those cases. So again, do we deliver or do we wait based on biophysical profile? That is not the single entity on which a decision for delivery is taken. So we always balance the odds and look at, I mean, all the factors before we take a decision for delivery. Sir, would you like to add something in biophysical profile?
Well, as Dr. Preeti rightly put, the weightage on Doppler has become much more than biophysical profile. But always remember that NST and Leica volume are parts of are two essential parts of biophysical profile. NST represents an acute marker, whereas oligohydramnios or Leica volume represents a chronic marker. In fact, you had the concept of a modified biophysical score.
Modified biophysical.
Yes, only bundled up the NST and Leica to the exclusion of the fetal breathing and the movements, right? So that would make life a lot simpler. Now, tell me which one of us would sit staring for breathing movements for half an hour?
30 minutes.
30 minutes, half an hour, and an extended BPP is for 40 minutes before you actually say that the breathing movements is zero, right? Which of us have the time, the resources? I think this modified BPP is a brilliant idea. And to that extent, yes, we always look at the Leica volume as part of our scans anyway, by default. And I always ask my obstetrician, if I'm asking for a Doppler, re-Doppler after 1 week, looking at the staging of the IUGR, I've asked for a re-Doppler after 1 week. I always request my obstetrician to do an NST midway.
Midway,
Don't
yes.
do it on the day. Don't do it on the day of the Doppler.
Correct.
You stagger your NST in between, and if you get a good, nice NST, that gives you extra, courage and confidence that you're on the right track in asking this patient to wait. So I always stagger NST and Doppler in where I have to do a serial Doppler, provided this baby is past 33, 34 weeks, past 32 weeks at least. Because before 32 weeks, we know that the false positive rate of NST is extremely high, and no, it doesn't really take. Computerized CTG is another ballgame. I'm talking of the conventional CTG. Conventional CTG before 32 weeks is full of false positives. So if it's crossed 32 weeks, I always do this staggering act and get the best of both worlds. That's how I
think so. That's an excellent suggestion, because that staggering it with the CTG in between definitely helps in continuing that, and the patient also keeps on, like, she's being followed up. Most of these have some or the other morbidity, either pregnancy-induced hypertension or diabetes, and for that also they need midway checks. So that is very useful. Do we have time to go on to other images? If nobody's stopping us, then somebody quickly read these images and then we move on. Because
Ma'am, we have 5 more minutes.
Okay, so 5 minutes. So quickly, Dr. Shashmita, do you want to read these images and tell me what do you want to do after that?
The renal pelvis in the left picture is appearing little prominent. So measurement is not taken, and it is not the proper section. It's not the proper section.
So the point is, if we have hydronephrosis, do we classify hydronephrosis? How do we classify hydronephrosis?
So it should be seen in the proper axial section, where the anteroposterior diameter of the renal pelvis should be measured. In third trimester, if it is more than 7 millimeter only, we can stamp it as there is some amount of renal pelvis dilatation is there. And then if moderate dilatation is there, if the pelvis along with calyces are dilated and they are connected to each other, then only two cystic structures are connected to each other. And significant dilatation when there is dilatation, but the renal parenchyma is normal.
So there are many classifications now that we know of. So which classification should we be following? Sir, I think you close it for us, sir. Which classification should we be following?
Now, if you go back, you had flashed Nguyen. That's the A1, A2, P1. That stuff. No, after this, I think I saw it went past.
No, sir, I think that I put the P1 here. I think the A1 is later on.
Yes.
Okay.
Next one, it is the
No, I have missed that slide. There's a blank slide there in between.
This one. UTD-A1 is
UTD. You've got it in one of your charts. UTD classification, P1, P2. The same thing is A1 and A2 for the antenatal.
Antenatal is A1, A2, and P1, P2 is the postnatal. The antenatal one, I missed that picture, sir.
Yeah, you missed that picture. Maybe that would give us a good standardization. The carry home with that is that if you want to call it obstructive in the second trimester, your cutoff is 7 millimeters. You should at least reach AP diameter of 7 millimeters.
7 millimeters.
In the third trimester, it goes up to 10 millimeters. Now, for me, 7 and 10 are just measurements. For me, the calicial status is extremely, extremely important. Your picture shows very well the central and peripheral calyces. Yeah, the central is a milder form of dilatation. Peripheral is a severe form of dilatation. Any form of calyceal dilatation clinches hydronephrosis. When you say hydronephrosis, it's obstructive. It's not non-obstructive. Like hydrocephalus is obstructive. Hydroureter obstructive. Whereas hydronephrosis also obstructive. So presence of calyceal dilatation for me is extremely critical. And as these diagrams very nicely show us, you look for calyceal dilatation in a coronal section, not in an axial section, not in a sagittal section, but in a coronal section, you can bring out these pictures very, very well. And presence of calyceal section dilatation, sure short sign of hydronephrosis or obstruction. Right.
What that picture which I missed here, this is P1, P2 because it's postnatal.
Postnatal.
Same thing we have in antenatal, it's only A1 and
A1, A2.
And if that is only central dilatation, then that is A1. And when there is peripheral, then it becomes A2, which is...
No. A1 is non-obstructive, A2 is obstructive. That's how it goes.
Get the peripheral dilatation.
Yeah, in both central and peripheral is severities, the degrees of severity in obstructive, whereas A1 is non-obstructive signs. So you have lesser than 7, lesser than 10 coming into A1, whereas more than 7, more than 10 go into A2. So that's how they've classified it.
Yes. So this is the more accepted classification now, which is that multidisciplinary team.
Urinary tract dilatation, UTD. Yeah.
So again, in a case of hydronephrosis, do we make a decision for delivery based on images?
No.
Like we now have the classification, we now have the measurements. So is that enough for us to decide when we would deliver? So when would you deliver, Dr. Jyotsna?
According to the UTD classification, even A2 to 3 is of higher risk. That is risk for the renal system and the baby. And your decision doesn't depend on the classification of the renal system. And decision is totally an obstetric management, obstetric decision. Because
you want the baby to achieve as much maturity as possible, because the treatment has to happen postnatally, and therefore it is better to deliver a mature baby than a premature baby.
Yes.
So even if there is some degree of hydronephrosis going to worsen in utero, it's okay to continue and achieve full-term maturity.
Yes.
So the decision is not image-based, but a clinical situation-based. So, Dr. Soumya, do you want to quickly read this image?
So this is the image of thorax, fetal thorax in sagittal axial views.
Sorry, ma'am, but we are running short of time. Kindly, if we can conclude the session.
Sure. So the diagnosis here is a mixed variety of CPAM. And again, the treatment is postnatal, and we continue vis-a-vis. This is diaphragmatic hernia. Again, another thoracic lesion, and all of us know that we do the assessment based on that imaging and the measurement of the lung head ratio. So we measure the lung head ratio and finally do what is called the observed upon expected lung head ratio and find out the this thing. So we do all these imaging in all these cases, but what do you think determines the decision to plan antenatal care and delivery? I think all of us has made it pretty clear that it's not just the imaging alone, but the overall clinical picture, the socio-financial issues of the patients, and the personal wishes. So while hydronephrosis, CPAM, CDH, all of them are correctable abnormalities, we have faced multiple situations where parents have either decided to continue, to our surprise, even with poor prognosis, sometimes to discontinue even with a good prognosis, because there are multiple factors that finally decide the decision for delivery. Now, while we get very carried away with imaging, one of the important things we have to remember is that
Really
images can be confusing.
Really good.
Don't always rely
Really
on images, because imaging is only one part of it, but your mind will only read what your your eyes will only read what your
See
mind
what
knows.
mind knows.
So you have to be in the right frame of mind, because in this image I can leave it for you to keep on imagining what all is there in this
Very
image. But that's how it is. So take your image correctly, interpret the images correctly, understand fetal physiology correctly, and keep up to date with the recent guidelines, because an image can change your decision, and that decision will determine the life of an individual who's going to be a citizen of tomorrow. So the first principle of medicine has always been do no harm. So let us try and concise our knowledge to an extent that we do no harm. So thank you very much. Thank you, sir, for all your inputs.
Thank you.
Thank you, Chinmay, for a
Thank you,
wonderful.
Dr. Chinmayi. Wonderful
Thank you.
cases. You took the discussion in a very meaningful manner.
Thank
And
you,
it's
sir.
nice to see Dr. Preeti and Dr. Jyotsna and my new friends, the other
Namaste.
doctors. Thank you all for a very, very brilliant participation.
Thank you,
sir.
Thanks a lot, sir.
Madam.
It's a privilege,
Madam.
sir, to be with you and ma'am. It's really a big privilege.
Thank you. Thank you. Thank you.
I would like to
Bye-bye.
thank all the panelists. Thank you so much for your time, and all the our vibrant coordinators. Thank you so much for taking your time and moderating this session so well. Now we'd like to conclude today's program with the concluding session by our beloved Dean Sir of IMS and Some Hospital. Sir, kindly take over the session and conclude the session for today.
Namaskar.
Namaskar, sir.
I am Dr. Gangadhar Sahu.
Yes,
I am here not as the dean, but as a gynecologist. And I am an ISOPARBian. I was the past vice president of ISOPARB. I am a grassroots worker of the ISOPARB also. So anyway, to conclude this session, only 2 sentences I will tell. From morning till now, say it is now 5:30. It is totally a beautiful and amazing and observing session. So I have heard Madam Chinmayi from the first trimester sonography till now to the closure. So I am very much impressed with Madam, with you. So this session of panel discussion was fantastic. Almost bit by bit, I was just telling my postgraduates that it is a full class for you now. So thank you, Madam, for this session. And I thank all the participants and all the faculties.
Thank you so much, sir.
Thank you,
So
sir.
for participating
Thank you, sir.
here.
Thank you.
Sasmita is here. So Sasmita, Dr. Suchita, Ramurthy sir. So my namaskar to all of you once again. And my vibrant team led by Tapan Patnaik who has made this possible. So I am also thankful to all those members of the team and all the members of ISOPARB. So once again, with the blessings of Lord Jagannath to all of you, I conclude this session. Thank you very much.
Thank you, sir.
Thank you very much, sir.
It is
Thank
very much
you.
informative and also educative. Thank you.
Thank you. Thank you so
Thank you,
much.
Thank you so much.
Thank you, madam.
Chinmay, it was really nice.
Thank
It
you.
was very good.
Really nice.
Really, it was very nice.
All of you made it nice.
No. You always does. You always do
Ma'am,
that.
your every talk is very interesting. Or every talk.
Thank you very much
Okay.
for all the
Thank
attendance
you.
of today, and thank you, sir, for concluding the session. And tomorrow we will be starting the program by 8 o'clock in the morning. We'll wish to join you again tomorrow morning.
Okay,
Thank you.
Thank you.
Thank you all.
Chalo, bye bye. See you soon.
Thank
Bye.
you, ma'am. Thank you.
Preeti, get well soon. Keep smiling.